डॉक्टर संजय। डॉक्टर संजय। डॉक्टर संजय।
Hello.
Good morning, sir.
Good morning.
Dr. Naibu has just joined and he'll start.
Good morning. This is the final day of the Fhno 2021. We will start off with the panel on the nasopharynx panel. I invite Professor Ravi Kannan to moderate the session. Can you put on?
Thank you. Thank
Yes, sir.
you very much. So let's start. We have a unusual, uncommon cancer with a lot of exciting things happening there. So let's start with the first talk of the session, Dr. Sanjay Vaidyanathan from the Royal Wolverhampton Hospitals, NHS, UK. Dr. Vaidyanathan, over to you. Hello?
Yes, sir. Yes, sir.
Is Dr. Vaidyanathan there?
Yeah, he's here. He's listening.
Can you just ask him to share the screen?
I've asked, sir.
Dr. Sanjay, can you hear?
Dr. Sanjay. Dr. Sanjay, are you able to listen us?
So if there's a problem, let's go on to the next speaker. We can come back to Dr. Sanjay in the meantime.
Okay, sir. Okay.
So let's invite Dr. Biswas, who will talk of re-radiation for nasopharyngeal cancer. Dr. Biswas is an additional professor, Department of Radiation Oncology at the All India Institute of Medical Sciences. And he's been awarded the fellowship of the Royal College of Radiology in 2000.
Gurmeet?
Yes, sir. Yes, sir.
Is Dr. Biswas there?
Yeah, he's here.
Dr. Biswas, can you hear? Can you hear me?
Yeah, I just joined right now.
Okay, fine.
So just give me a minute. Yes.
Yeah, sure.
So good morning, ladies and gentlemen. I would like to thank the organizers for the kind invitation. So I'm trying to share my screen. So am I audible and are my slides visible?
Visible and audible, sir. Visible
Okay.
and audible.
So thank you very much. So this is a little bit in advance. The topic assigned to me is re-radiation in nasopharyngeal cancer, the evolving concept. So, so worldwide, the 5-year overall survival outcome in patients with nasopharyngeal cancer is to the tune of 50 to 60%. However, these results might be better in centers of excellence in Hong Kong, Singapore, and southern China. And the patterns of failure are predominantly distant metastasis. Also, there might be local failures, regional failures, and local regional failures. So upon diagnosis of local or local regional recurrence, thorough assessment of the physical condition and restaging with a contrast-enhanced CT scan and MRI of the head and neck region and metastatic workup with the whole body PET CT scan are needed. The role of plasma EBV DNA for detection of local recurrence in such scenario is not very clear because hardly 50% of cases have detectable levels. The time to recurrence, the details of previous treatment, both radiation therapy and chemotherapy, should be carefully reviewed. And it is very important to retrieve the original RT plans to assess whether the recurrence is in-field, marginal, or out of field. And early in-field recurrence portends radioresistance. Furthermore, it's important to know the doses are delivered to the various dose-limiting organs at risk and the consequent late effects incurred in the primary course of radiation therapy. So all patients with local recurrence ideally should be managed by a multidisciplinary head and neck cancer team. And it is of paramount importance to note the patient's age, the performance status, the comorbidities, the patient preference, and to have a balanced talk with the patient and the caregivers pertaining to the risk-benefit trade-offs. So this is just to give a glimpse of data from our part of the world. This is a retrospective analysis of 33 pediatric and adolescent patients treated at AIIMS New Delhi from 2014 to 18. More than 90% had undifferentiated nasopharyngeal carcinoma, 85% of the tumors stained positive for EBV LMP1. The treatment approach was induction chemotherapy followed by concurrent chemoradiotherapy. And majority of the patients were treated by IMRT or VMAT techniques. The median RT dose was 65 grays, 60 grays, 54 grays in 30 fractions over 6 weeks by SIP technique. And concurrent chemotherapy was given in 32 patients. So after a mean follow-up of around 21 months, 12 patients experienced recurrence or progression. And the most common pattern of failure was distant metastasis. All these 12 patients had distant metastasis in the bones. The other patterns of distant failures were in the lungs, distant lymph nodes, and liver. And local regional failure was discerned in only one patient in the periparotid region. The 2-year actuarial rates of overall survival and progression-free survival were 71.8% and 54.1%. So the point to note is that distant metastasis is a predominant pattern of failure in our part of the world. And fortunately or unfortunately, we have limited experience in the treatment of local or local regional failure in such patients. So coming to the role of surgery with or without radiation therapy, the surgical resection is the preferred option for local recurrence, provided that expertise is available and clear margin is likely to be achievable to avoid the added morbidities associated with the second course of radiation therapy. So for patients who are salvaged by surgery, re-radiation should be considered for positive resection margin or closed resection margin. What is the evidence behind the use of surgery? This is a landmark trial published in the Lancet Oncology in 2021. 200 eligible patients were randomized to receive either endoscopic nasopharyngectomy or IMRT in a multi-center phase 3 randomized controlled trial conducted in southern China between 2011 to 17. After a median follow-up of 56 months, 74 patients had died, 29 in the surgery arms and 45 in the IMRT arm. The 3-year overall survival were respectively 85% in the surgery arm versus 68% in the IMRT group, with the hazard ratio being 0.47 and the p-value being statistically significant. The most common severe toxicities, late toxicities were pharyngeal mucositis, 5% versus 26% in the surgery versus IMRT groups, and death due to late RT toxicities were 5% versus 20% in the surgery versus IMRT groups. So to conclude, endoscopic surgery could be considered as the standard treatment option for this patient population, although long-term follow-up is still required. So what are the contraindications to re-irradiation in patients with locally recurrent nasopharyngeal carcinoma? The time to recurrence less than 12 months, residual brainstem, spinal cord, or optic chiasma toxicities more than equal to grade 1, residual temporal lobe, optic nerve, brachial plexus, soft tissue, or bone toxicities more than equal to grade 3. What is the implication of tumor volume in such scenarios? Studies by Tia and Associates and Han Associates have shown that the recurrent tumor volumes of more than 30 and 38 cc as negative prognostic factors. The Hong Kong nasopharyngeal cancer study group demonstrated local control rate less than 10% if the recurrent GTV volume was more than 80 cc. However, as per the consensus guidelines, bulky recurrent tumor is not an absolute contraindication for re-radiation. For re-radiation, the recurrent GTV needs to be carefully controlled on the contrast-enhanced planning CT scan, which should be co-registered with the MRI and the FDG PET CT scan. The CTV is the recurrent GTV with a 5 mm anatomically constrained expansion, and the PTV is the CTV with a 2 to 3 mm isotropic expansion, and there is no role of elective nodal radiation in such patients. The salvage rate is dose dependent at AIMS New Delhi, where we have more experience for re-radiation in other sites of head and neck cancer. We have gradually moved from 45 to 50.4 to 54 grays in the last 15 years, and now we are offering 60 grays in carefully selected patients for re-radiation. In nasopharyngeal cancer, the outcome is significantly inferior if the total re-radiation dose is less than 60 gray. On the contrary, several studies have demonstrated that dose more than 68 gray is also detrimental due to excessive fatal toxicities. In the phase 2 RCT of 117 patients by TN and Associates, the 5-year overall survival was 30% versus 44% in the group treated with 68 grays in 34 fractions versus 60 grays in 27 fractions. Similar results may be noted in a meta-analysis of more than 1,700 patients with NPC. Hence, the therapeutic window is quite narrow in patients with local or loco-regionally recurrent nasopharyngeal cancer, and the intended total dose in the second course of IMRT should be in between 60 to 66 grays. Small retrospective study on 20 patients reported by Lee and Associates showed that hyperfractionation with dose escalation to 64.8 grays using 1.2 gray per fraction delivered twice daily achieved similar overall survival with a substantial decrease in hemorrhage compared with 60 grays in 30 fractions. Similar results have been seen in studies by Karam and Associates from North America. So though hyperfractionation is the ideal fractionation and should be given twice daily with 6-hour interfraction interval, conventional fractionation may be the more pragmatic option in majority of the centers worldwide due to logistics. So this is the tabular representation of dose prioritization and acceptance criteria for re-radiation by IMRT or VMAT in nasopharyngeal cancer. So the brainstem, spinal cord, and optic chiasma and the recurrent GTV should be layered in tier 1 as per priority. The optic nerves, the temporal lobes, and the PTV should be layered in tier 2, and the carotid artery should be layered in tier 3. So this is the preferred tolerance for these various critical organs at risk during the primary course of radiation therapy. And assuming a 30% recovery from radiation toxicities at 1 year, the preferred cumulative dose for this OARs is kept at 130% of the tolerance. And assuming a 50% recovery from radiation toxicities at 1 year, the acceptable cumulative dose of this OARs is kept at 150% of the tolerance. So moving to the physical characteristics of protons and heavy ions, this is the percentage depth dose curves of X-rays. This is skin sparing effect, Dmax, and then a gradual or gentle fall off thereafter. In contradistinction, protons or carbon ions have relatively less entry dose, and most of the dose is deposited at the very end of the path with practically no exit dose. However, we can appreciate a small tail in carbon ion due to the formation of heavy nuclear fragments. This pristine Bragg peak is spread out to form the spread out Bragg peak, which encompasses the tumor, and we can appreciate a decrease in the entrance dose and a marked decrease in the exit dose in protons or heavy ions in comparison to photon IMRT. So the development and increasing availability of protons and heavy ions can potentially lead to further improvement in dose conformity. So these modalities with higher LET and RBE can potentially circumvent radioresistance due to tumor hypoxia. However, it should be cautioned that enhanced biological effect can also lead to increased collateral dose to normal tissues. So it's important to avoid critical structures at the very end of a particle range, because dosimetric uncertainties about particle ranges and the biological effects at the end of the particle tract still linger. So this is the largest experience of 206 patients of locoregionally recurrent nasopharyngeal cancer treated with carbon ion radiotherapy to a dose of 50 to 69 gray equivalent at the rate of 2 to 3 gray equivalent per fraction at the Shanghai Proton and Heavy Ion Center. This was published in Cancer in 2020. The median follow-up was 22.8 months. The 2-year overall survival and local control were in excess of 80% and just short of 60% respectively. On multivariate analysis, older age was predictive of Watt's overall survival, whereas larger tumor volume and lower BET were associated with inferior local control. Interestingly, no severe acute toxicity was noted in this study, and the severe grade 3, grade 4 late toxicities were temporal lobe necrosis in less than 1% of patients and mucosal necrosis in 16% of the patients. So the salvage treatment with carbon ion radiotherapy is efficacious for patients with locoregionally recurrent nasopharyngeal cancer with acceptable toxicity profile and may be potentially superior to photon-based IMRT. So this is the recurrence in the left cavernous sinus in the pterygomaxillary fissure, and this is the PTV for the recurrent GTV. And we can appreciate the high dose and the intermediate dose isodose curves tightly sculpted around the target volume in the axial, coronal, and sagittal sections. Coming to stereotactic radiosurgery or radiotherapy, so this with its characteristic dose conformity and precision setup is a potentially advantageous modality. And effective tumor control for low volume recurrences has been reported, but such patients are also amenable to endoscopic nasopharyngectomy in selected situations. There may be serious toxicities, including damage to the central nervous system, fatal carotid blowout, or massive hemorrhage from mucosal or tissue necrosis, perhaps due to high dose per fraction in such treatment modalities. So caution needs to be exercised against using this mode for recurrent tumor close to neural tissues or the carotid vessel. Further studies are needed to explore the optimal time dose fractionation schedule and combination with immunotherapy. So this is one of the largest papers of 125 loco-regionally recurrent nasopharyngeal cancer patients who received salvage stereotactic radiosurgery versus fractionated stereotactic radiosurgery. So 86 patients were explored in a matched pair design. The median dose was 12.5 grays in single fraction SRS and 34 grays in 2 to 6 fractions by stereotactic radiosurgery using multiple fractions. We can appreciate there was a significant increase in local control with fractionated stereotactic surgery. However, there was no significant difference in overall survival. The severe late effects, brain necrosis and hemorrhage were all numerically lower in the fractionated stereotactic radiosurgery arm. So this is the recurrent tumor volume in the right side of the nasopharynx, and this is the 80% isodose line where the dose has been prescribed in the single fraction stereotactic radiosurgery. And this is again a recurrent tumor volume in the right side of the nasopharynx. And this is the 80% isodose line where the dose has been prescribed in fractionated stereotactic radiosurgery. So to conclude, fractionated stereotactic radiosurgery was superior to stereotactic radiosurgery using single fraction in salvaging local failures of nasopharyngeal cancer, especially in R-T2 to T4 disease. There is also a potential role of brachytherapy, which I will skip in the interest of time. And so re-radiation has to be carefully integrated with systemic therapy, and systemic therapy should be integrated with the second course of radiation for T3 to T4 tumors and N+ tumors. It may also be carefully considered in T1 to T2 N0 tumors, and the induction concurrent chemotherapy program is the preferred sequence. And the perceived benefits of induction chemotherapy include it allows more time for recovery, especially if the recurrence-free survival is less. If the time to recurrence is less than 12 months, it is also useful in downsizing the recurrent tumor bulk and facilitates better sparing of adjacent critical organs at risk. So the most common regimens include cisplatin plus gemcitabine or taxane or 5-FU in the induction backbone. If cisplatin is contraindicated or the platinum-free interval is less than 6 months, agents with non-overlapping toxicities or anti-tumor activity should be considered. Thus far, the data on the use of targeted therapy, including cetuximab, has been disappointing. However, there is emerging interest in the use of immunotherapy based on encouraging data in the palliative setting for recurrent metastatic nasopharyngeal cancer. The potential role of combining immunotherapy with optimal local salvage treatment warrants further exploration. So I will skip this in the interest of time, and these are the seminal papers on immunotherapy in recurrent metastatic nasopharyngeal cancer. So to conclude, re-radiation for locally recurrent nasopharyngeal cancer is challenging because prior radiation delivered in the first course is often close to the tolerance limit of surrounding normal structures. And a delicate balance needs to be struck between achieving local salvage and minimizing treatment-related toxicities. Surgical resection is preferred for resectable recurrence if expertise is available and clear margins are likely to be achievable. For patients treated with re-radiation, the most conformal technique should be used. IMRT VMAT is most often used, although protons or heavy ion therapies, if available, may be beneficial. This is suggested reading for the residents. And with this, I'd like to put a full stop and thank you very much for your kind attention.
Thank you. Are there questions? So, that was a very comprehensive overview of re-radiation. So I just thought, we don't see so many nasopharyngeal cancers in the country except for some parts of the northeast. We don't really see so many nasopharyngeal cancers across the country. So does it make sense as a policy, as a cancer policy, to sort of fix 3-4 centers that will treat all the nasopharyngeal cancers in the country?
I think it's an interesting concept. This is often being tried in various countries in the West, like UK, to pool the rare cancers so that we can have excellent data. However, I think there are logistic difficulties in doing the same in our country, but I think pooling of data in large centers, for example, AIMS, PGI, TMH, maybe some centers in the South, and looking at it in a critical fashion would be interesting.
Okay, thank you. Thank you very much.
Okay, thank you.
Oh, there's a question from Mudit. How do you follow up these patients to find early recurrences?
So we see these patients for the first 3 months, for every 3 months for the first 2 years, and then every 6 months from 3rd to 5th year, and annually once thereafter. We get 0-degree endoscopy done at every follow-up visit, and we also do CT scan at 3 and 12 months after completion of the primary treatment. Then we perform imaging only on suspicion of disease recurrence. But again, to reiterate that local recurrences are exceptionally rare in our part of the world, and the predominant pattern of failure is distant metastasis. So we have to be very careful, and we should always inquire about bone pain and bone tenderness on follow-up visits, because that is the predominant pattern of failure in our part of the world.
There's a comment from Dr. Kudus Ahmed. He works in Guwahati. His comment is pooling of data from northeastern cancer centers may be useful in the regard of NPCs. There's another comment from Mudit. Most important is nasopharyngoscopy to pick up early recurrences.
So I agree with both the comments. I think since nasopharyngeal cancer is very common in the northeastern part of our country, we should look at pooling the data at least from that part of our country.
More than pooling of data, I was thinking of building expertise in one area. And what you say is also true. There are logistic issues. Some of them are insurmountable. Patients won't be able to go to a central center, even if we do fix up something. But we have to look at it. And thank you very much. Thank you, Dr. Bishwa. That was very, very interesting. Unfortunately, Dr. Sanjay will not be able to make his presentation because he has a technical glitch with his PowerPoint. He's neither able to email it to us nor is he able to open it on the Zoom platform. And so I guess we will have to go on with the next speaker for today, Dr. Rayappa, who's a head neck surgeon working in Chennai and a long-time friend of mine. He will speak on the role of salvage surgery in nasopharyngeal cancer. Dr. Rayappa.
Thanks, Dr. Ravikant, for your kind words. And I'm really I'm glad I'm given this opportunity to talk about the role of salvage surgery in the nasopharyngeal cancer. As far as nasopharyngeal carcinoma, the primary treatment is chemoradiation. And the 5-year local control rate is good, especially in T1 and T2 lesions. And it's almost only about less than 10 to 20% of the T1 and T2 tumors fail at the primary site. And as far as the salvage surgery for recurrent or residual tumor, the well-accepted treatment for a long time has been the neck dissection for metastatic cervical nodes. Whenever the tumor fails at the primary site, always been considered for re-irradiation, even though it's known to have lots of limiting factors and that cause lots of complications. That's because the salvage is being considered for a long time as not possible because the nasopharynx was considered an unresectable structure. That's because of the central location of the nasopharynx, because it's surrounded by various bony structures, uninvolved bony structures like the cranial base superiorly, laterally by the ramus of the mandible, and anteriorly by the maxilla, and posteriorly by the vertebral column. And the access to the nasopharynx has been pioneered by various surgeons in the last 2 to 3 decades. And the first one was by Fhno in 1983. He devised the transtemporal approach, which is a lateral approach. And later by William Way and Ivo Janak, almost the same time, they described the maxillary swing as well as the facial translocation approach. And later, Randall Morton from New Zealand, he described the transmandibular approach. And Paul Donald finally described the transfacial subcranial approach. And so the 5-year survival rate for re-irradiation was approximately about 30%. And with the salvage surgery, the 5-year survival is almost double. So definitely that has proven the role of salvage surgery. And there are a number of approaches people have described, but none of the approach is perfect for every tumor. So the approach depends upon whether the tumor is limited to the nasopharynx or gone to the infratemporal fossa or the intracranial extension or involvement of the internal carotid artery. So the open approach is broadly classified as an anterior and lateral approach. And as far as the anterior approach, the transpalatal approach was described by splitting the soft palate and midline for small, tiny, centrally located tumors, and it has been almost completely replaced by the endoscopic approach now. And transcervicomandibular palatal approach described by Randall Morton, by dividing the mandibulotomy and also extending the incision along the soft palate, push away the lateral wall of the oropharynx and the soft palates to expose the nasopharynx. And this is excellent exposure. It gives an excellent exposure for the inferior part of the nasopharynx, but the access to the superior access is very poor. But also it results in trismus. Then the facial translocation approach described by Janak and also by William Way. In this one, the facial bone, which is not involved by the tumor, is translocated along as an osteoplastic flap, remove the tumor, oblong removal of the tumor, and then reposition it. So that's the It gives a good exposure for the nasopharynx as well as the infratemporal fossa. So this can be classified as a maxillary swing or include the external nose as well in the swing. And at the same time, you can do lower temporal craniectomy for addressing the intracranial extension. And this is just a case example to show the tumor in the nasopharynx extending into the infratemporal fossa. The arrow is pointing at the carotid artery. There is a small fat plane around the carotid artery showing the carotid artery is not, parapharyngeal carotid artery is not involved. This is removed by the nasofacial, the maxillary translocation. This is about almost, now it's about 14 years now post-surgery. He's doing exceptionally well, and 16 years now. And the morbidity is much less, the cosmetically quite acceptable approach. And so once the tumor extends laterally towards the ramus of the mandible and also towards the parapharyngeal carotid artery, the facial translocation will not give good access for oblique resection. So you need what's called this extended subcranial approach. This is described by the Paul Donald. And in this one, we do the oblique resection of the entire content of the infratemporal fossa, skull base, and also the internal carotid artery. This is a 34-year-old female with recurrent nasopharyngeal carcinoma. It's involving the horizontal petrous carotid artery here. For comparison, the opposite side, normal one. And the foramen ovale is widened. This is a tumor in the nasopharynx, the infratemporal fossa. The dura, the middle fossa, the dura is infiltrated there. The incision as marked here expose the mid and the lower facial skeleton. You do the osteotomy at the angle of the mandible, and the posterior half of the maxilla is also removed along with the tumor in this way. This is after complete resection. This is the internal carotid artery that was resected just before it enters the cavernous sinus. And the dura, middle fossa, the dura is also excised after taking this picture. And the defect was reconstructed using the rectus abdominis microvascular flap. And I talked about the anterior approaches. Let's talk about the lateral approaches. The Hugo Fish described 3 different types of approach. Type A and B are mainly for removing the glomus jugulare tumors involving the internal carotid artery. Type C is for the nasopharyngeal carcinoma. It gives a good access to the vertical petrous carotid artery as well as the horizontal petrous carotid artery. And the disadvantages, it destroys the hearing that side and also have limited access to the contralateral nasopharynx. This is the young guy about, I think 34, with a tumor extending up to the level of the skull base. The parapharyngeal internal carotid artery was involved post-chemo. So I'm just going to describe diagrammatically what the procedure was done before seeing the intraoperative picture, otherwise it would be difficult to orientate. This is the sigmoid sinus, internal jugular vein, and the internal carotid artery. We make the post-oral incision, raise the flap, and then do what's called subtotal petrosectomy. And then clear the infratemporal fossa, excision of the internal carotid artery, and also the nasopharynx. The entire thing will be resected oblong. So this is the post-intraoperative picture. This is on the left side. So this is the level of the zygoma, and this is the posterior end of the nasal septum. This is the contralateral eustachian tube. This is the internal carotid artery that was ligated just at the level of the skull base. This is the sigmoid sinus. We've done the subtotal petrosectomy and excision of the lateral wall of the nasopharynx as well as the lateral wall of the oropharynx in this patient. And the defect was reconstructed using microvascular flap. And this is 4 years post-op, so he did very well after this surgery. And I've described so many open approaches to the nasopharynx, and all these are associated with lots of morbidity like the facial scar, trismus, palatal perforation, malocclusion, numbness over the cheek, and loss of hearing. And all these are due to the type of exposure, not from tumor resection. So these can be avoided, these morbidity can be avoided if you use endoscopic approach, but that is not suitable for all cases. It's for small T1 or T2 lesions in the nasopharynx. So in the endoscopic nasopharyngectomy, we resect the lateral wall of the nasopharynx and also the roof of the nasopharynx, which is nothing but the floor of the sphenoid sinus and part of the posterior pharyngeal wall as well. So this have the recurrent nasopharyngeal carcinoma in the nasopharynx. The PET is showing the hypermetabolic activity there. And so it's just the intraoperative video. This is the fossa of Rosenmuller with a small residual tumor there. We've done the medial maxillectomy, septectomy. The nasoseptal flap is kept on the opposite side contralateral maxillary antrum for safekeeping. Then this is the posterior wall of the maxilla. Then the sphenoid ostium is widened. Then the pterygoid plates are stripped of the soft tissue. And then the pterygoid plates will be drilled out. Then the soft tissue stripped of the skull base and also the clivus. And then the skull base bone is drilled, so it gives additional margin. Then the mucosal cuts in the posterior wall and also the lateral wall going through the eustachian tube orifice. And this is the posterior wall, the vertical cut in the posterior wall. The soft tissue is elevated, and also the clivus is being drilled. And when the clival bone is drilled and bring it down, the soft tissue comes off the clivus. That gives additional deep margin. Here, the eustachian tube near its junction with the bony junction, the eustachian tube is divided with a coablator. Sorry. Anyway, this is the. Sorry. This is after complete resection is guided by the frozen section. Then the exposed raw bone, irradiated bone is covered with the the septal flap from which was raised from the opposite side. This is the post-operative scan showing complete resection and absolutely no recurrence so far. And there are contraindications for endoscopic approach, which is whenever there's internal carotid arteries involved, the endoscopic approach is not indicated. And when there is extensive dural infiltration needing dural resection, and there's intradural extension, these are the contraindications. If you look at the data in the past, and most of these endoscopic approaches were done only in a couple of papers with a double digit. Most of them are single digit references. And most of them were for T1 and T2 tumors, and very little, 2 cases of T3 and 3 cases of T3 in all these papers. So basically, as far as my experience in the past, I have very limited experience in the last almost 20 years, and most of them were stage 1 tumors, and they have absolutely no recurrence. Some of them with 6 years of follow-up. One is with that's for a sarcoma, is the 10 years of experience, and the stage T3 tumors did not do well, and only one is T3 is doing well so far, and so this one is with the recurrence but still alive. That's the Dr. Biswas has presented this paper from the Lancet, and that proven that the endoscopic surgery significantly improved the overall survival in compared to the re-irradiation. And if you look at compared between open and the endoscopic surgery for T1 and T2 tumors, and the endoscopic, the nasopharyngectomy gives equally as well as probably considers a better prognosis, better results than open approach, and for RT3 and T4. So RT3 is reasonable the 5-year survival in open approach, and none in the endoscopic approach. T4 is almost no 5-year survival. Conclude by saying the primary treatment for nasopharyngeal carcinoma is the chemoradiation, and surgery is definitely better than re-irradiation for recurrent tumors. or T1 and T2 tumors, endoscopic approach, which is the ideal one, that gives results less morbidity. And or T3 and T4, we need a open surgery. And whenever possible, we have to use endoscope to reduce the morbidity. Great, thank you. Thank you for patient listening. If you have any questions, I'd be happy to answer.
Thank you, Dr. Ayappa. There are no questions in the Q&A, but there are some questions in the chat box. Before that, I wanted to ask you, when you resect the ICA, will you restore continuity? Will you reconstruct the ICA?
No, so the cases we have resected, we done the check the cross circulation prior to surgery with the balloon occlusion test, and we sacrificed them. We now, out of probably about 15 to 18 cases of resections of internal carotid artery, and after a balloon occlusion test became negative. And of that, I think 2 patients had minimal neurological deficits after surgery, even though they have the the good cross circulation. Both of them recovered, but they had temporary weakness.
And what about long-term follow-up? Did any of them develop a stroke on follow-up?
Not a long term. So the immediately, the only 2 I said, no, out of the probably 15 or 18 cases, two I remember very well, because they had the stroke immediately, I think within a day or 2 after surgery. That may be because the stages of blood beyond the area of occlusion that has dislodged. And all the other did not have anything, if I remember correctly.
Okay, thank you. There's a question from Dr. Nitin Sharma. Would you like to reconstruct the defect? Oh, I guess he means the dural defect. Would you like to reconstruct the defect after surgery? If yes, how?
If it is an open procedure, it's quite obvious to reconstruct the defect. The defect is very well exposed. The neurosurgeon can do the dural defect with the fascia lata, and that will be supported with the free flap. In endoscopic approach, as far as nasopharynx is concerned, that region is very difficult to reconstruct endoscopically. That's why it's dural resection is not a it's one of the contraindications in that region.
Okay. What
other areas of the dura endoscopically we can reconstruct using fascia lata, and then supplement with the pedicle flap, either the pericranial flap or the temporoparietal fascia flap. All these can be used, but that's it.
In open procedures. Yeah.
Yeah.
What are the local control rates in T3, T4 lesions in salvage surgery?
In my experience, T3, T4, I had only, so if the endoscopic thing, T3, I had only done about 3 or 4 cases, of which only 1 is still without disease. All the others had recurrence in the nasopharynx itself.
What is the contraindication to salvage surgery?
Contraindications, see, if the cavernous sinus is involved, yes, definitely we can't give a complete clearance in that region. And again, the extensive intracranial, the brain parenchyma involvement, absolutely, I think it's a contraindication. Should not do that.
Okay. Sorry, there's a request from the organizers to take the questions in the end. So we'll do that.
Sure.
Okay.
Thanks, Dr. Kiran. Thank you.
Okay. So let's call upon the third speaker for today. Dr. Sanjay's slides have opened. So, Dr. Sanjay.
Yes.
Please start.
me share screen. Something I can't seem to find the share screen button now.
It's the green button in the center of your feed. At the lower end.
No. Yeah. Okay. Can you see it now? Are you able to see it?
Yeah, we can. Please go ahead.
Okay. Firstly, good morning to all of you, and apologies for any delays I've caused, primarily because my PowerPoint refused to open. So I was transferring between two laptops. Anyway, now I managed to open it. I hope you can see I'm a radiologist, and my main interest is head and neck radiology and neuroradiology. So I'll just briefly take you through staging of carcinoma nasopharynx, how we practice in the UK, and I'm sure it's probably slightly better in India because you have more easy access to imaging, I imagine, than in the government service in the UK. So this is based, the staging of carcinoma nasopharynx is after the clinical examination by the ENT surgeon and any suspicion of malignancy or metastatic nodes in the neck. What we do generally is an MRI of the head and neck. We also do a CT of the neck, chest, abdomen, and pelvis in carcinoma of the nasopharynx, if we suspect carcinoma of the nasopharynx, and the MRI shows a positive finding. If the MRI does not show a positive finding and we have metastatic nodes which are squamous cell carcinoma in the neck from the histology, then we go on to do a PET CT to try and find the unknown primary. The latest edition of the AJCC Cancer Staging Manual is what I use as a reference. I'm sure you know the difference between the nasopharynx, oropharynx, and laryngopharynx. So we're mainly interested in this region of the anatomy. So imaging modalities that we use are CT and MRI. I put CT first because it's more easily accessible than MRI, but we primarily use MRI. So what I intend to do is take you through some examples of T1, T2, T3, T4, and discuss it in that manner. So firstly, the primary tumor staging, the TX is the primary tumor cannot be assessed, and T0 is there is no evidence of primary tumor. In other words, it's like a carcinoma of the unknown primary, but there is EBV positive nodal involvement. So this is an example of a tumor which is staged as T1. I'm just showing you just the slides which are relevant here of the images, and the tumor is confined to the nasopharynx, and it could extend to the oropharynx or the nasal cavity without parapharyngeal involvement. So that's the definition of T1, and you can see in the right fossa of Rosenmuller, there is a soft tissue mass, which is the primary lesion. In this particular case, we see no retropharyngeal nodes at this level of imaging. This is another example of a T1 tumor where the lesion has actually extended from the nasopharynx through the posterior choana into the nasal cavity. So bulky tumor, but it's still T1 according to the TNM classification. On the right side of the screen, you can see there is another mass, nicely defined, does not involve the prevertebral muscles, and is restricted to the mucosa here. So this is another example of a T1 tumor. Now, these images are post-contrast T1 fat suppressed usually. I've also shown some without fat suppression, so you can see that the fat suppression really helps in delineating the tumor very well. This is an example of a T2 tumor. In T2, it extends to the parapharyngeal space and also can extend into the medial pterygoid, lateral pterygoid muscle, or the prevertebral muscles. This is a new classification of T2. And here you can see a tumor, which is on the left side. It's extending into the parapharyngeal space here. On the right side, you can see the normal anatomy. So this is the levator villi palatini, the red arrow. The blue arrow is or green arrow is the tensor villi palatini. And this is the pharyngobasilar fascia here, the yellow arrow. So on the left side, the tumor has invaded all these tissues. The pterygoid is also being involved in the sort of medially. So this is a T2 tumor. Another example of a extensive T2 tumor here, but it's still T2 because it's restricted by the margins here. And here on the back posterior aspect, you can see that there is involvement of the prevertebral muscles. On the right side, another example of a T2 tumor. Here it's involving the pharyngobasilar fascia. It's involving the levator villi palatini, and posteriorly, it's also invaded the prevertebral muscles. We move on to T3 staging of nasopharyngeal cancer. Here, the definition is it infiltrates bony structures at the skull base. It could involve the cervical vertebrae. It can even extend into the paranasal sinuses and the pterygoid structures. So here's an example here of a tumor which has started infiltrating the skull base of the clivus here, and laterally it is involving also some prevertebral muscles. So what are the pterygoid structures that I referred to? It's basically the medial and lateral pterygoid plates, probably better seen on CT scan than on MRI. The pterygomaxillary fissures and the pterygopalatine fossa, these are potential spaces which could be involved by tumor in T3. So an example here, rather large lesion which has gone into the pterygoid muscle. It's gone almost to the lateral margin of the pterygoid, so it could even be classified as T4 in some cases. Posteriorly, you can see it's involving the pterygoid plates here, completely involving it. The carotid is paired. You can see it's separate. In this, it's the same patient at the superior level, it's gone into the cavernous sinus. So this is skull base involvement, and I would call it T4. Okay, but I've just given this example, this slice, as an example of T3. So another example here of a T3 tumor. This particular patient is a 59-year-old man who actually presented with Fhno syndrome. And as part of the investigation of his brain for Fhno syndrome, we saw this mass lesion. Sorry? Can you hear me?
Yeah, it's audible.
Yeah. So on the left side of the patient, you can see that the lesion is going towards the sympathetic plexus, and it has taken out some nerves. But also, although this is Fhno syndrome, we still call it T3 because it's not a direct cranial nerve involvement, which would be the classification for T4. So coming up to T4, nasopharyngeal cancer staging, the definition is that it could involve the intracranial contents, namely the cranial nerves. Inferiorly, it could involve the hypopharynx, the orbit, or the parotid gland. Now remember, involvement of the oropharynx by a nasopharyngeal tumor is still not T4, it is still T1, T2, okay? Extensive soft tissue infiltration beyond the lateral surface of the lateral pterygoid muscle is also included as T4. So here, these are examples of quite good imaging that we obtained from patients who have skull base invasion. On the left side, quite an extensive nasopharyngeal tumor, but what it is doing is it's going into the skull base, and here it's involved the V3 division of the left trigeminal nerve, okay? On the right side, here the V2 division of the trigeminal is involved, and you can see in the foramen rotundum, there is involvement of the cranial nerve. On the left side, you see the normal left V2, okay? So these are examples of cranial nerve involvement by nasopharyngeal cancer. You will see that these are fat-suppressed T1 post-contrast imaging, which gives you better assessment of the anatomy. Again, another patient, you can see here, there is involvement of the pterygoid canal on the left side, and here there's involvement of the V2 division, okay? On the right side, that's a normal V2 division. Here, you can see this is the involvement of the Gasserian ganglion on the right side. This is the normal Gasserian ganglion on the left, and that's the tumor here. So they can infiltrate along the skull base, and that makes it T4. And obviously difficult to resect, so treatment will be mainly chemoradiotherapy. Another example of an extensive nasopharyngeal cancer going into the postnasal space, going into the skull base here, and on the left side, it's gone beyond the pterygoid muscles into the parotid. This is a CT scan just to show where we can actually look at the anatomy very clearly. On the right side, you can see the pterygoid plate. On the left side, the medial pterygoid plate is invaded by tumor, and the tumor is extending contiguously into the nasal cavity anteriorly. You can see the enhancing thickening of soft tissue there. Another patient, here it's gone into the pterygopalatine fossa. There's widening of these spaces and also involvement of the parapharyngeal space. So extensive tumor further up, this patient had skull base involvement. Yet another patient with quite marked tumor extension posteriorly. You can see the carotid space is involved, the masticator space is involved, and it's gone posteriorly into the prevertebral muscles and even further into the paravertebral muscles. Okay, so extensive T4 involvement. That's a retropharyngeal space. That's a carotid space. Briefly, nodal status, as you know from your experience, that most patients present with metastatic nodes in the neck rather than a primary presentation of a T1 tumor. We use mainly MRI again to stage the neck nodes. So N1 is defined as metastasis above the caudal border of cricoid cartilage. It could be unilateral cervical nodes or unilateral or bilateral retropharyngeal nodes, but less than 6 centimeter in the maximal dimension. Now, we don't take the short axis dimension, we take the greatest dimension for retropharyngeal and cervical nodes in assessing nodal status for nasopharyngeal carcinoma. N2 is bilateral cervical nodal metastasis, again less than 6 centimeters, but above the caudal border of cricoid cartilage. And N3 would be unilateral or bilateral cervical nodal metastasis greater than 6 centimeters, and also nodal metastasis extending below the caudal border. So even lymph node stations 5B would be considered as N3. So just an MRI to show primary lesion with retropharyngeal node on the right here, and on the left, and then you can see bilateral cervical nodes going all the way to level 4, probably even level 5 on that side, on these slices. Another example of retropharyngeal nodes, quite bulky retropharyngeal nodes on both sides. For retropharyngeal nodal assessment, MRI is superior to CT and PET-CT as well, because you can actually separate the tumor from the retropharyngeal node. In PET-CT, everything might look as one big mass. Another example of retropharyngeal lymph nodes here in a patient with.
And I hate to interrupt, but we are running short of time.
Okay. Okay. Do you want me to stop? I'm nearly done.
Yeah. Thank you.
Thank you.
So let's go on with the last talk. Dr. Vikram Maya, the consulting radiation oncologist at Bangalore. He's going to talk on chemoradiation and adjuvant therapy for nasopharyngeal cancer. Sorry, Dr. Sanjay.
That's okay. It's my fault. Yeah.
You cannot start screen share while the other participant is sharing. I think somebody else is also sharing. So,
Oh, Dr. Sanjay, you have to stop screen share.
Okay.
that's the green button low down.
Yeah, it's saying that I'm not. We still, yeah.
It's visible now. Can you put it on slide view?
Good morning, everyone. I thank the organizing committee to have given me an opportunity to talk on this topic. It's basically evolution of chemoradiation and adjuvant therapy for nasopharyngeal carcinomas. In fact, one of the most important thing about the nasopharyngeal carcinomas is actually chemo and radiation. But it is very interesting to see how it has evolved over the ages and how we were able to give a beautiful benefit to the patient with respect to chemoradiation. So basically, in the past couple of decades, we have borne a number of we are witness to a number of advances in radiation, medical radiology, molecular biology, which has helped us to treat these nasopharyngeal carcinomas. And this has led to the improvement of local control as well as overall survival. And the most important of all is reduce the long-term side effects. So as of radiation therapy is concerned, it is one of the most radiosensitive tumors, nasopharyngeal carcinomas. So 1965, Moss et al. Showed 25% of patients were alive at 5 years and established that RT as a primary treatment modality for NPCs. That during all those times, it was two-dimensional radiotherapy or 2D RT during the Cobalt era. Then the Queen Elizabeth Hospital at Hong Kong and MD Anderson also showed a very good improvement in disease-specific survival to more than 50%, and overall 5-year disease-specific survival to more than 50% after treating with only radiation. So we have evolved from 2D to 3D and then to intensity modulated, and then of course VMAT and tomotherapy and proton. All these things, the most important thing about all these things is that it has helped us to improve the sparing of normal tissues and give a little higher dose to the tumor per se. And all these things, especially IMRT, has also reduced the neurotoxicities, xerostomia, trismus, dysphagia. And there are several RCTs to have shown this particular benefit with the IMRT. One RCT and several meta-analyses have shown that IMRT enhances disease control and also helps in survival. So the average 5-year survival rates or disease-specific survival for NPCs has increased steadily from 30% to 50% to 70% and till the 1990s. Then with the advent of 3D CRT, it has become to 81%, and with the advent of IMRT, it has become 85%, with continual reduction of serious late neurological toxicity. All this was not only possible because of technology, but also because of chemotherapy. Now coming to VMAT and tomotherapy, it is also a modified type of IMRT, but it's like an ARC type of therapy. And again, the most important advantage of this is it is dosimetrically superior with respect to conformity of the tumor and to the normal tissue, the minimum dose going to the normal tissue. And of course, we just heard our previous speaker speak about the MRI and how MRI is useful in our treatment planning. And using these MRI, actually, we can do a deformable registration with our planning CT scan. And with this fusion of MRI and PET, we can get a better delineation of the tumor volumes. Then next comes, all these things will not be possible without an onboard imager, because we need to see what is happening with the position of the patient every day. So we have onboard imagers on cone beam CT scan and MRIs, and we have used adaptive planning called as ethos, adaptive radiotherapy planning, on-table radiotherapy planning using artificial intelligence. And of course, Dr. Biswas already spoke about the proton beam therapy. Of course, it is not a commonly used thing because of the non-availability and the cost factor. Chemotherapy, everybody is aware of this landmark trial, which actually changed the concept of treating nasopharyngeal carcinomas. Al-Saraf et al. With the intergroup 0099 trial, which have shown major 3-year actual progression-free survival and a 3-year actual overall survival benefit with respect to addition of concurrent chemotherapy followed by adjuvant chemotherapy. So this was a landmark trial, and everybody started to follow this. And many of them started to have, I mean, there were many more other phase 3 trials, and based on these phase 3 trials, using concurrent chemo-RT versus RT alone and concurrent chemo-RT were followed by adjuvant RT, that had shown a major benefit in overall survival and also disease-specific survival. Then came the meta-analysis, MAC-NC, which was there. They had an offshoot of it called as the MAC-NPC meta-analysis, in which they had shown nearly around 4,800 patients. They showed that the addition of chemotherapy to radiotherapy improved overall survival and progression-free survival, and there was an absolute benefit in overall survival at 5 years of around 6.3%, which was very significant looking at the patient numbers. These are the graphs which showed that in any whatsoever form, the chemotherapy addition actually improved the survival curves for overall survival. Then there was again an update in the later part of this 2020, in which they had said that this confirms the maximum benefit of concomitant chemotherapy and concomitant plus adjuvant chemotherapy, and suggests that addition of induction or adjuvant chemotherapy to concomitant chemotherapy improves the disease outcome. So the best benefit of chemotherapy, the benefit of chemotherapy actually decreases with the increasing age. So all this actually confirms that addition of chemotherapy has definitely improved the outcome in nasopharyngeal carcinomas. And the results from this intergroup and 2017 MAC-NPC meta-analysis suggest that concurrent and adjuvant chemotherapy is superior much better than when we use it alone. So these are all those trials which have shown the benefit with addition of chemotherapy. Now coming to the other thing, which is induction chemotherapy. Many studies have shown from 1990 to 2000, they have compared induction chemotherapy plus radiotherapy with radiotherapy alone, and have shown there's no improvement in disease-free outcome. But the updated MAC-NPC suggests that addition of induction or adjuvant chemotherapy to concomitant chemotherapy improves tumor control and survival. So this is the MAC-NPC graph, which has shown that there is improvement in overall survival and progression-free survival with the induction chemotherapy also. So there are lots of now, what is the most optimum sequencing? Do we need to give induction followed by concurrent chemotherapy, or to do neoadjuvant and to do concurrent followed by adjuvant? So there's a lot of confusion. So what happened is the Chinese group and the ASCO came up with these guidelines for treatment staging, for treatment of stage 2 and 4A nasopharyngeal carcinomas. They highlighted on 5 major points. The first point being the radiation type and dosage, and the second one being the recommended chemotherapy sequencing. And the third one was chemotherapy option for patients with nasopharyngeal carcinomas receiving concurrent chemotherapy, and chemotherapy options for those receiving neoadjuvant, and also chemotherapy options for patients with nasopharyngeal carcinoma receiving adjuvant chemotherapy. I would stress upon the first 2 points because this is relevant in the present situation. So according to that, for all patients, this is very interesting, that for all patients with nasopharyngeal carcinomas, intensity modulated radiotherapy with daily imaging should be offered. This is the word should be offered. And if IMRT is unavailable, patients should be transferred to institutions that could implement IMRT whenever possible. Means to say that the minimum possible thing for a nasopharyngeal carcinoma in the radiotherapy setup is an IMRT, and we should not deny the patient of the same. Then coming to the chemotherapy part, for patients with T2, N0 NPCs, chemotherapy is not routinely recommended, but may be offered if there are adverse features such as bulky tumor volumes or high EBV DNA copy numbers. For patients with T1 to N1 NPC, concurrent chemotherapy may be offered, particularly for T2 N1 patients. And then coming to stage 3 and 4A NPC cancers, except stage T3 N0, chemotherapy should be offered in addition to concurrent. And for stage 3 to 4A, who do not receive induction chemotherapy, basically they are saying that induction chemotherapy followed by concurrent chemotherapy is a treatment of choice. But if you're unable to do so, then we have to offer them concurrent followed by adjuvant therapy, because there is no head-to-head trial comparing both these protocols with respect to concurrent chemotherapy. So this is in general about the whole guidance. And based on this, even the NCCN came up saying that for a node-positive disease, it is very important to give either induction chemotherapy followed by systemic chemotherapy or concurrent chemotherapy followed by adjuvant chemotherapy. Both are of equal stance, and therefore we should have a guideline based on these protocols. Thank you. Any questions?
Thank you, Dr. Vikram. We've already gobbled up time from the next session. So I guess we had to leave questions for direct communication. There are plenty of questions, but my advice is to everybody to contact the speakers directly. Thank you very much. And I guess we close the session.
Thank you.
Thank you, sirs. I would like to invite Dr. Prathamesh Pai, who is a professor of head and neck surgery and chief of unit at Tata Memorial Hospital, Mumbai. Over to you, sir.
Good morning, everybody. Thank you, Nebu. For this session today, we have a whole panel of speakers, and we will, at the end of the panel, we will have a brief discussion. We are already 15 minutes late. I'd like to invite the first speaker, Professor Paolo Bossi. He is a medical oncologist, and he focuses on head and neck cancers, and he has got a special interest in the neoadjuvant chemotherapy in the sinonasal skull-based tumors. Over to you, Dr. Bossi. Do we have this video?
We have recorded presentation.
Skull-based tumors have been treated in the past 2 decades with a lot of systemic therapy, and let's hear it.
I'm a medical oncologist and associate professor of medical oncology in Brescia, Italy, and it is really a pleasure to be with you to this annual conference of the Foundation for Head and Neck Oncology. The topic of today is the systemic therapy in sinonasal. We will discuss mainly on epithelial sinonasal cancers, so we will concentrate on this histology without speaking of sarcoma, melanoma, and hematological tumors for sake of time. So first of all, may we look at some predictive factors in order to identify the benefit of systemic treatment in sinonasal cancers? Let's proceed in our evaluation with an histology-driven analysis. First of all, let's speak about ETAC, intestinal type adenocarcinoma of the ethmoid tract. As you know, in most of the cases, a professional disease. In this disease, there is a high occurrence of molecular alteration, the most frequent one being represented by a mutation of TP53 gene. And according to this work that has been published a few years ago, the disease-free survival of these cancers in locally advanced stage can be ameliorated thanks to induction chemotherapy with cisplatinum and 5-fluorouracil. However, the benefit of this induction chemotherapy is not referred to all the cancers and to all the patients, but it is restricted to the subgroup of patients bearing a functional p53 protein in their tumors. So a protein then can be activated, that can work in order to perform its activity when activated with chemotherapy, by chemotherapy. There is also room for non-intestinal type adenocarcinoma. There is a room for molecular evaluation, as we know that there is a role for ETB6 rearrangement. This is a rearrangement that characterizes this very rare tumor, but that can be evaluated, as we have, as you know, drugs like entrectinib or larioctinib that can act on this pathway. Then what about another cancer, the sinonasal carcinoma with the INI1 deficiency? This is a potentially histone methyltransferase named tazemetostat that could be useful in INI1 negative tumors, and that has been employed in some sarcoma. These are the data in epithelioid sarcoma with the INI1 deficiency, and this is the quite impressive response that they can obtain. So in order to evaluate if this target can be useful for drug treatment also in this cancer, we should look at this in our pathological report. What about SNU, sinonasal undifferentiated carcinoma? We know that there is a mutation, in particular in the IDH2 gene, and this mutation is important as it is has a really strong prognostic factor. You can see here the disease-specific survival of sinonasal undifferentiated cancer having a mutation in green or not having this kind of mutation. What about immunotherapy in this cancer? It is essential to identify immune pathways that can be investigated for a possible integration of immunotherapy into a multidisciplinary approach in order to guide a personalized treatment. So, as of today, we have no specific data regarding this treatment, but we should look at this for the future. So, in this era of personalized medicine, there is really a need for additional research on molecular and genetic abnormalities that may lead to effective treatment. Let's move to the other part of this talk, so the therapeutic approaches. We may see that something is happening, in particular thanks to the multidisciplinary approach to this very rare cancer, and to the ability of the group of oncologists, radiologists, radiation therapists, surgeons, and pathologists to meet together and to discuss these cancers and to be able to decide jointly the best treatment that can be performed. In this regard, the role of systemic therapy into the multidisciplinary management should be an histotype-driven role, in particular for what concerns chemotherapy, and the main aim of this systemic treatment is to maximize the local, regional, and the distant sites benefit that can be obtained. Let's evaluate the different treatments that have been employed throughout the last years in these cancers, and we may see here that this is a review that has been performed on some papers dealing with induction chemotherapy. And you may see that the most employed drugs are all combination platinum-based, plus 5-FU, plus taxane, plus methotrexate. This is an old study. However, if a benefit can be derived and theoretically hypothesized, the treatment should be performed with a platinum-based combination. And we also know that the response to induction chemotherapy is really a strong prognostic factor. Starting from this paper published in 1988 to this other paper, we know that patients achieving a pathological complete response after induction chemotherapy have the highest survival evaluable. This is another paper with squamous cell carcinoma showing that the patient having a progressive disease during chemotherapy are the ones that have the worst prognosis. And there is also a recent and very elegant trial presented in Journal of Clinical Oncology 3 years ago that showed that induction chemotherapy can be a guide for treatment optimization in SNAC, cynonesal undifferentiated carcinoma. So all the patients were treated with a combination of platinum plus etoposide or docetaxel, followed by chemoradiation or followed by surgery and chemoradiation. Induction chemo gained a response in about 2/3 of the patient, and then the authors evaluated, even if in a retrospective way, the prognosis according to the response to induction therapy and to the following treatment. And they were able to assess that the patient responding to induction chemotherapy gained the most important results in terms of survival if then treated just with chemoradiation. On the other side, patients not responding to induction chemotherapy had the highest benefit when treated with followed by radiation treatment. There is another trial recently presented that showed the importance of induction chemotherapy in this retrospective series and that confirmed the prognostic role for the response obtained by the response to induction chemotherapy. And let's move to the last trials that have been performed. This is an Italian experience. 2 trials, one for operable patients, SINTART-1, and one for inoperable patients, SINTART-2. Patients were treated with a histology-driven chemotherapy, and in the first case, if achieving a response higher than 80%, they moved directly to heavy ion-based radiation therapy plus chemo. In case of less than 80% of response, were admitted in hospital to receive surgery followed by radiation. On the other side, patients inoperable obviously were treated with the heavy ion-based radiation and chemotherapy after histology-driven chemotherapy. And what about the results? In the SINTART-1 study, so operable patients, in this first prospective study, in this group of patients, we were able to show that surgery-sparing multimodal approach was feasible and was also effective in patients achieving a very good response to induction chemotherapy. So this is, I do think, a really great good news for this kind of patients. On the other side, patients that were not operable and that they received multimodal approach with induction chemotherapy followed by heavy ion or photon radiation therapy in conjunction with chemotherapy, just only slightly greater survival than what reported from previous experiences, so underscoring the need for further treatment improvement. So in conclusions, it is essential for sinonasal cancer a cooperation with pathologists and molecular pathologists in order to exploit biology to discover new targets that can be both prognostic and predictive of benefit of a specific and defined treatment. Then we know that multimodal therapeutic approach that may include surgery, radiation, and induction histotype-driven chemotherapy is at the moment the best treatment that we have in our hands. But there is an important role for multinational collaborations, and there is a really high need for further research in these very rare cancer types. I would like to thank for your attention. This is my mail, and I really enjoy.
Thank you, Dr. Bossi, for that elegant talk. So we have seen how we are in exciting times, and we are going to use the multimodality treatment for the benefit of our patients. So for the next talk, we have Dr. Reggie Thomas. Can I have a slide, please? Dr. Reggie Thomas is a professor in the Department of ENT at CNC Vellore. He has a special interest in skull-base surgery. I would like to invite him to speak on the endoscopic oncosurgery in skull base, the possibilities and the limits. Over to you, Dr. Thomas.
Thank you, Dr. Prathamesh. I'm not able to share the screen yet because the other participant's screen is still on. So if they can disable the other screen sharing, then I can share.
Now you can share, sir. Now you can.
Okay. Thank you, Dr. Prathamesh and the rest of the team in Fhno in Trivandrum. Thank you for this opportunity. I would like to go ahead straight with my presentation. So that's my hospital, and the topic is specifically on endoscopic oncosurgery, the possibilities and limits. Obviously, this is a very exciting topic. To be very frank, there are three or four baselines in this. It's primarily histology-driven approach, and most of the time we end up with a surgery with a post-op RT, and margin-free resections are sort of the most ideal, and there are select role for chemotherapy in this domain. And coming to, this is my basic, and this is also what we look at. Most likely we end up with a close margin. So the only time I've ever managed to do a piecemeal resection is only once, when you have a very small tumor, en bloc. Usually it's a piecemeal that we end up with. So these are some basic things. You have to have a very clear idea about the margins and the reconstructive plan right before you start. You cannot have a situation where you have not thought about it before you start this. This is a strange scenario that we come across very often, where people go ahead with a CT scan, do a polypectomy, and NCCN has actually recognized it and brought in guidelines even for this, where again surgery takes a predominant role, whether there is gross disease or there is no disease. This is an excellent paper that came up in 2010, and the follow-up of this also notes the advantages of the endoscopic approach. Dr. Lund notices that the concept of en bloc resection versus a piecemeal, the advantages of routine endoscopy continuing to bring in into light the early recurrence, and the most important thing is the first surgical excision, where you go ahead and do a proper job. And all the three approaches are extremely relevant: the expanded one, the conventional craniofacial, and the combination of with endoscopic techniques. This is my approximate series of 74 cases in 10 years. So I've got two regions to discuss: the anterior cranial fossa and what are the limits. Broadly, anything above the upper half of the frontal sinus, beyond the mid-pupillary line on a coronal plane, and involvement of the facial-maxillary skeleton would broadly be contraindication for a pure endoscopic approach. The most important thing when you handle an anterior skull-based tumor is the extent of involvement of the dura, because that will clearly change your reconstruction plan. As you handle the anterior cranial fossa, reconstruction takes predominance, is one of the surgeries where you have to plan your reconstruction much ahead of finally ending up with the defect. So it can be an extracranial where there is no dural involvement. It can be an extradural, no intradural involvement, and this can be an intracranial intradural. And this usually ends up with combined surgery, because the reconstruction can be extremely challenging if you do purely endoscopic, especially if it is widespread. So these are the post-op pictures that we can get. And this is a video where the olfactory neuroblastoma, which we are looking at. And you can see that the olfactory tract has to be excised along with this, at least in the later stages. And this is the crista galli being taken down, and resection of the olfactory nerves that needs to be done for clearance of the upper part of the disease. So again, what do we do with orbits that are involved in these disease? The rationale for orbital excision has been completely revised over years. Nowadays, we can even do a frozen section on table and proceed only if required with an orbital excision. And many of the times we are actually able to save the eye. So this is a frozen section going on, and these are the post-op results. You can see immediate post-op after 6 months, and this is a lateral nasal wall reconstruction of it. So coming to this, olfactory neuroblastoma definitely poses a lot of challenges. When do you actually go and resect the olfactory tract, and what is going to be your reconstruction in these cases? So reconstruction takes a major bulk of your work in this. Usually it's multi-layer with a vascularized pedicle flap. A vascularized pedicle flap technically it tends to give a better result according to literature. And you have wide defects like this, and you need to plan your repair well ahead. And for the sake of brevity of time, I'll skip these videos. This is a video of the pericranial flap placement. This is the maximum that you can do from an endoscopic corridor, where you can actually get the inlay, onlay, and followed by transposition of the pericranial flap. And this usually gives a wide cover, vascular cover for your defect. So coming to the different types of flaps, one needs to understand that nasoseptal flap is usually not available for reconstruction in this domain. So these are different types of flaps that you get: extracranial, extranasal flaps. And these are two techniques which can be used when you have a wide defect. That is, one is to make sure that the anterior end of the graft is tucked in. If you feel that the anterior-most portion of the repair is not very stable, you can actually pull it forward and get it riveted in so that it stays there and does not slip. So this is the riveting going on, where you don't need to do this for every patient that you handle, especially only if you have suspicion that your graft is going to get displaced on top. So that is a riveting that is going on, which pulls in the graft well and stabilizes the graft. So the other technique what one can do is to do a transposition into the orbital part. Again, there's a tight inlay, and then you lift off the lamina and remove the lamina, lift off the periorbita, and slip in your onlay graft. This is very useful when the defect is extremely large and you don't have anything to anchor your onlay grafts. So this sort of, the orbital periosteum sort of holds the graft in place between the fovea and the orbital periosteum. So this is one technique which has been helpful in very large defects. So one needs to be aware of complications. The most dreaded complication is the tension pneumocephalus. You need to have your neurosurgeon bailing you out if you get it. I have had it 2 times in my 10 years, and both the times the neurosurgeons were the ones who bailed me out. And your index of suspicion has to be very high to pick this up. Cases of leak and meningitis, we are quite familiar as ENT surgeons, but tension pneumocephalus with a Mount Fuji sign, you have to keep it in mind. It can happen. So coming to middle cranial fossa, the entire limits are slightly different. It's neurovascular structures. These are all the nerves that you can come across in the site. These are the different segments of the carotid artery that you can come across endoscopically. All this becomes your boundaries for resection. You cannot cross these nerves and arteries because the mobility will be extremely high. And this itself, NCCN itself classifies these are all contraindications for relative contraindications for surgery. Again, if you have an adenoid cystic coming into these regions, you may still consider surgery. So this is an adenoid cystic carcinoma. We can see that is involving one of the maxillary nerve in the video, and we have to go ahead and resect it because this is a good tumor in the sense the lifespan is quite long. And if you can give an R1 resection with a post-op RT, the patients tend to have a good outcome. So hemorrhage is also part of the deal. You need to know how to control this. You have to drill off the entire base of that tumor that is studded in the bone, and you have to take it out and give them post-op RT and follow them up. So these are, when the nerves are involved, you will end up usually having an R1 resection with preservation of nerve functions and with a post-op RT. So coming to orbit, a lot of revision has happened here. This is the two concept of periorbital fascia and the orbital fascia, which Dr. Rammohan Tiraveri highlighted. And these are all the factors that you look at when you handle the orbit, and the depth of involvement and the different muscles. Is a stripping of the entire periorbita from the muscles. So to look at this, you can see the star. It's only when the absolute indication for orbital clearance is when the muscles in significant involvement of the fat, globe, and the orbital apex. So this is an orbital preservation that we have done for a young lady who came, and the key is to find the plane between the periorbita and the tumor and dissect it. At the same time, get a traction on the outside with your ophthalmic colleague, pulling the muscle away so that you can drag it and get the plane and strip it off. So again, coming to hemorrhage, you have different options of hemorrhage, different types of hemorrhage, and you need to be familiar with what you're handling. So you need to know the types of bleeds that come in this area, and you have to strategize your bleeding, because at times you can even end up, if you don't practice it well, with a DIC, which you should avoid. So this is a patient with a renal cell carcinoma mets, which came for biopsy actually, which ended up with a huge hemorrhage on table. So we can see the different types of bleeders that is being handled. This is the sphenopalatine cauterization that's going on. It didn't subside, and then we went on with the antiethmoid, finally ended up with packing the whole thing. So to conclude, what are the possibilities? In anterior skull base, you can get an R0 resection with a clear or closed margin. With a middle skull base, sphenoids and nearby region, it is usually be a closed margin or a positive margin, especially adenoid cystic. And what are the limitations? Critical neurovascular structures and reconstruction challenges. You need to plan your reconstruction, especially if the reconstruction is going to be difficult from below. It is safer to take a transcranial route, especially large tumors, because there you get a much better access to reconstruct and suture correctly. So selection of the approach is the most critical thing for which patient, and histology of the patient, the tumor, margins, and final outcome. Thank you. I'm not able to hear you.
Thank you, Reggie, for that excellent talk. You have clearly delineated what are the boundaries an endoscopic surgeon should endeavor to follow, especially adhering to oncologic principles. We take the questions towards the end of the session. For the next talk, I would like to invite Dr. Ali Asghar Moyadi. He's a professor and head of neurosurgery at the Tata Memorial Hospital, and he will talk to us today about the transcranial approaches to the anterior skull base, principles, techniques, and outcomes. Over to you, Ali.
Yeah, thank you. Organizing team for inviting me for this session. Can you hear me? Just checking.
Yeah, we can hear you and see you. Yeah.
Okay, fine. All right, thank you. So I think the session has, been dealt with very nicely with the first two talks, and I think Dr. Reggie has actually done a lot of the work for me, set it up. So what I'm going to be focusing on is the transcranial approaches to the anterior skull base, which are complementary to the endoscopic approaches which he has talked about. I will be focusing, the topic which was given to me was anterior skull base. So I will be focusing on the transcranial approaches for the anterior skull base. And essentially the tumors which we are talking about here are the malignancies of and the paranasal sinus tumors. But the principles and the techniques are also applicable to all of the tumors may be present in the anterior midline skull base. Now, again, we've all seen that sinonasal tumors are extremely rare tumors, and these are very complex lesions. Critical neurovascular structures are often involved and potentially transgress the dura, which is actually a very critical barrier between the viscerocranium and the neurocranium. Just no man's land, and most of the tumors here were always considered unresectable with prohibitive morbidity. The philosophy has, however, evolved, and these have been all attributed to better surgical techniques and experience, improved multiplanar imaging, combined team-based approach, which is, I think, one of the fulcrums for this treatment of such tumors, improved perioperative management, and evolution in adjuvant therapies like we've seen in the first talk. So it's essentially a teamwork, and at the Tata Memorial Center, we have a team, and some of the data I will talk about is emanates from our cumulative experience over the last many years. The tumors essentially involve the paranasal sinuses, and the majority of our tumors in the anterior skull base have been malignancies. Spectrum. The ones being adenocarcinomas, squamous cell carcinomas, adenoid cystic, and esthesioneuробlastomas. The key decision-making elements when treating these kind of tumors, which are not so common, are first to have a tissue diagnosis. And we've seen that reiterated in the previous two talks, that a lot of the decision making is histology based. The second important component is to be able to evaluate the extent of the disease, both the local and the regional extent of disease and systemic. A very important aspect here is evaluation of the dural involvement. I'll just talk about that in the next slide, because this has an implication on the resectability of these tumors. There are certain red flags that you need to identify which will preclude resectability, and then you need to consider other options. The evaluation of extent of disease also has a bearing on the choice of approach, as Dr. Reggie actually pointed out. And there is a role of neoadjuvant chemotherapy. We saw that in the first talk. And in our experience, we've had that in almost 15% of the tumors that are treated. And then there is also a very important component of the treatment is adjuvant therapy. And 90% of patients, our patients in our experience, have gone on for that. So it's a combined approach and not just one of the elements, though I will be focusing only on the surgical approach. The dural involvement is actually very important to assess, and this has to be done with a complete contrast MRI. The categorization of the dural involvement is a normal dura, where the tumor is close to it, but the dura is normally seen. There is no obvious dural enhancement. And then there is dural involvement, which could be characterized as extradural, intradural, or parenchymal. And there are certain radiological signs which help you ascertain them, but all of these do not have 100% positive predictive value or sensitivity and specificity. And therefore, a combination of inputs is required, and it's always useful to have a good neuro or a head and neck radiologist involved in this assessment. This is important because there's an implication on not only the prognosis, but the surgical strategy that you will be employing, and then the reconstruction, again, rightly pointed out by Dr. Reggie in the previous talk. Having decided on surgery, the principles of surgery remain as for most solid tumors: complete removal, en bloc removal. There is a caveat here with negative margins. This includes adequate exposure of the tumor, early devascularization, the attachment wherever possible, and en bloc removal. However, tumor debulking is often supplemented where tumors are large, or in endoscopic surgeries, and even in a lot of transcranial approaches, you will end up tumor debulking to get around the tumor without retracting the brain too much. And then a complete resection. The dural involvement has to be assessed and addressed. You would want to minimize neurovascular conflict and injury, and then a thorough reconstruction. So just briefly, the decision-making in our team, if the tumors are restricted to the paranasal sinus, we would prefer an endoscopic resection. If it transgresses the midline cribriform, then we would go in for an endoscopic craniectomy. If there is significant lateral extension, then we prefer an open transfacial approach. And then if there is significant intracranial extension also extending in the lateral plane, we would do an open transcranial transfacial approach or a subcranial approach, the combination with transfacial or endoscopic approaches. The transcranial approaches to the anterior skull base have been developed by neurosurgeons initially for giant pituitary adenomas. Frazier and Dandy, doyens of neurosurgery, developed it in the 1900s, early 1900s. And this was a bifrontal access to the pituitary and midline skull-based tumors, and also for skull-based trauma. And then Tessier adopted it for craniosynostosis and craniofacial surgery. And Ketchum then combined these with a combination of facial translocations for complex craniofacial resections. Ravi also proposed a subcranial approach to extradural skull-based lesions. And since then, there has been a proliferation of these approaches with various names, modifications, and confusing terminologies. Just to show you this, there is a lot of different terms used for more or less similar approaches. In order to reconcile the terminology, the group from MD Anderson proposed calling them transbasal approaches to the anterior skull base. And the characteristic of all these approaches is a bicoronal incision, not a transfacial incision like a Lynch or an extension, with a transcranial access and varying degrees of frontal bone removal for the transcranial access. Further subcharacterization of these are based on the amount of supraorbital bar removed, the medial canthus handling, and the lateral orbital wall removal. All of these are essentially to reduce frontal lobe retraction and orbital mobilization. So this is the standard transbasal approach, a bifrontal craniotomy. This is actually one of the major approaches which we would use. If you add a supraorbital removal and varying degrees, just the glabella or the entire supraorbital bar, but sparing the medial canthus, is a transbasal 1. The transbasal 2 and 2 have progressive further increasing removal of the nasal bar, and transbasal 3 has also removal of the lateral orbital rims in order to allow lateral mobilization of the orbits and further exposure. In our experience, we've almost exclusively used the transbasal approach, which is just the bifrontal craniotomy and occasionally removing the supraorbital bar. This forms the workhorse and the basic technique on which the other modifications are based. And typically for this, the head is put on pins, 3-pin fixation, mildly extended to allow the frontal lobes to fall down. A bicoronal skin incision is used. We harvest a large pericranial graft, which goes well beyond the posterior skin incision, and do a bifrontal craniotomy, flush with the base, exteriorize the frontal sinuses, dissect the dura, address the tumor component if it is extradural or intracranial and intradural, then resect the dura and reconstruct. This is just a short video, and I'll try and run through this in the interest of time, but to demonstrate the principles. This is the skin flap, and this is a raising of the pericranial flap, which has to be done very meticulously, a generous pericranial flap. And then we do the bifrontal craniotomy. And following the bifrontal craniotomy, you avoid a midline burr hole in the center at the base to avoid a cosmetic deformity. Exteriorize the frontal sinuses, and then dissect off the dura of the base till you reach the tumor. There can be extradural tumor or there will be intradural tumor, and you address it accordingly. In this case, there was intradural tumor. So we open the dura after transfixing the anterior part of the superior sagittal sinus. The dura is then resected circumferentially with a margin, preserving the tumor en bloc. Sometimes there are extensive adhesions to the brain, and you have to be careful to avoid brain injury or coagulating veins, important veins in the brain. To complete the circumferential dural resection so that the entire tumor is isolated. If there is significant intranasal component, then you have already mobilized it intranasally via an endoscopic approach, which is complementary to this transcranial approach. Once the entire tumor is isolated with the dural rim, then you drill off the base as widely as the involvement of the tumor requires. And you can even remove the medial third of the orbital plate over here. And once that is done, you detach the entire specimen. In this case, we had endoscopic assistance, and this was then removed. Following this, you need to repair the dural defect primarily, watertight. And having done that, we use the temporalis fascia. And following that, we would then layer the base of the anterior cranial fossa with the pericranium. I will just skip through. This is the pericranium being put there. And we always prefer, as far as possible, to take these hitch stitches on the pericranium beyond the dural margin that we had resected. We parachute these sutures and pull them in so that it fits snugly, covering the base. And then you put a thick layer of gel foam over there to act as a buttress. There doesn't require any reconstruction from down unless there is a very big defect, and then we could supplant that with another fascia from the endonasal. As I said, reconstruction is very important because you need to support the brain and the orbit. You need to separate the viscerocranium and the neurocranium and provide a lining for the nasal cavity if you've done a lot of nasal work. And you want to reduce dead space, so that's not a major issue if you're doing restricting our talk to the midline anterior skull base. The pericranial flap remains the workhorse, and there are certain limitations, especially in previously treated cases, and then various local modifications of the galio-pericranial complex can be used, and very rarely you would need to use any free flaps. Post-op care, we routinely give perioperative antibiotic prophylaxis with head elevation of 30 degrees and nasal pack for 5 days. And if there is significant intradural brain handling, then we would add cerebral decongestants like mannitol, anti-epileptics, and we would always do an imaging, in that case, a CT or an MRI on post-op day 1 to assess the status of the intradural of the contents. Watch for pneumocephalus. Dr. Reggie pointed that out. Seizures sometimes, and you could give prophylactic anti-epileptics if there is significant intracranial handling. There could be frontal lobe dysfunction, especially if you have coagulated veins, and you have to watch out for that. And CSF leak, though with open approaches, generally the incidence of CSF leaks is less. This is the snapshot of overall perioperative outcomes in all our anterior skull bays, including endoscopic. CSF leaks here are seen around 6.9%, but most they more often happen in our endoscopic resections than the open transcranial resections. Finally, and this is just my last slide, oncological outcomes. Indicators of poor prognosis are squamous cancer, the histology that we know, a high-grade tumors, undifferentiated or squamous cancer, the level of invasion and dural involvement, and this has been seen in the older international collaborative study and some other studies. But more importantly, it's the cut margins which actually dictate the prognosis. And local recurrences can vary, again, based on histology, and survival rates also depend on the histology. I just had one more slide on open versus endoscopic. The endoscopic approaches have better cosmesis and quality of life and are supposed to be less morbid. Leak rates remain a little high in literature, and the oncological benefit is actually now well accepted because it's not about piecemeal or en bloc resection, but about having negative margins. However, there is difficulty in comparing data across series because of differences in the kind of heterogeneity in the kind of tumors which are included in these, and therefore the role is evolving, but each of them complement the other. To finally summarize, anterior skull base malignancies are rare and complex, and approach requires multidisciplinary teamwork and careful evaluation of loco-regional systemic disease. Surgical management is a key component of overall care and dictates outcomes. Open craniofacial resection is the standard of care, though endoscopic approaches show comparable results in select cases. The key remains radical excision, negative margins, and adequate reconstruction. Thank you very much. And I'd like to acknowledge the entire skull base team, which is actually part of this work. Thank you.
Thank you, Ali, for that comprehensive talk. And I think we have learned a lot about the management of the intracranial extension of these tumors. To complement our treatment options, we also have radiation therapy as an important component. And to talk to you about the radiation therapy outcomes and the challenges and limitations, we have Dr. Punita Lal, who is a professor in the Department of Radiation Oncology at the SGPGI Lucknow. I'd like to invite Dr. Punita Lal to begin her talk.
Thank you, Dr. Pai. Good morning, everyone, and I'd like to thank the organizers for giving me this opportunity. I'll just start my screen share. So, is it visible?
Yes, we are.
Yes,
Right. So, I'm going to talk about the difficulties and potential solutions that we have to offer or to bring to the table as far as skull-based tumors are concerned, because as far as we are concerned, these are a complex lot because they are slow-growing extraaxial tumors, and usually they are, more often than not, they are benign. Of course, they reach up to the malignant end of the spectrum as well. Mostly they are locally aggressive, and rarely they tend to metastasize. To name a few, they are meningiomas, pituitaries, gliomas, chordomas, sarcomas, and quite often we see metastasis as well. So as has been discussed by our surgical colleagues earlier on, surgery is the key component of treatment. It's a gold standard, and it takes care of the local invasion. And in cases of small tumors, complete removal is possible. In extensive disease, of course, where margins become an issue, subtotal or partial excisions are what we get to see more often than not. And so the endpoint from the surgeon's perspective is always complete removal as far as possible, so that there are no recurrences. But when we look at radiotherapy, our endpoints in these, especially the benign end of diseases, is we stabilize and ensure that there are no progressions. What are the problems that we face in these tumors? They are usually irregular shaped tumors, which cause problems in planning for us. The anatomy is difficult. There are crucial structures which are sitting quite close to the tumor-bearing regions. And we, of course, have to include not only the tumor, but the microscopic extensions that are possible. For instance, if we look at these dural tails that are present, they might not be visible on imaging, but they are very much there. And based on the image, good quality image, and our experience, and the way they tend to percolate down into the non-hindering areas, we have to encompass them into our treatment portal. So we have to ensure good immobilization when we are planning for these tumors, and look at what kind of dose schedules we have to plan. The critical structures that we are always, as radiation oncologists, wary of in this region are brainstem, optic chiasm, and the entire optical apparatus actually, and the hypophysis, the cranial nerves that are lying or traversing in this region also hold importance, and we have to respect their tolerance. So the goals in contemporary radiotherapy are that we try and improve the disease control, the survival, and the quality of life. Try and see if we can escalate the dose without increasing either long-term, the acute or the long-term toxicity. That's possible with better targeting, so that we are able to reduce side effects. In cases of photon-based radiotherapy, there has been a technological evolution. We have modern imaging, which allows us identifying our tumors better, the tumor-bearing microscopic disease better, and also the critical structure that lie in the vicinity. So precision is possible, especially alongside when we have sophisticated linear accelerators, and which can aid better beam shaping and allow image guidance and verification. If we have to have an algorithm, so for skull-based tumors, if they are small and there are no neurological deficit, observation, especially in benign ones, is possible until the deficit appears. Then comes the surgical excisions or radiotherapy. In cases of extensive disease, a combination of surgery and radiotherapy is what is required. So as far as radiation-related options are concerned, because these are slow-growing tumors, they are benign tumors, they're more often than not radio-resistant tumors. We need significant amount of dose so that we can take care of their progression. And how do we deliver that? By the use of highly conformal precision radiotherapy, image-guided verification, and beams, contemporary beams that offer steep dose gradients, or highly biologically effective particle radiations. So the photon beams that most centers would be having, we can offer SRS or stereotactic radiosurgery or radiotherapy alongside with that, with image guidance, cyber knife or gamma knife, and of course we have the good old conventional radiotherapy. And respectable dose in such tumors would be around 50 to 60 gray. The choice of treatment, of course, depends upon the risk of complications complications that might be there, depending upon where the tumor is located, how much dose we are planning, and what kind of histology is there. Fractionated radiotherapy by stereotactic conformal radiation is possible and should be attempted in cases when we are dealing with larger tumors. Larger tumors, and sorry about that. As far as the protons are concerned, that is the new kid on the block, and that has the added advantage of a Bragg peak effect, which ensures that beyond the tumor, there is no energy deposition to the normal structures, and so the normal tissue injury is less. And the tumor response, of course, as we have seen in the recent studies, is similar to what we would see in photons, but the complications would be less. Availability is much of an issue because they are present in only select number of centers, and the cost is phenomenally high. The proponents of protons would like to believe that this could be the gold standard of the future. The physics is such of protons that we ensure that beyond the target, wherever the target is situated, beyond that we are able to, the beam just falls flat, and we are not, the need to irradiate is beyond the tumor is not there. So we are able to minimize the toxicity, have respectable local controls, and similar quality of life. Of course, the literature as of now has smaller studies, recent studies, small number of patients included, and shorter follow-up. The evidence is still to be gathered. There are hardly any randomized trials, and we expect that there would be selection bias in these trials that have been reported so far. And as far as can be judged, apart from elegant plans, clinical outcomes, long-term clinical outcomes, the debate continues for that. The numbers are rising, and the particle beams are getting accepted more and more into the mainstream treatment options. As far as other particles are concerned, like carbon ions, who are they are biologically more effective, and they are probably more useful for the radio-resistant tumors, but their availability is rather limited, more in cases of Japan and Germany, not across the world wide. And there are a couple of randomized trials which have compared protons with carbon ions and have shown that the results are encouraging because they have higher radiological, biological effectivity, especially in cases of chordomas. So if I were to conclude, I would say that these are usually benign tumors which are radio-resistant, and post-op radiotherapy can be beneficial if we adopt safe and effective techniques which are available. Particle therapy in the form of protons or carbon ions are the new thing that one has to offer, looking for more evidence. They are effective, but the cost and availability is a major issue. So thank you very much for this. I would like to wind up. Thank you.
Thank you, Punita, for that very comprehensive talk. I think all the panelists have beautifully shown how these rare tumors in the vicinity of paranasal sinuses and skull base are now being managed in a very comprehensive manner. The focus remains on trying to achieve a good control using multimodality therapy. Neoadjuvant chemotherapy has a role in certain tumors which are responsive, such as sinonasal undifferentiated carcinomas. We also have seen how endoscopic surgery has brought about a paradigm shift in the management, wherein you are doing a sequential or a piecemeal resection with the objective of achieving complete control of the base of the tumor. You've also seen how intracranial extensions can be elegantly managed with a complete control of the disease, and how radiation therapy will give us a better control for these close margin resections. There are a couple of questions in the chat box, and I would like to just combine a couple of them. Reggie, you showed about the histology-driven management, especially surgically, and adenoid cystic cancers, as we know, have got a lot of submucosal spread. So there seems to be a gray zone wherein some would call it palliative surgery and some would call it curative. So there are questions which say that at what point in time would you consider converting to an open resection, and would you really call this a curative surgery? And I would ask Ali to also complement that after you.
Thank you for that question, Pratimesh. I wouldn't consider adenoid cystic as curative surgery because I've often seen perineural metastasis manifesting much later, even in cases where I felt I had taken out everything. Much later, deep down the nerve, there are lesions manifesting, and you can see the lesion spreading deeper to the plane of your field, like a skip metastasis going on. So in view of that type of a disease, that is the downside of an adenoid cystic. I don't think you can ever say that I've taken out the whole thing because there are lesions deep inside the nerve. But the good thing about adenoid cystic is if you are able to remove the gross tumor that you can see and they give radiation, these patients tend to go on for a long time with minimal morbidity. So I have not converted any of my adenoid cystics into open unless the presentation itself in the beginning itself was such that it necessitated an open approach. But if it was something that is well within the range of an endoscopic, I've always attempted endoscopic. I've never had a situation where I had to convert it into an open. But there are times when we have gone open because the situation demanded an open right from the word go. So I wouldn't consider it as a curative because you have lesions deep down. That's the way the tumor behaves. But it's a good tumor compared to a very resistant sarcoma or a very highly poorly differentiated squamous cell carcinoma where the lifespan is much shorter technically.
And you will definitely improve the local regional control rates with your surgery.
It is mostly a local regional control that you get. Very often when I see my patients do come back over the years with the distant mets, but the local regional control is quite good. They don't have any symptoms there. They're quite comfortable. And but there is pulmonary mets or there is a bone mets that starts down the line. Usually a pulmonary met that we see after 5 years, they get this. These are the good ones, the good histological tumors. The ugly ones, no matter tetracastal sarcoma, if you have one of that, they tend to have a poor prognosis, no matter how much you really chase it. So you have to really sit with the patient, select the patient, select the approach, and plan your therapy. And a few other things which I've noticed is histology, again, is extremely important. I've come across cases where people have gone ahead and operated before the final IHC markers are out. So again, between olfactory neuroblastoma and neuroendocrine, it can make a huge difference. There is a role for neoadjuvant chemo, and you need to give it and then go in. So again, histology is very much important. You have to wait for the final report before you actually go ahead and plan your resection.
So Ali, can you also add what would be your consideration for not doing a surgery in lesions such as adenoid cystic, or would you operate all patients?
I think I'll ask you to answer that question, Prathamesh. But I think I agree with what Reggie says that. So the indications for surgery for most skull-based malignancies, there are certain cases where we would not offer surgery at all. For example, if there is bilateral ICA or bilateral optic nerve involvement, or there is gross intracranial disease, which is severe and significant brain invasion. The question here is in adenoid cystic, is it a special case scenario where you would still consider R+ resection or debulking surgery? And so as Reggie pointed out that if it is a question between endoscopic and open, sometimes in open, it's still not possible to get the microscopic margins on the nerves or those vessels which are there. And therefore, I would agree when he says that, usually that decision is upfront when you see the MRI and the site. Occasionally, and I think you can corroborate my view there, is that sometimes we've had some question about whether this extension into the dura or beyond is there at endoscopy and surgery. And we have probably converted a couple, or maybe at the time of reconstruction when we feel that the reconstruction may not be very adequate. But other than that, I don't think there have been reasons or cases where we had to convert. Maybe you can add and supplement that.
Yeah, I think upfront, if you have cavernous sinus involvement, gross orbital extension in adenoid cystic cancers, you would not consider surgical option upfront. So, like Reggie said, you would look at it critically with your radiologist and assess whether we would be able to get the disease off maximally. You will not go ahead with an R2 resection, that is gross disease left behind. So all in all, when you are selecting out the case for surgery, you are not going to be selecting out the ones that Reggie pointed out, that these are the outer limits. Your carotid arteries, your optic nerves, your gross intracranial extension, these still remain contraindications. Remember, intracranial extension of diseases have a 25 to 30% 5-year survival. So that is a very poor outcome even after complete resections. So bear in mind that histology is critical. However, do not select out cases. Do not imagine that you can go ahead and do a debulking surgery and allow your radiation oncologist to mop it up. Punita, would you go ahead and tell us about what is the role of radiation in these patients, wherein I would not consider surgery?
Yeah, so so there are two things. One thing is that if you've actually not considered surgery, then we are not looking at cure, in the sense we're not looking at complete eradication. That's one thing. Having said that, if you so let's say it's a sort of effective palliation or some kind of definitive treatment that we've given. We've gone to we usually would go to higher doses to the extent that the critical structures can tolerate, and stop short at that. But our goal, our aim is not to completely remove, because I don't think complete removal would be possible.
So I want you to also, tell the audience, because everybody thinks proton therapy is a cure for these patients. Is that you pointed out about photon and proton? So is the radiation therapy the difference, or it's morbidity that we are focusing on when we are considering protons?
Yeah, so we should be very, it's actually very clear that within up to the tumor, the dose distributions are similar and the effect is similar. It is beyond the tumor, outside where the exit doses go, that's where the proton has more control. So you just stop short, and therefore there are no doses going to the structures that lie, the normal structures that lie beyond the tumor, and therefore the morbidity is less. So as far as we are concerned, we should view it that yes, the plans are definitely looking better with protons, and dosimetrically there is similarity that is present within up to the tumor bearing area. Beyond that, there's hardly any dose that is going.
Right.
So local controls, I don't think we should be viewing that there will be much better than the photons.
Right. Thank you for that clarification, Punita. I think we have had an excellent session. However, we are running short of time. We are almost 15 minutes delayed in the overall program. I'd like to thank all my panelists for the excellent presentations and very lucid delivery of the messages. Thank you very much, Reggie, Ali, and Punita, and Paolo Bossi. We will communicate via mail. Thank you, the organizers, and back to you.
Thank you, Professor Prathamesh. Now it is time for the Hirnandani oration. It will start at 11:20. I would like to invite the chairpersons, Professor Sudhir Bahadur, former professor. Gurmeet, can you put on the slide, please?
Sure, sir.
We will start at 11:20 as per the schedule. We'll have the slides on now. Can we start now? I'll invite the chairpersons on. Professor Sudhir Bahadur, former professor of head and neck surgery, AIMS New Delhi, and past president of Fhno, and Dr. Madan Kapre. He's at present the director of Niti Clinic, Nagpur, and past president of Fhno. Over to you, sirs. Gurmeet, the next slide, please.
Hello.
Yeah, sir, it's audible. Gurmeet, the slide.
Yeah. Good morning. Can I have a word with Professor Sudhir Bahadur? Is he on the line? Can you hear me?
We do hear you, Dr. Kapre.
Dr. Bahadur is in attendee list. Can somebody?
Sir, we are promoting him, but he's not accepting the call as well. I have allowed him to speak as well, but he's not accepting it.
So shall I give me Vikram?
Yes, Dr. Kapre, please. Yeah.
Guide me now. What do we do?
Now, Dr. Kapre, please take over both functions.
Okay, fine. Alok. Yeah. So shall I start with?
Hello.
Dr. Sudhir Bahadur is there. Dr. Sudhir Bahadur is able to speak.
Good morning,
Okay,
Dr. Madan,
great.
and good morning, the audience. Thank you for giving me this honor to introduce Professor Hiranandani. Professor Hiranandani has been amongst the earliest and most prominent of head and neck surgeons in this country. He worked as the professor and head of otolaryngology in the city of Mumbai from 1950s to over to late 70s at the TN Medical College and BYL Nair Hospital. He has received his early education in Mumbai and later trained himself in England. He introduced several surgical techniques besides publishing many papers and a book on the middle ear histopathology. He was the teacher par excellence and took active part in the social work around Maharashtra in various capacities. He received several honors, including Padma Bhushan in 1972, the Dhanvantri Award in 1987, and few international awards as well. He also established a 135-bedded hospital in the township of Hawaii in Mumbai. With these few words, I would request our speaker to take over and deliver the oration named after Professor Hiranandani. Thank you. Hello.
Good morning all again. It is my privilege to chair this session along with Professor Sudhir Bahadur, who is an esteemed teacher for all of us here in India. I'm here to introduce to you the esteemed speaker for the day, that is Professor Kyung-tae from Korea. Professor has been a professor of Department of Otolaryngology and Head and Neck Surgery at Seoul University, Korea. He's also director of Hanyang University Cancer Center in Seoul, Korea. He's the secretary and also is a former president of Otolaryngological Surgeons and Head and Neck Surgery. He's a tremendous educational experience. He's at the Hanyang University School of Medicine, Seoul for last almost 15 years. He has a postdoctoral fellowship in the Department of Thoracic and Head and Neck Medical Oncology at Texas at MD Anderson Center, Houston. He has a several academic societies connection. To speak the few, he's a president of Korean Society of Otolaryngology and Head and Neck Surgeon. He's a vice president of the Korean Thyroid Association. He's a president of the Resident Training Program Committee, and he has been editor for several journals, including the Korean Society of Head and Neck Surgery, Korean Society of Head and Neck Oncology, and also been the general secretary of several bodies. He's a board member, and it can go on. And I'm come to the last that he is instrumental in a lot of activity amongst thyroid, even in our country. I personally met Professor Tae in Cochin way back almost 15 years, where he instigated and practically stimulated us, holding our hands to start a similar society, which is Indian Society of Thyroid Surgeons in India. I can also point out here, because this is probably the right forum, that he has actually visited our country in the remotest part, which is the tribal belt in Melghat district in Vidarbha, and actually operated there. I can imagine what pains he must have gone through to operate in kind of a fairly medieval situations. So a man of great talents, a man of great human approach, and a teacher par excellence. May I request Professor Kyung-tae to start with his oration.
Okay.
Something which we all have close to our heart, Professor.
Yeah, thank you very much, Dr. Manan Kapuri, for your two kind introductions. Okay, let me show my slide here. Yeah, actually, it is my great honor to be a speaker of Dr. Hiranand's oration. Thank you very much for your kind invitation. Today, I would like to talk about updates and advance in transferal thyroidectomy. Among various remote toxic thyroidectomy, the transferal approach is getting popularized due to the advantages of least surgical morbidity and excellent cosmesis. Transferal thyroidectomy may include sublingual, oral vesicular, and combined approach. Also, it can be classified into robotic versus endoscopic procedures and the theater insufflation versus gastric method. The first transferal approach was tried using a central sublingual route in 2008 in cadaver and pig model. And also the lateral sublingual approach was developed in cadaver and pig model. However, the working space is very narrow and there are unusual complications such as hypoglossal nerve injury. So this approach was not used in human thyroidectomy. Dr. Wilhelm performed the transferal endoscopic thyroidectomy first in human using one sublingual port and two oral vesicular port in 2009. This technique was initially very attractive. However, it was not widely adopted worldwide. It has been performed only in some centers in Germany and China. The transfer approach using 3 oral vascular incision was first described by Richmond and cadaver model using Da Vinci surgical system in 2011. This approach provides the basics of current transfer vascular approach. Actually, the first transfer vascular endoscopic thyroidectomy for human was reported in China in 2014. However, the oral vascular approach became widespread after Anung's study in 2016 with the term TOEVR. The gaseous transfer endoscopic vascular approach using external retractor without CO2 insufflation was also introduced to avoid the CO2-related complications. However, the placement of external retractor blade narrowed the oral pore space. Also, the surgical view is inferior to the CO2 insufflation method. Also, gaseous or CO2 insufflation transfer robotic thyroidectomy using Da Vinci single port system was introduced in 2019. However, I don't support these approaches. These techniques utilize a long 3 centimeter central vascular incision. So this large oral incision and wide dissection of soft tissue might result in high possibility of mental injury and soft tissue damage. The transoral vascular approach with CO2 insufflation is currently the most popular procedure in transoral thyroidectomy. The invasiveness in creating a working space is less than other remote access thyroidectomy, and post-operative cosmesis is potentially better than other procedure. Also, this approach enables the surgeons to perform bilateral total thyroidectomy and central leg dissection. The transoral robotic procedure, we can use 3 robotic instruments with an additional light axillary port. With the placement of axillary port, we can do counter traction, so it facilitates the dissection and improves surgical dexterity. Actually, I tried post-auricular port to place third robotic instruments. However, I found that manipulating the third instrument via the post-auricular port is very limited and inconvenient. Axillary port is better than post-auricular port, so I adopted the axillary port. The indication of transoral thyroidectomy can be expanded according to the experience of surgeon. However, tumor size can be a limiting factor because the resected specimen is removed through the small oral incision port. Therefore, I think the ideal indication of transoral approach might be tumor less than 2 or 3 centimeters if the axillary port is unavailable. In the transoral approach, we need to compare the endoscopic versus robotic procedure. Definitely, I prefer the robotic procedure. The crucial advantage of robotic procedures are 3D magnified view and the simultaneous use of 3 robotic instruments. So we can do counter traction and the surgical dexterity can be improved. We can also find dissection of the recurrent nerve and the parasite glands. Also, it is easy to take out a sizable surgical specimen through axillary port. However, in terms of cost effectiveness, the endoscopy procedure is more cost effective, and the operative time is significantly shorter than the endoscopy procedure because the robotic procedure requires a docking time and a long time to exchange a robotic instrument than the endoscopy procedure. Several studies have recently revealed that surgical outcomes of transoral approach are acceptable and comparable to the conventional approach. And in our study, the surgical outcome did not differ between the transoral and the conventional approach, except for the operative time. The operative time was longer in the transoral group. The post-operative cosmesis is excellent in most patients. It is a post-operative 3 months view. The oral mucosal incision heals well, and the patient was very satisfied with postoperative cosmesis. Transverse aortectomy is feasible and safe. However, there are some unusual complications such as mental of injury, surgical site infection, and embolism. The incidence of recurrent nerve palsy in transverse aortectomy is acceptable in meta-analysis studies. However, it might be more frequent in transverse approach, especially in the learning curve or the low volume surgeons. Studies performed during the initial period of transverse approach reported a higher rate of recurrent nerve palsy, ranging from 12 to 20%. The neural monitoring is very practical and helpful to identify and confirm the laryngeal nerves. So I routinely used neural monitoring during transverse aortectomy. We evaluated the success rate of neural monitoring in transverse aortectomy. In our study, neural monitoring was successful in 83% of patients, and the fail rate was higher in the early period of the transverse approach. It might be related to the learning curve. The identification of extra branch of superior laryngeal nerve is challenging even in conventional aortectomy. Therefore, we evaluate the feasibility and success rate in transverse aortectomy, and the success rate of external branch monitoring was 42.5%. The low success rate might be related to the difficulty in identifying the external branch in limited surgical space, especially if the nerve pass inside into the pharyngeal muscles. The incidence of mental nerve injury is quite diverse in previous studies. During the introduction period of transverse aortectomy, the mental nerve injury rate are very high, ranging from 75 to 100%, probably due to the learning curve. The definition of mental nerve injury is not well established. It is generally evaluated according to the patient's subjective symptom. Therefore, we objectively investigated the mental nerve injury rate. We prospectively assessed the cutaneous sensation using the monofilament test pre and post operatively at the 10 joints of the chin, face, and neck. And the mean pressure threshold of the chin and lower lip were not different pre and post operatively. However, the pressure threshold of the submental area increases significantly after surgery and returned to normal at post-op 3 months. It might be related to the mechanical skin trauma induced by the blunt dissection and trocar insertion at the submental area. Approximately 10% of patients show the transient mild sensory disturbance on the chin after post-operatively, and it recovered to normal at post-operative 1 month. This result might prove that mental nerve injury rarely occurs during transverse aortectomy if the procedure is performed correctly. So to avoid the mental nerve injury, the central vestibular incision should be placed in the safety triangle zone, and the lateral incision should be made as close as possible to the oral commissure. Also, we need to minimize the dissection of the chin and central vestibular area. The rate of aortic embolism in transverse aortectomy has been reported to be very low. Only 4 cases of aortic embolism has been reported in the literature. However, the actual incidence might be higher than reported or expected. In transverse aortectomy, aortic embolism usually occurs during the elevation of skin flap due to accidental injury to the anterior jugular vein. I reported a case of a severe aortic embolism that led to cardiac arrest requiring resuscitation in transverse aortectomy. You can see the gas bubble in the area of tearing of the vein. Therefore, To prevent short-term embolism, skin flap should be elevated precisely through the subplatysmal layer under endoscope guidance to reduce the chance of tearing and injuring the vein. And also the CO2 insufflation pressure should be set at as low as 4 to 6 millimeters of mercury. The surgical site infection rate reported in previous studies are very low. However, I reported a relatively higher surgical space infection rate of 6% after transvaal thyroidectomy. Surgical site infection is not well defined or standardized. Our study included any case of inflammation, including mild swelling and skin redness, so the infection rate was relatively high in our study. It is an example surgical space infection. To prevent surgical space infection, the operating space should be treated antiseptically and washed with saline to remove blood clots and burn tissue and any other debris. In addition, appropriate antibiotics may be necessary pre and post-operatively. Skin burn and bruising can also occur in transvaal thyroidectomy. Skin burn and trauma can be caused by heat from the endoscopic tip of monopolar bulbi and mechanical trauma. The most skin burn and damage are mild and resolve without sequelae. Also, the most bruising and ecchymosis spontaneously resolve 1 to 2 weeks after surgery. Sometimes transvaal thyroidectomy procedure need to be converted to conventional or other remote access approaches. The most common cause of conversion is uncontrollable intraoperative bleeding and also theater embolism and inability to remove the entire tumor, and the tracheal injury have been reported as cause of conversion. Significant advantages of transvaal thyroidectomy compared to conventional thyroidectomy are superior cosmesis and better preservation of postoperative voice outcome. We evaluated the cosmetic outcome of transvaal robotic thyroidectomy, comparing it with other procedures. To evaluate the cosmetic outcome, we used self-assessment cosmetic questionnaires, including cosmetic satisfaction score and the scar consciousness scores. Also, the cosmesis index was defined as a percentage score for cosmetic satisfaction and scar consciousness. In the result at post of 3 months and 1 year after surgery, the cosmetic satisfaction score and cosmesis indexes were significantly higher in the 3 robotic groups than the conventional group. In the robotic groups, cosmesis was superiorest in the transvaal approach, followed by the transaxillary and the lateral approaches, although it did not reach statistical significance. However, if the sample size increase, we might get the statistical significance. Also, the scar consciousness score were significantly higher in the transvaal and axillary group than the conventional group. However, the post-auricular group were not different from the conventional groups. The result of scar healing are also different according to the individual and approach method. For example, some scar heals well, while some scar heals with hypertrophy or keloid. So we evaluated the scar healing itself using Vancouver scar scaling. Vancouver scar scale score of lateral and axillary approach were significantly worse than the conventional group. Actually, the lateral approach showed the worst Vancouver scar scale. Some patients complain of hypertrophic scar and discomfort of the scar after the lateral approach, and the actual instance of hypertrophic scar tend to be higher in retroauricular approach compared to conventional approach. It is one of the disadvantages of a retroauricular approach. As I mentioned, superior voice outcome is another advantage of transverse otholectomy compared to conventional procedure. We evaluated the voice outcome after transverse otholectomy in patients with a vocal cord paralysis. In our study, the voice handicap index was significantly lower in the transverse robotic groups, and the highest frequency was significantly higher in the transverse groups. Also, we evaluated the voice outcome after transaxillary approach, and the highest frequency was significantly higher in the transaxillary group. We also evaluated voice outcome after the post-auricular approach. As same, the highest frequency and frequency range were higher in the post-auricular groups. Actually, we don't know the exact causes of the better voice outcome after remote access otholectomy than the conventional approach. I think it might be related to less laryngotracheal fixation after the remote access approach. There is no anterior neck incision in the robotic procedure, so the adhesion between the skin and strap muscle and trachea might be less. QOL is another issue after thyroidectomy. We evaluated the QOL after transverse thyroidectomy. In the result of a University of Washington QOL questionnaire, the appearance score of transverse group was significantly superior to the conventional group. And anxiety and mood were the most critical issue after thyroidectomy, both in transverse and conventional groups. Appearance was the next important issue after surgery in the conventional group. However, the appearance was a low-ranked issue in transverse group. And finally, I would like to discuss transverse robotic lateral leg dissection. The lateral leg dissection for thyroid cancer was performed by minimally invasive video-assisted approach, gaseous transaxillary approach, breast, retroauricular, and BABA approaches. Lateral leg dissection via the transverse approach was considered impossible. However, recently I introduced the robotic selective neck dissection technique using the transverse approach, and the report is surgical feasibility. It is a surgical video. As you can see, transverse robotic approach is feasible for the dissection of levels 3 and 4. The dissection of level 5 is also possible if indicated. However, the dissection of level 2 is difficult due to inadequate surgical view and angles. And in the pattern of lateral lymph node metastasis in PTC, it usually occurs in multiple levels, most commonly in levels 3 and 4. However, in our previous study and other studies, single level metastasis occurred in about 20% of patients. Therefore, transverse robotic lateral leg dissection can be indicated for those patients with a single level metastasis in levels 3 or 4. In summary, transverse robotic and endoscopic thyroidectomy is feasible and comparable to conventional thyroidectomy in selected patients. A transverse approach might be preferable to other remote access thyroidectomy. And the essential advantage of transverse thyroidectomy are superior cosmesis and voice outcome. However, there are unusual complications such as cerebral embolism, mental of injury, and surgical site infection. Thank you for your attention and your time.
Excellent presentation. I'm sure Sudhir Bahadur would like to make a comment. but there is some deviation from the normal that we don't accept questions for the oration. But here, because the faculties are not having an opportunity to interact with the delegates, the FHNO body decided that maybe we could allow some dialogue between the delegates and the faculty. And I'm sure Professor Tay will be very happy to participate into this small discussion. And I'm sure Alok will guide us through this part. Over to you, Alok.
Well, thank you, Dr. Kapre. I mean, you could as well, I'm sure. But let us invite the three designated members who are going to discuss and comment on this as we move on. So Professor Amit Agarwal is here, Dr. Siddharth and Dr. Dabas.
Good morning, everybody.
Good morning.
So we had a fantastic oration by Dr. P on the very novel technique of transoral thyroidectomy. It has progressed from endoscopic to robotic, and I'm sure that is the attraction for most newer robotic surgeons to take up transoral, because it's really a scarless, the only scarless technique amongst the various techniques in thyroidectomy. But having said that, I think a lot of surgeons are wary about mental nerve injuries. And so that has always made the surgeons a bit anxious how to avoid. But evolution of this technique over the last few years has actually showed that the mental nerve injury can very well be avoided. And I would like Dr. Tai to especially tell the delegates and all the listeners tips and tips how to avoid a mental nerve injury, especially in a robotic transoral thyroidectomy.
Yeah, thank you. It's a very nice question. It's mental nerve injury, one of the important issue in transoral thyroidectomy, and many surgeons worry about that injury. But as I show you in our previous study, if you make a light incision in the oral vestibular area, and also we need to minimize the dissection of the tune area, the incidence of mental nerve injury is very low. So as I've shown, the central vestibular incision should be placed in safety, the triangle zone area in the central part, because the mental nerve is launched outside of the safety zone. Also, lateral incision should be made as close as possible to oral commissure to apart from the mental nerve. Also, lateral incision placed in oral commissure provide another advantage, is that it provides more wide angle between the two robotic, the robotic or endoscopy instruments. So it is easy to manipulate instruments without collision. Yeah. But as I mentioned, these days, some surgeons trying to the transoral approach using the Da Vinci SP single port system. Actually, the Da Vinci single port, the diameter is 2.5 centimeters. So at least if you use the SP system, we made at least 3 centimeters incision in central oral vestibular area. So it is related high possibility of mental injury. So I think it's not good option for the transoral approach, yeah, especially for the mental injury.
Thank you for clearing our doubts. The other thing, would you like us to strictly include inclusion criteria? I mean, how would you tell us to select our patients exclusively for transoral? For example, I'm a robotic surgeon. I do BABA and retroauricular and different techniques. Which particular set of patients would you feel that I should do transoral? I can do a transoral.
Actually, the indication can be expanded according to experienced surgeon. So as I mentioned, however, tumor size is kind of important limiting factor, because we usually, especially the endoscopic procedure, we need to take out the surgical specimen through the small central oral port. Usually it is 1.5 or at least 2 centimeters. So the tumor larger than 2 centimeters actually is not good indication for the transoral endoscopy approach. However, if we use the X-ray port, we can extract more larger sizable tumor, 4 centimeters or 5 centimeters. But the X-ray skin is more expandable. So you make it just 2 centimeters, we can take out a larger sizable surgical specimen.
Thank you. One last question from my side is, suppose I'm a trained robotic surgeon or a trained robotic thyroid surgeon, and I want to start transoral technique. So what number of cases would be my learning curve? I mean, how many cases do you think I should do before I can master the technique?
Yeah, actually, learning curve is also different according to the experience of the surgeon, I think. Yeah, but some study also, I think, is, but generally, 20 or 30 cases are necessary for the learning curve, overcoming the learning curve in transverse thyroidectomy. But if you are familiar with other robotic or other genotoxis approach, it may be maybe more risk than that. The 10 cases might be enough. Yeah.
Thank you so much. Thank you so much.
Morning, Dr. Tay and Dr. Siddharth. In my early experience with transoral thyroid surgery, I've come across a couple of post-operative concerns. So I would like to just give guidance how to kind of minimize these post-operative concerns from the patient point of view. So one thing is they get some tethering in this ventral chin region and some amount of deepening in the suprahyoid area, or maybe you can say tethering in the suprahyoid region. So any tips to kind of avoid or maybe restrict this?
Yeah, the good point about that is, sometimes it's skin trauma or some skin dimpling or some of them irregularities can occur after transverse thyroidectomy. To avoid that kind of a complication, I'd like to recommend we need to elevate the skin flip precisely on the subplatysmal layer. It also reduces the bleeding, also it reduces the thickness of skin flap. The thicker skin flap is better for the cosmesis, is minimize kind of irregularity and dimpling. Especially if you dissect the chin area, if you dissect superficially through just the skin underneath, sometimes it perforates the skin flap, or the skin thickness is very shallow, so it causes some dimpling of chin area. So I would recommend the skin flap on the chin area through the mandible periosteum over the periosteum to elevate the thick skin flap. Yeah.
We generally have more candidates as a female, but especially if you have to perform this in male patients with a low thyroid volume or maybe 2 centimeter thyroid nodule. So I had 2 instances where I had to finally, because of the technical issues, I couldn't complete completely. I couldn't do it completion. So I had to convert it to open. So any tips or guidance that how to do, because the Adam's apple comes in the way of the maneuvering. It comes continuously to the medial aspect.
Yes, I mentioned this. So tumor size is important actually. Larger than 2 centimeters is not a good indication. I routinely use the X-ray port, so I can extract the surgical specimen more than 2 centimeters. However, if you use only the central or vestibular area, it is actually very difficult. You may cut the surgical specimen in the plastic bag and take out it. Yeah, it is one of the things.
So in males, we find this Adam's apple, which comes in our surgical field. I mean, the maneuvering of the instrumentation is difficult in male patients when we are taking them for transoral. So anything that you would try help to help this?
Yes, yeah. Many in male patients, there are the thyroid cartilage tuberculosis is obstructed the surgical view. So many is more difficult. So for the beginners, the ideal indication is woman, not the man. Actually, you choose the man first. For overcome this kind of disadvantage, you may elevate enough working space.
Okay.
So we elevate more wide skin flap area, so it provides more larger working space. It's easy to manipulate instruments, and we can get easy access to through the Ranger cartridge. Yeah.
Last question, like post-operatively, do you suggest any compressive bandages or anything to decrease the amount of edema or collection or something for or better healing?
Yeah, I routinely use the facial band to compress the chin and neck area. Yeah, you can use that. It's helpful. Yeah, I usually use it 1 or 2 days post-operatively. Yeah.
What amount of time, like people do expect some amount of edema and numbness in this chin region. So what's the duration that they recover from this? It's like 1 month, 2 months?
The chin, some patients actually in our study also 10% of patients or some patients complain about the numbness and chin area, but they usually slowly recover through the 1 or 2 months. Yeah.
Okay. Thank you. Thank you.
Thank you.
Dr. Ted, our third discussant, Dr. Dabas, has not been not here, but let me ask you an issue or two, which is, so you have been a great sort of say mentor to us in India, and you have helped us with robotic thyroidectomy, but that was in the phase before transoral, more with the retroauricular approach, and many of us have adopted that. Our concerns about moving on to transoral primarily relate to tumor sizes. We don't quite have those tumor sizes available to most of our population. Most sizes are bigger. And also using the gas, because as we don't quite have the exposure to using gas insufflation for thyroidectomy, and we're not quite comfortable or aware of complications that occur in that situation. The attraction, of course, is that it seems to be a very comfortable way to move from hemi to total thyroidectomy. So as we progress and we gain expertise with hemithyroidectomies, we obviously now want to move on to total thyroidectomies, but find that difficult from the lateral approach. So tell me, when you have issues with tumors more than 2 centimeters, and then what is your preferred approach after the transoral approach?
Yeah, transoral approach, I think, is the best approach. I think for more than 2 centimeters. Yeah.
So you don't have tumors more than 2 centimeters in Korea? Is that something that is unusual in your practice?
Not usual. In most the pancreatic cancer patient in Korea is less than 2 centimeters. So we can usually do the transoral approach easily. But it's larger than 2 centimeters. You can make the XY port. It is easy to take out more larger sizable specimen, 2 or 3, 4 centimeters you can extract it. So I recommend you make the XY port, even in endoscopic approach. If it's difficult to take out surgical specimen, you edit the XY port and extract the surgical specimen through the XY port. Also, I definitely recommend transoral approach better than the retroauricular approach. Retroauricular is limited to just the hemithyroidectomy. It's very difficult to contract the side through unilateral incision. However, one of the advantages of transoral approach, we can do the bilateral total thyroidectomy. Yeah, it is one of the big advantages. Yeah, we can switch it. Yeah.
So I think once the pandemic finishes, maybe we can get you to visit us again.
Of course, yeah. Thank you for that.
Until that happens. So, Dr. Kapre, can we have Dr. Vikram Kekatpure join us, and perhaps you and Dr. Bahadur can
yes, of course,
can get the
That has a question. Can you allow him?
Can I have a question, sir?
Yeah, yes. Go ahead.
So with the present Da Vinci Xi system, the robotic arms are 8 millimeters or so. So are they sufficient? I mean, is it compatible for the transoral thyroid surgery? Do you think?
Yeah, actually, I'm using the Da Vinci SI system. Also, I've experienced with XI system. Definitely, XI is better than SI, especially the docking of robotic arm. The XI system is the arm is rotating, booming, so it's easy to the docking the robotic arm. But SI is also possible. It's not. Yeah, if you're familiar with SI system, you can do that. Yeah.
The size of the instrument is larger. It's 8 mm rather than the 5 mm. So will that
5
be a
mm is, yeah, 5 millimeters instrument, you can use it. Also in XI system, yeah. SI system.
Well, thank you very much, Siddharth, and of course, Amit, and chipping in with Alok. But there are certain niceties that we have to now follow because it's a very great honor to all of us to have Professor Tay to give this prestigious L.H. oration. And on behalf of all of us here, may I ask Alok and Vikram to continue with those very nice and very, very heartwarming formalities which has been going on. Can I give it to you, Alok?
Yes, thank you very much. Yeah.
So Professor Tay, thank you again. Unusual times, but nevertheless, we have had the pleasure of your company and of course enjoyed the science that you have put forth to us. Really cutting edge work here. So would you have the medal that we sent down to you available?
Yes, I got it. Yeah, beautiful medal. Yes, I like it. Yeah, I love
you
it.
get it, please. It would be nicer if Dr. Kapre or Dr. Bahadur could have done it. But
don't think that it is our hands which are putting the medals on your neck.
Yeah, very nice medal. I'm very proud. I'm very honored, yeah, to have a medal. Yeah.
Thank you so much. And Vikram Kekatpure, Secretary, I think we also have this tradition that if you have been to us and been a prominent speaker at us, we would like to induct you as honorary member of our society. And our Secretary, Dr. Vikram Kekatpure, would you please move forward and induct Dr. Tay, please?
Thank you, Professor Tay. Indeed, a great oration. Now it's our privilege to induct you as the honorary life member. So the certificate of membership says, we the undersigned hereby declare Dr. Kyonte is nominated a honorary life member of the Foundation for Head and Neck Oncology. As such, he shall enjoy the privileges and be subject to obligations of membership of Foundation, whose objective is to promote the science and practice of head and neck oncology. Signed by Alok Thakkar, Honorary President, Vikram Kekatpure, Honorary Secretary, Subramaniam Iyer, Chairman, Governing Council. So welcome, Dr. Tay, to our association.
Thank you very much. It is my great privilege to be the honorary member of the Foundation of Head and Neck Oncology. Thank you very much.
Thank you, Dr. Tay. Till we meet again. So
thank you. Thanks so much.
Right.
Okay.
Thank you.
Bye. Bye. See you later.
Thank you. Bye.
Bye.
And of course, thank you, Dr. Bahadur and Dr. Kapre, for, as you said, a wonderful session and a heartwarming formality.
So, can we go on to the next oration or?
No, let us, yes.
Okay, so now it's time for the foundation oration. I would like to invite Professor Jyoti Dabolkar, ex-president of Fhno and Professor Emeritus at KM Hospital. She is the chief editor of Journal of Physicians and Surgeons and consultant to the Reliance Foundation Hospital, Mumbai. And our next chairperson is Professor Anil De Cruz. He is the director of oncology at Apollo Hospitals. He is the president of UICC and president of Indian Thyroid Surgeons, and he is a governing council member of Fhno. Over to you, the chairpersons.
So, can you all hear me? Hello?
Yeah, it's audible.
You can hear me? Hello?
Yeah, we hear you and see you, Jyoti, and certainly lovely surroundings. So.
Thank you so much. Surrounding I chose for my dear friend, Kaustubh. I'm so proud about him because he's one guy who has proved to all of us that not being a professor, but he can do much more than a professor can do. He has started off alone. He has started a group practice. He has started a DNB teaching and in his own institute, which is now attached to HCG. And he is, as a president, has been responsible along with the others to, can you all hear me?
Yeah, it is audible.
Can you all hear me?
Yes, madam.
Okay,
Please go
so
ahead.
he's been responsible. He's responsible for starting this fellowship, which is the main objective of our foundation. Because we started off that our country is so huge, large, with a burning problem of oral cancer and head and neck cancers. So we need to train more people and we need to train more hands. And this is how we started the fellowship, which is I think 3 batches are passed out, and every year we have been taking about 20 fellows to train. And Kaustubh has achieved this in his president's post to put up everything in place and start this off, and it has started off well. So I'm really proud to introduce him for his teaching, and it is so lovely that he's speaking on his experience on the teaching facilities and teaching opportunities for our juniors. So I'm very happy that our junior crowd is going to listen to the facts and fictions about the teaching programs available. And any of you have any queries after the oration, probably there will be no questions or answers. So you can be in touch with him or me or anybody from FHO office bearers who can help you out in learning the head and neck oncology. With these words, I will hand over the mic to Kaustubh to give his oration.
Thank you so much.
He has joined on
Fhno.
the airport.
Hello.
Yeah, go on, sir.
Just before Kaustubh says, it's an irony. I'm heading towards Goa where I'm going to meet Jyoti and Kaustubh. We are just having a weekend together on a very auspicious, but I have to board a flight, but I had to come on and say a few words about Kaustubh. I just wanted to say that he's someone who should be a role model for the youngsters. Initially practiced at an academic institution, opted out very young, but did not leave academics. He continued to develop a great practice, mentor many people. I think in private, he probably has the best head and neck setup in terms of volumes, the number of youngsters who work with him, as well as the number of youngsters he has mentored. And he's talking on something very, very dear to my heart, and that's challenges and opportunities of training, which basically is education. And I think all of us and many of the youngsters listening to us, we normally do well in service. But to really be an accomplished head and neck surgeon, you need to put in dimensions of education and training. And I'm delighted to introduce Kaustubh, and I look forward to hearing his thoughts. Kaustubh, the floor is yours.
Thank you so much, Anil, with those kind words. Nebu, can we start my oration?
Please start. Nebu has just gone. For some time, Dr. Bipin here. Please kindly start, Dr. Kaustubh.
Good afternoon. I feel privileged and honored to give this foundation oration for FHNO 2021 virtual conference on the topic which is very close to my heart. This is my team at HCG Cancer Center, Ahmedabad. The topic is challenges and opportunities for head and neck training in India. Let's go to Indian scenario. Southeast Asia, India being the largest population in that group, has 70% of global cancer load. India has an estimated 2.7 million cancer patients. To this, about 1.3 million new cancer patients are added every year and approximately 0.8 million die annually. So 20 per 1 lakh population is affected by oral cancer, and it accounts for about 30% of all types of cancers. Over 9 people in India die every hour, every day because of oral cancer. And according to WHO's latest assessment, cancer cases in India will multiply 5 times over next decade. You can see that compared to USA and other countries, India has a very huge oral cancer load, incidence-wise as well as mortality-wise. If you see the figures of world and the projection, in 2020, 371,000 patients had oral cancers in the world. And in India, out of that, 126,000 patients of India were sharing that burden. So almost 33% of world's burden of oral cancer is shared by India.
When we talk about cancers in India, the Globocon 2020 data shows that lip and oral cavity is having the highest number of cancer amongst all cancers for male. And in female also, if you exclude breast, cervix, and ovary, which are female organs, lip and oral cavity cancers is highest incident cancer. Risk of developing cancer before the age of 75 by NICPR and ICMR data says that male has 9.8% and female has 9.4% risk of developing cancer. Estimated number of people living with the disease in India are around 2.5 million, and every year about 13 lakh people join as they are detected with new cancer. Cancer-related death is about 8 lakhs, and there are 27 government-recognized cancer centers across India which deals with these cancers. You can see that the head and neck is amongst the highest cancer incidence in India. But what I want you to look at is these two slides. You can see that when we talk about the healthcare professional positions, there are so many vacant positions and there are so many shortfalls which are needed for adequacy in most of the states of India. And you can also see that the infrastructure is also lacking. You can see that in most of these states, the primary healthcare center and community healthcare centers are also extremely low compared to what is needed. India's healthcare infrastructure has a long way to go. You can see that for 10,000 people, India has the lowest hospital bed, lowest number of doctors, lowest number of nurses and midwives, and lowest pharmacists. And these are the expert availability scenario. I can roughly say that Fhno has about 1,200 members and IASO around again 1,200 to 1,500 members today. There are MCH seats every year 75, DND surgical oncology 47, and radiation and medical oncology another 500 or so. Combine this are also not enough to take the load which India has. The 2019 Index of Cancer Preparedness has assessed 28 countries for adequacy of measures to treat and prevent cancer, and India has ranked amongst worst. India's healthcare system and infrastructure are third worst in the index. Government projection shows that we need about 600 quality cancer centers by end of this decade, and adding to this complex need is the fact that we have less number of qualified oncologists to treat our mammoth load of cancer. There are many teaching programs and training programs going on in the country, but it's not enough, as we have about one oncologist for every 2,000 cancer patients compared to in Western world where there is one for every 100 cancer patients. There's a need for proper training and research also, especially for trained experts, and most oncology centers are located in western and southern parts of India, and that too in major cities. The mortality rate among cancer patients in India is 4 to 6 times higher than that in US. The baseline cost of treatment is around 3 to 4 lakhs on an average, which is higher than annual income of more than 80 to 85% of households in India. India will need about 450 to 550 dedicated cancer centers by 2020 and will need over 5,000 oncologists by 2020. This was the statement given by IIHMR in 2014. I don't think today we have been able to achieve this. So the challenges are many: slow growing pool of experts, uneven geographical and developmental distribution, non-willingness to work in government sectors, skewed cost model for patients, lack of proper guidelines for training, hazards of compromise in quality care. There are many articles which suggest that large number of potentially curable patients are inappropriately treated and their outcome is significantly affected in our country. So these facts cannot be altered. They have to be dealt with. And as Einstein says, in the midst of every crisis lies great opportunity. Fhno Governing Council thought about this, and for some time they have been planning to do something about this. When I became the president in 2017, I had a dream to contribute and was greatly supported by my predecessors, Dr. Subbu, Jyoti, Anil, Moni, Ashok, and others. I got a great team: Dr. Devendra as secretary, Dushyant, Shamit, and Deepak Bala as task force of Fhno's fellowship dream. Today, the committee has grown and there are many people who are supporting this initiative. But in those days, the challenge was conceptualization. We have to make a draft, but this draft had to be made very precisely. And that's why the task force was needed to design rules, curriculum, exam patterns, etc. And then the challenge of implementation. So this 2-year fellowship vision was made as a long-term initiative. And Dr. Dushyant Shamit and Deepak Bala were given the task force responsibility in November 2017. They formed fellowship document and structure. The core curriculum was formed. 2-year structural program was designed. Mandatory rotations to radiation, medical oncology, oncoradiology, oncopathology were thought of. How to accredit the institutes were designed. Entrance and exit exam policies were discussed, brainstormed, and amongst us, we discussed about it, and then we froze it, defined the matching process, and this was a very intelligent suggestion by the task force, which was implemented, which I'll come to in next few slides. We decided that the fellows must get stipend from the institutes, and the minimum amount which was decided to be kept was 50,000. The objective of this initiative was very clear, that we wanted a structured and didactic training to all candidates in all aspects relevant to research, prevention, diagnosis, treatment, and rehab for head and neck cancer patients, with specific emphasis on hands-on surgical training and contemporary reconstruction. The fellowship had 2 parts. The fellows with maxillofacial background were given Fhno oral oncology fellowship, and the fellows with other backgrounds like MS, DMB, Diploma, ENT, MS, DNB General Surgery were given Fhno Head and Neck Fellowship as their fellowship path. The clinical experience, research experience, publications, their observerships, their career goals, and their recommendation letters were to be considered when they apply. The institutes had to have minimum set standards of infrastructure, workload, experience, and qualifications of program directors and assistant program directors. Regular academic programs have to be instituted as tumor board, journal clubs, seminars, etc. And the inspection by Fhno fellowship committee members was mandatory before allowing them or accrediting them for the fellowship. Even after accreditation, periodic re-evaluation and feedback were mandatory. We had our first cycle in March 2019, where 18 institutes were accredited across India by personal visits by fellowship task force or fellowship committee members, and more than 90 applicants applied, out of which 40 applicants were qualified for entrance exam, and out of them 16 were matched to different institutes. They went through surgical training of 2 years, which was an advanced training, ablation, neck surgery, endoscopy, reconstruction, head and neck endocrine and skull-based surgery, transoral surgeries, as well as their exposure to medical radiation oncology, dental and OMF, prosthetics, pathology, radiology, speech and swallowing, nutrition, psycho-oncology, critical reading of the literature were taught, clinical research they were put into, they were supposed to publish papers, professionalism, art and science of medical decision making were taught, the criticality of tumor board and working as a team was emphasized. There was a stringent quality control criteria. 6 monthly online review was done for all fellows. Yearly personal review of logbooks, etc. at Fhno National Conference was carried out. Exit exam at 2 years at Fhno National Conference or at HCG Cancer Center in COVID times when conferences were designated to be online. This entire part of execution of this fellowship was very critical in initial period, and there were a lot of learning. The first and the most important thing was to form a dedicated dynamic website. This website, www.fhnofellowship.org, is extremely informative and interactive for everyone who visits it. There are all the data which are updated regularly on these sites. The entrance components were application by the candidates, review of eligibility is done by the committee, evaluation of experience, academic work for internal marking, candidate submits choice list of institutes, meaning that he ranks the institutes. Then there is a theory examination. There are interviews where resume projection and targeted discussions are carried out by the examination faculty. There is a merit list after that, and then there is a matching process, and then there is result declaration. The matching is done very efficiently. Candidates submit ranking of the institutes, and the institutes also ranks the candidates. Candidates are called according to merit in their entrance exam interview, and then they are matched with the institute which have ranked them. So this ensures compliance on part of candidates and institutes both. There is a continuous evaluation, online forms for progress monitoring, periodic evaluation with communication to concerned parties. Internal evaluation is also being done, and feedbacks are given to program directors, assistant program directors, as well as to the candidates regarding the requirements which are not met with. All these online forms are evaluated by the task force committee. Their publications, their internal academics, like their attendance to tumor board, their attendance to seminars, case presentations, rotation records, their accredited courses and meetings participation is also taken into consideration, and the surgical case log is also maintained online. So every time the fellow scrubs, assists, or does a surgery under supervision, or he does a surgery independently, everything is put into the online case logbook, which is monitored by the fellowship committee. Exit exam candidate must be an FHNO member, meaning that if the candidate has not yet become FHNO member, he is not allowed to enter the entrance exam, exit exam. He has to become a member in order to give exit exam. The components are short notes and MCQs as theory, practical tables and cases. There is internal evaluation, and there is minimum 50% of score required for passing. There were a lot of teaching initiative for fellows from task force. There were academic lecture series and FHNO fellowship online lecture series, which was taken very regularly. And I must thank all these contributors, all these leaders, all these faculties who spared their time and taught these fellows online. Dr. Purvi, Dr. Sudhir, Dr. Shamit, Ajay Kumar, Raman Dev, Aditya Joshipura, Dushyant, Samskruti Murthy, and Deepak Bala, and many others who contributed this teaching. Dr. Rajesh Kantharia organized a face-to-face meet for fellows of the first batch at Bharuch, where Dr. Anil, Moni, Nirav, Rajesh, Senas, and Dushyant were faculties, and they taught them the required training for FHNO fellowships. We had 2 publications for our initiatives where we described our journey, milestone, challenges, and the future directives. Today, the status of the structured 2-year FHNO fellowship is as follows. March 19 batch, there were 15 candidates. There were 16 to begin with. 1 fellow could not complete the fellowship. Out of 15, 14 passed. 1 fellow was failed in exit exam. In October 19 batch, 17 candidates plus 1 fellow who failed, meaning 18 appeared, and out of them again 14 only passed. October 20 and October 21 batch are yet to go for exit exam. Right now, we have 35 accredited institutes across India, and there are 2 more in pipeline who are waiting for their inspection by the task force for FHNO faculties. The exam faculties, I must thank Dr. Jyoti Dabolkar, who is the chairman of exam committee chairperson, Dr. Vikram, Shamit, Deepak, KK, Arun, Rajesh, and Dr. Prasmesh Pai, who was examiner in the last exam, exit exam. These are some clips from the exams. And this is the first batch of fellows who went out as FHNO fellows and the examiners. The certificate reads like this, that this is to certify that Dr. So-and-so has worked as FHNO institutional fellow at so-and-so institute from March 15, 2019 through March 15, 2021. He or she has fulfilled all criteria and has successfully passed the examination. FHNO proudly awards the institutional fellowship in oral oncology / head and neck oncology. We wish this fellowship shall be helpful in betterment of patients and in creating healthier world. This is signed by me as chairman, Dr. Alok as president, Dr. Jyoti Dabholkar as chairman exam committee, Dr. Vikram as secretary FHNO, Dr. Dushyant as secretary FHNO institutional fellowship program. And then we had some very delightful feedbacks from the people who exited the exam and who cleared the exam and become the first successful batch of FHNO fellowship. Good experience for me as a beginner in the head and neck oncology field, adequate hands-on experience which led to confidence in operating independently, well-rounded clinical experience, excellent clinic exposure and sound knowledge in clinical judgment and good surgical training, oncological decision-making and exposure to variety of cases, able to make sound decisions of treatment of most head and neck malignancies and perform resection surgery with reasonable expertise. The program director has been very supportive and taught at the OT table. Plus, I got to know the country's most leading names in the field of head and neck oncology. Every decision was evidence-based, and my program director is one of the best I could expect or deserve. It is blessings to have a mentor like Dr. XXS, who he is a great teacher, a competent surgeon and academician, extremely thoughtful, and is always kind to fellows. He attends all teaching sessions and always there to help us academically. He makes sure that the fellows get something out of each case. And all these fellows are doing exceedingly well. 4 of them were absorbed at their own institute where they got trained as fellows, as assistant professor or consultants. And there are other who passed, are working as consultants in community and are operating at the reputed institutes of their cities. This is the second batch of fellows who passed out. I must thank all these people, Dr. Subbu, Dr. Jyoti, Anil, Ashok, Alok, Arun, Vikram, Deepak, Shamit, Dushyant, Prathamesh, Aditya, Devendra, Gauri, and KK for supporting and getting the dream of FHNO come true, and also to me, who wanted to contribute meaningfully to FHNO as well as to the country. But I must say that there are miles to go before we sleep. And I look at all these young leaders of our country to take this entire momentum through the years to come. Thank you so much.
So, do I do the formality, Vikram?
Yes, madam. Please go ahead. Please go ahead.
Okay, so I'm so excited because not only Kaustubh is here to receive this medal, but his wife Rupa is also here. And as it goes, that every successful man, there's a woman behind him. She's next to him. So I'm so proud being a woman that she's here today. And I'm making this swear, and I'm very proud for the stupendous work he has done for FHNO. And the whole team also receives this honor. Thank you so much. It's little difficult because we are sitting down, but I hope everybody can see it. And I'm really happy today. Thank you so much.
Thank you, Dr. Jyoti. And I would like to say that all these young people who are listening to this lecture or oration, you must not hesitate. There is an ample opportunity in our country, and you have able leaders in FHNO. You can contact anyone, any of us, and can get the guidance. And if you have a passion, you will find your way out. So don't hesitate. Go ahead, make our country proud. Thank you so much.
Anil sir wants
so
to
many
make
congratulations. Yes, Vikram, please.
Dr. De Cruz wants to make final comment? I see him, he's still there. Probably not. Thank you, Kaustubh sir. Thank you. Wonderful oration. It's a great journey. Congratulations to you. It's a great contribution.
Thank you.
Thank you,
Thank you
Kaustubh.
all.
Enjoy your vacation. Glad that Jyoti could be with you, and at least one oration medal could be actually conferred as it should be. Great.
Thank you.
Excellent. Thank you. Lovely. Anji. So Vikram, we break for lunch. Nebu. So Vipin, yes.
Yes, sir. So poster session will go on parallelly, and also the lunch symposia, and we will reconvene at 1:30 for the video session, the debates, and the technology primer sessions.
Excellent.
Hello? Hello?
This video demonstrates.
I am Dr. Arulalan Madhi. Posterior septotic exposed gastrium by lateralizing the
Gurmeet, what is it? What is it? Can you mute it?
a very warm welcome in
Good afternoon, everyone. The next session is the video award session. I would like to invite Dr. Suhail Hassan. He's head of the Department of ENT and Head and Neck Surgery, Majumdar Shah Cancer Center and Narayana Health Center. Sir, can I have you on line?
Yes,
There is a bit of echo, sir. Can you?
Yeah, can you see me?
Yeah, sir. It's visible and everything is fine.
Yeah, I'm just reading
Gurmeet, can we have the judges? So you can invite the judges.
Yeah, I'll just invite the judges. 1 second. Good afternoon. We're going to start off our video session this afternoon, bang on time, and I'd like to invite our faculty of judges, Dr. Farida Wadia. Ma'am, I hope you can log on and see the screen going. Dr. Kannan, Dr. Santosh Kumar, and Dr. Fhno P. Mohiuddin. Yes, Dr. Fhno. Dr. Fhno is there, and Dr. Kannan. Dr. Fhno is a consultant head and neck oncosurgeon at MOSC Medical College, Kolancheri. Welcome, Dr. Fhno. You're one of the judges, and Dr. Kannan, who's a consultant head and neck surgeon at Apollo Specialty Hospital in Chennai. Welcome, Dr. Kannan, and Dr. Santosh Kumar, who's a consultant and head of the Head and Neck Surgical Oncology Division at MVR Cancer Center and Research Institute in Calicut, Kerala. Welcome, Dr. Santosh, on the panel of judges. And Dr. Farida, we'll hope to see her in a bit. We are on time, and I hope all the presenters have logged on and are there, and I hope the video screening goes on well. I know there are always issues with, videos coming
sir,
on.
I'm Dr. Santosh.
Yes, Dr. Santosh.
I don't know whether other judges have logged in or not.
No, I can see Dr. Fhno Mohiuddin, I can see you and Dr. Kannan. Dr. Farida hasn't logged in. We are waiting for her. I can see the three of you.
Sir, Dr. Farida is not joining.
Okay, all right. Okay, fine. Thank you. Thank you.
So, can you have the list on the screen?
Sure.
Yeah, you can just put the main video, presentation slide on the screen, and then we can.
The list on the screen, please.
Yeah, that's great. Okay, we have 6 videos, and I hope all the 6 participants or presenters are here. Gino Sebastian and Bharat Saxena, Arulalan, Nityanand, Dr. Natarajan Ramalingam, and Dr. Arnab Chakraborty. I'm sure they would have, organized their videos, and I don't know if possible have a dry run, and I hope everything goes well for all the presenters and the videos go on well. We'll just, as soon as I get word from the organizing team, we can start. You can hear me clearly, right?
Yes, sir.
Dr. Kannan, Dr. Santosh, and Dr. Mohiuddin?
Yes, I can hear. I'm Dr. Santosh,
okay.
I can hear.
Yeah. So I think you've got that, note on the judging and the percentage and the marks to be given, etc. I hope you've seen it.
Yes.
The categories you have to mark with. Yeah, that's all. Just to confirm that.
Okay.
Yeah. I think that's certainly.
Can we have the first presentation on?
Yeah, if you're ready, we can go ahead with the first presentation. Should we start?
Yeah, we can start.
Okay. Yes. Okay, Dr. Gino Sebastian will be starting.
Excuse me, sir. Can I share my screen so that I can play the video in which I have recorded the description, also the narration, also?
Organizers, please.
Gino, what is the problem?
Sir, I am not able to share my screen. If I can share my screen, I can play the original video where
you are allowed to share.
You are allowed to share.
No, your video was playing. He wants to share his visual screen, I think, to talk about it. Is that it?
Yes, sir. Actually, I have prepared my video with narration also.
Sir, you are Dr. Gino. You are logged in with two devices, I guess.
Yes, sir. Yes, sir. Now I can share my screen.
Can you do that? Then, yeah, because we were just seeing the video with the music.
Yes, sir. Now it is starting, sir.
The procedure is total laryngopharyngoesophageectomy by stripping technique and gastric pull-up. Indications of this procedure include extensive malignancies.
Are you able to see the screen? I could not.
No, we can't see the screen. It's you say started screen sharing, but we can't see.
Okay, sir. 1 minute.
Dr. Gino, if there is any issue with sharing your screen, let the tech team show the video and you can put your audio on. That is another possibility.
No, madam.
If there is any, let them play the video. Your audio can be on.
You know,
Otherwise
the video can go on. You can just talk in the background if you want to say anything.
The video is having a music, sir. So
you can mute the music.
Can you share?
Can you mute the video?
Yeah, mute the music. And can you do that on the video? I don't know.
So we did that, but
or lower volume, lower all the volume on the video, make it nil, and then you can speak.
So we did that. Dr. Sebastian, can you share us the video, please? We can move to the next.
Yeah, okay. You sort it out, and then you can come back.
Yeah.
We can.
Yes, sir. I will play after the first. We can proceed with the second video, sir. I will play after that.
Yeah. Okay. Dr. Bharat Saxena to present next.
Good afternoon, sir. Emphasizes on how TFL perforator complements and completes the ALT-AMT flap axis. We have a 56-year-old male patient with right buccal mucosa squamous cell carcinoma involving the mandible extending up to the upper GB sulcus and laterally onto the skin. Stage T4A N0 M0. The patient is planned for a free ALT-TFL flap considering the large lining and soft tissue requirement. With the help of Doppler, the ALT-TFL perforators are preoperatively marked. The approach is a non-committal incision 1.5 cm medial to the ALT vascular axis, which is joining the ASIS and superolateral patella. After taking the anterior incision, it is deepened through the subcutaneous tissue and a subfacial dissection is started. Rectus femoris muscle is identified and retracted, after which the dissection continues in the septal plane between rectus femoris and vastus lateralis muscle to identify the lateral circumflex femoral artery pedicle. We now continue to categorically identify the subfacial entry of the ALT perforator. The perforator is then dissected through its entire intramuscular course towards the source vessel, which in this case is the oblique branch of lateral circumflex femoral artery. The perforator is dissected in its entire course, preserving the motor branch of the vastus lateralis muscle. No amount of the vastus lateralis muscle is harvested with the flap during the perforator dissection. The medial incision is then extended superiorly and posteriorly to begin with the identification and dissection of the TFL perforator. After identifying the TFL muscle, we continue between the TFL and the lateral facial layer. At the junction of the TFL and gluteus medius muscle, more often than not we encounter a robust TFL perforator. We then divide the TFL muscle at its insertion and reflect it superiorly to de-roof the perforator in its entire course. The TFL perforator is dissected completely till the transverse branch of LCFA. Multiple branches, including the muscular branch to TFL muscle, are divided. In this case, the oblique and the transverse branch of LCFA were joining into a common stump without having to divide the motor branch of vastus lateralis muscle. The descending branch of the LCFA was divided. After analyzing the defect, the flap dimensions were decided. The posterior incision is taken to completely island the flap on the ALT and TFL perforator. Since both the perforators were strong and pulsatile, the paddle is divided between the two. This gives greater liberty with respect to flap inset and volume correction. We were able to achieve tension-free primary closure of the donor side. The final defect in the case included wide local excision of buccal mucosa with segmental mandibulectomy including the condyle, along with upper alveolectomy and a large skin excision. The flap inset was planned in such a way that the TFL component was used for mucosal lining and the ALT for the outer skin defect. The artery was anastomosed to facial artery and vein to the IJV tributary.
Okay, thank you, Dr. Bharat. Thank you for your presentation. Yeah, that the audio and the music in tuned and it went off all right. Now we'll have our next presenters ready, please.
The next third presentation is Nityan here. Sir, can I share my screen?
Yes, please go ahead. You're Dr. Nityanand, is it?
Yes, sir.
Yes. Okay, okay. There's another person ahead of you. He's not here. I guess.
Fine, sir. So you can go ahead with that, sir.
No, I just wanted to know whether he's there. Arul?
Yes, sir. I'm here, sir.
Yes, sir. You can proceed with him, sir.
Yeah. You're in the order to present next.
Sure, sir.
So
Sure, sir. Okay, sir.
Go ahead. We'll follow the order. It's easier for the judges also. There's no mix-up. Okay. If you're ready, Arul, you can start.
Let me rest for 5 minutes. But 5 minutes is so long to me. I'm not in a position. Is my screen visible, sir?
Yeah, we are seeing some screen. I think, yeah, fit the whole screen. Yes.
In this video demonstration, I'll be describing an endonasal endoscopic excision of a clival mass. The patient was a 54-year-old female with history of headache for past 2 years, double vision on right gaze for 2 months, and reduced sensation on the face on the right side for 1 month. On clinical evaluation, she had lateral rectus paresis and right-sided trigeminal nerve hyposthesia. On CT imaging, she had a lesion centered on the clivus with extensive bony destruction and involving the right petroclival junction. On MRI, the lesion was highly vascular with involvement of the right petroclival junction. The tumor was encasing more than 180 degrees of the right paraclival ICA. We usually perform a virtual surgery based on the radiology, where each and every steps are demonstrated. In this case, we'll be starting with an left-sided anterior and posterior ethmoidectomy, followed by the right anterior and posterior ethmoidectomy, which will be followed by posterior septotomy and removal of the key of the sphenoid. We plan to remove the left middle turbinate to create a good trajectory to reach the right petroclival junction through the left nasal cavity. This will be followed by tumor debulking starting at the center, followed by lateral dissection, and at the end of the surgery, we'll try to remove the tumor on the right petroclival junction. Reconstruction would be performed using fat, fascia, and bilateral nasoseptal flap. With this plan, we go on to the surgical table. After adequate nasal decongestion on the left side, the middle turbinate is taken down at the level of the axilla, followed by an uncinectomy to expose the maxillary sinus ostium. The middle turbinate is detached of all its attachment from the lateral wall and resected out from the nasal cavity. This exposes the bulla ethmoidalis and the maxillary ostium. This is followed by uncapping of the bulla and anterior ethmoidectomy, revealing the lamina papyracea on the left side. This is followed by posterior ethmoidectomy. This completes the ethmoidectomy on the left side. This is followed by exposing the sphenoid ostium by lateralizing the superior turbinate, which is taken down for complete exposure of the sphenoid ostium. After packing the left nasal cavity, we go on to the right nasal cavity. Outfracturing of the inferior turbinate to create more space on the nasal floor, medializing the middle turbinate, and starting to perform the anterior ethmoidectomy by uncapping the bulla ethmoidalis. This is followed by posterior ethmoidectomy, which creates a lot of space on the lateral aspect of the middle turbinate. Middle turbinate is lateralized to expose the sphenoethmoidal recess, which is followed by the identification of the sphenoid sinus ostium. Superior turbinate is taken down to create further exposure to the sphenoid ostium. Now we come to the left side to mark incision for the nasoseptal flap, the anterior incision being marked using a Colorado needle, and the flap is raised from the septal perichondrium. This is followed by the superior incision, where care is taken not to injure the olfactory fiber, followed by the inferior incision along the floor of the nasal cavity. The entire nasal septal flap is elevated from the septum and is harbored into the maxillary sinus. The same steps are performed on the right side the nasal septal flap is being elevated from the nasal septum and is being harbored into the nasopharynx. After performing posterior septotomy, the bilateral sphenoid ostiums are exposed. From this point in the surgery, we utilized the two-surgeon four-handed binostril approach. The sphenoid sinus rostrum is drilled out and excised, exposing the bilateral sphenoid sinuses. The removal of the mucosa exposes the tumor in the clival recess. The floor of the sphenoid sinus is drilled to expose the clivus further inferiorly, exposing the grossly destroyed bone in the clival region. It's followed by drilling of the cellar floor and to expose the dura covering the pituitary fossa, which marks the superior limit of our dissection. As planned in our virtual surgery, the tumor at the center of the clival recess is being resected, and the tumor is resected till we reach the posterior fossa dura. Resection of the tumor involving the left side of the clivus. Using a double suction technique, the tumor is resected and sucked out simultaneously. After adequate tumor resection has been performed on the left side, we now move on to the right side where the tumor is dissected, and again using a double section technique, we dissect the tumor as well as remove the tumor from the surgical site. During this dissection, we encountered a small CSF leak in the retroclival area. Now we switch to a 30-degree endoscope to visualize further. After adequate tumor removal, this is the tumor cavity. The tumor cavity is filled with hemostatic material bilaterally and is packed using Surgicel to attain absolute hemostasis. Tumor cavity is filled with free fat harvested from the right thigh region, which is followed by an fascia lata graft, which is placed in an underlay fashion and is tucked all around the tumor cavity. This is followed by another layer of fascia lata, which is placed in an overlay fashion. The left nasoseptal flap is taken out of the maxillary sinus and is placed over the tumor cavity region, followed by the right nasoseptal flap. These flaps are supported by gel foams and Merosil nasal packing. This is the post-operative CT scan showing complete removal of the tumor and the tumor cavity. In the post-operative period, the patient had no CSF leak, and during the follow-up, patient showed improvement of both diplopia as well as right-sided facial hyposthesia. Thank you.
Thank you. Thank you for your presentation. I think we're going to go on with the next presenter who was already ready.
Thank you, sir.
Yeah, thanks for your presentation. Yeah, Dr. Nityanand.
Yeah. So can you hear me? And my screen is visualized?
Yep.
Yeah. So good afternoon. So today I'll be presenting about a combined approach craniofacial resection. My patient was a 42-year-old male who presented with a nasal obstruction for the past 3 months, which was biopsy proven as esthesioneuroblastoma, grade 3. This is a pre-NACT MRI showing an extensive right-sided nasal cavity lesion, which was completely filling the nasal cavity and extensive intracranial involvement also. Since due to the intracranial involvement, we had given 2 cycles of NACT in the form of etoposide and cisplatin, and this was the post-NACT MRI, which are more or less a stable response. So this lesion was more or less same, still completely filling the right nasal cavity with extensive intracranial involvement, with just abutting the periorbita and no intraorbital extension. So the surgery was planned for a combined craniofacial resection because of the intracranial involvement. My extent of resection was from the lamina papyracea to one side to the other side, and anteriorly from the posterior wall of the frontal sinus to the planum sphenoidal on the posterior aspect. So the main steps of the surgeries will be followed mainly to get the landmarks work from periphery to and then coming to the center. So we'll be demarcating the landmark in the periphery and then slowly debulking the tumor, and then to find out where the tumor is finally attached, and from there to get the adequate margins and then to resect the tumor. So we started with the D&E, which showing a predominant lesion on the right side with relatively free left side and the nasopharynx. So we started the dissection from the left-hand side. So with started with the middle turbinate resection. We performed an uncinectomy and which proceeded with an ethmoidectomy. This was followed by delineating the skull base, anterior skull base roof. We did a middle metal antrostomy also. We had given a mucosal, axillary mucosal incision to delineate the frontal process of maxilla. This was enable us to get the access to the frontal sinuses. So an axillary mucosal incision was given and the bone over it was exposed, for which a drilling of the frontal process of maxilla was done to gain access to the frontal recess area. Since the anterior ethmoidal roof was exposed, the anterior ethmoidal artery was exposed, and then we cauterized that. This is the anterior ethmoidal cell and the completed anterior ethmoidal cavity. The frontal recess was identified, through which we can gain access to the frontal sinus. Next, we proceeded with the septotomy after resection of the bony and cartilaginous septum, and then converted dissection to a binostril forehand approach. And this is the tumor, which is slowly debulked through forehand approach. Along with debulking of the tumor, we took proper specimens, and the ethmoidectomy also performed along with that. The posterior end of the bony septum was then resected, which then exposed us to the sphenoid ostia. Then we found out the once the tumor was debulked, we found the anterior superior attachment of the tumor. This is very important step to gain adequate mucosal margin. So we took adequate mucosal margin along the medial wall, along the lamina papyracea, and laterally in this medially on the septum and laterally on the lamina papyracea. The tumors once again debulked from there. This is a complete sphenoethmoidal cavity. This is complete dissection, which is showing from lamina papyracea to lamina papyracea on either side. This is two sphenoid ostia on the either side, and the rostrum of sphenoid which is still remaining. Next, we aim to get the frontal sinus on the right side. So since the frontal process of maxilla is already exposed, we started drilling on the frontal process of maxilla, and then reaching on to the frontal recess. We found a small mucocele at the frontal recess area, which was removed. We gained access into the frontal sinus ostia through the frontal recess, and the frontal sinus ostia was then further widened by drilling out the beak of the frontal sinus. So complete draft 2B was completed, exposing from the lamina papyracea to the septum. So our intranasal part is complete with the entire lamina papyracea dissection, and posteriorly from the planum to the posterior wall of posterior table of frontal sinus. Then a bicoronal incision was planned, after which incision was given to expose the flap. A pericranial flap was elevated with a pedicle along the supraorbital and supratrochlear vessels. A bifrontal craniotomy was then proceeded. And the calvated bone graft was then harvested. Then our work proceeded under the microscope we gently started teasing the dura from the underlying skull base bone. We could identify the bulge of the tumor, and we took the mucosal dural incision as a margin. The superior sagittal sinus was cauterized and then ligated, and the dura was incised, taking adequate margins. The posterior part of the dura was then teased out from the remaining tumor, and there was minimal infiltration of the pia on the by the tumor on the left-hand side. Once the dural incision is complete, we started exposing the bone, that is from the cribriform plate on either side from the lamina papyracea to lamina papyracea, and posterior wall of the frontal sinus to the plane of sphenoidal. Then adequate bone cuts were given. This would completely free the specimen. The tumor was gently teased out and delivered intracranially, dividing into the intracranial part and the intranasal part. The fasciolata graft was harvested, and then primary dual repair was done with meticulous suturing of the fasciolata to the resected dural margins. Then a peritoneal flap was then inserted as the underlay technique. Coming intranasally, we usually do a 2-layer closure intranasally with 1 layer of fasciolata, followed by another layer of the 3rd layer of fasciolata over it. This to completely give an watertight seal over it. Once the watertight seal is achieved, we could see a pulsation of the brain through the fasciolata. The nasal cavity was packed with gel foam and Surgicel and Mirocell. Post-operatively, the patient had uneven full post-op period, and final histopathology was Escherichia neuroblastoma grade 2 with the closest cut margin of 0.03. And patient is now undergoing the adjuvant therapy. Thank you.
Okay. Thank you. A note to our judges, Dr. Santosh and Dr. Kannan, if you would like to ask few questions to the presenters, you're more than welcome. If there anything you would like to after the presentation, I know it's a video. They are presenting
excellent.
Self-explanatory, but if you'd like to, you're welcome to ask.
Excellent presentation, Dr. Nadaraj. On the innovation aspect of it, what would you suggest? What is the innovative technique in this? What would you suggest on that?
So innovation in terms of that. Sir, I'm not able to get your question, sir.
What is the new thing you have done in this, Dr. Nadaraj?
This is not
just to demonstrate about the technique, sir. Yes, sir.
Otherwise, it's a flawless presentation. Excellent, Nadaraj. Thank you.
Thank you, sir.
Yes. It's nice presentation, but innovation is a question.
Hello.
Hello.
Yeah. Did you? Was there any questions more to be asked,
No,
Dr. Natarajan?
No, sir.
Yeah. Okay. Then if there's nothing else, all right. Okay. So we go on to the next presenter, who's I think Natarajan Ramalingam, right?
Yes, sir. Good afternoon, sir.
Yeah. Good afternoon. Yeah,
I'll share the screen, sir.
Yeah. Sure.
Sure, sir. So can you see the screen, sir?
Yeah, we can see your screen.
Yes, sir. So good afternoon, everyone.
Yeah,
I'll be
but
presenting. Sorry, sir.
yeah, you get your slideshow on. It's just on that. Just click and get your slideshow. I'm not seeing your slide.
Sir, can you see that my video, sir?
No, we
Video
can't
is
see your
started.
video.
We can
can't
see
your
your
video.
folder only.
Yeah, you can see your folder. Click on your adjunct in thyroid surgery to open that up.
First open the file, then start sharing.
Can you see now, sir?
First open the file, then start sharing. Reshare, share again. Stop sharing, then reshare before sharing.
Just unshare.
Yeah, before sharing, open the file.
Can you see the video, sir?
Sir, I said before sharing.
Dr. Natarajan, can you do one thing? Can you open the video on your computer and then share the screen?
1 second, sir.
You just stop sharing it, then open the video on your screen and then start sharing the screen.
Can you see now, sir?
Yes.
Yes. Yes.
Sorry for the delay, sir. Sorry. Sir, good afternoon. I'll be presenting on the adjuncts in thyroid surgery. The adjuncts described in the video are intraoperative neuromonitoring and parathyroid autofluorescence by flow optics. What is the rationale for flow optics? When parathyroid tissue is subjected to near infrared stimulation, it emits an autofluorescence signal, which is 2 to 10 times at 820 nanometers. Exact fluorophore is not identified. By doing this, we can identify the parathyroids. So our patient is a 55-year-old female patient with bilateral nodules, proven papillary thyroid carcinoma. So we plan for total thyroidectomy. The subplatysmal flaps are elevated superiorly, inferiorly. The lateral approach is used so that we can use the lateral approach to identify the parathyroids first up, and also as we are using IONM, we need to access the vagus nerve for the initial identification of the vagus nerve also. So here the omohyoid is retracted medially, and the straps muscles are gently elevated from the bed of the tissues. The ansa cervicalis is identified and lateralized, and the dissection is proceeded medial to the ansa cervicalis. The next step is to expose the thyroid lobe fully, as shown here, and the thyroid lobe is gently mobilized off the bed. The next step is to identify the vagus nerve. Now we can see the probe which is stimulating the vagus nerve, and you can see the response, neuromuscular response also. The next step is to identify the visually the parathyroid glands, which now we can see the superior and inferior parathyroid glands. Next, the probe is being shined with the OT lights being switched off surrounding at a distance of around 15 centimeter. When this is done, the brightness is first increased so that the focus is adjusted, and then the exposure is increased when as the brightness is reduced. And an instrument is used to point the parathyroid gland inferiorly, which is being shown. I'll be showing subsequently the autofluorescence video also simultaneously when this is when this step was being done. So this is the screen grab showing the left inferior and superior parathyroid, which was identified visually. So when coming to the new NIR-AF video, we can see the same instrument which is pointing to the inferior gland. We can see the lighted parathyroid glands as compared to the thyroid gland. Since it is a grayscale image, we don't have quantified the lighting up of the parathyroid gland. Both the left superior and left inferior parathyroid glands are demonstrated nicely. The main trick is that the exposure should be increased after the brightness is being reduced, which is done after the focusing. So we can see simultaneously both the grayscale image and the visual identification image matching. The next step is
how can you differentiate it from a central compartment node?
Yes, sir. When a central compartment node is there, the type of uptake is more for a parathyroid gland as compared to a lymph node. Basically, in a grayscale image, that is the problem because the quantification is not there. That's why we have used ICG subsequently to help our identification. proceeding with the video, the next step is to identify the superior pole, where we can see it in the reef space with avascular space, which is being stimulated. You can see the twitching of the cricothyroid muscle also well, and the neuromuscular response also on the side. Then the vessels are ligated and rechecked again, which shows that the nerve is intact. The dissection is proceeded superiorly to inferiorly as a routine thing. Now we can see that the checking of the visual parathyroid glands is being rechecked. Position is being rechecked by the Rosic sign also. And the subcapsular dissection by Delbridge technique is being continued superiorly. At every step, the tuberculous candle is being exposed now, and we can see the relations of the parathyroid gland and the tuberculous candle, and also the vessels. You can see the vessel which is being dissected off the capsule with an intact vascular supply to the parathyroid gland. The main importance of this video is that these are adjuncts. Main technique is the routine surgical technique, which is important rather than the adjuncts. Now the recurrent angina is identified next to the inferior to the deep to the tubercle of Zucker candle, which is being stimulated and identified. Again, the vascular supply is being demonstrated in relation with the recurrent laryngeal nerve and the tubercle of Zucker candle. So the dissection is proceeded inferiorly. So gently, the both superior and inferior parathyroid glands have been dissected off the thyroid capsule laterally. So you can see the recurrent laryngeal nerve entering, and the superior and inferior parathyroid glands, which is lateralized. Now the ligament of Berry is dissected off. This shows the relationship of all the critical structures in the groove area. Now the dissection is continued inferiorly. The thyroid gland is gently lifted off the tracheal bed. The ligament of Berry is being dissected out completely, and the lobe is mobilized completely. After this step, the next step is to do the check for the nerve. Now the R2 is checked, recurrent laryngeal nerve, external branch is being checked, and the vagus is being checked, showing the completeness of the dissection. So this is on the left side. Then I will be rushing through the right side procedure also for want of time. The visual identification of parathyroid gland is done. Similarly, the next step will be to identify with the NIR-AF. The right EBSLN is being checked. The autofluorescence is being checked, and recurrent laryngeal nerve is dissected off, and the gland is being mobilized completely. So basically, we don't use ICG first because it results in staining of tissues in the bed, which results in visual identification. It will be difficult. So the R2 and B2 are being done now to ensure completeness of resection. Next, subsequently, I'll be showing the post-resection NARAF video. We can see the trachea and both the glands on either side, which is still having fluorescence. Next, ICG is injected with a dose of 2.5 mg per ml, maximum dose of 5 mg per kg. Now we can see that in this ICG perfusion, they can see the dye in the IJV grayscale image, and both in the inferior and superior parathyroid gland. And the y-axis shows the intensity. When we look at this now at 0 minutes, the intensity is maximum on the IJV. Now it is maximum in the gland at 1 minute of injection, and at 2.5 minutes of injection, 3 minutes of injection also, the dye is still persistent in the parathyroid glands. So the postoperative course, patient was not having any vocal cord palsy and did not have any supplementation of calcium or vitamin D3. Coming to our experience with this autofluorescence, we had presented in AHNS. The NIRF-AF cohort had lower postoperative hypercalcemia and increased detection of glands also. This was a matched pair analysis with the controls. Thank you.
Two questions from me.
Yes, sir.
Actually, what is the use of injecting ICG and checking whether parathyroids are there or not after surgery?
Yes, sir. The main aim is that, sir, even though the parathyroids are being preserved visually, the main question of perfusion arises, whether they are perfused or not. So ICG is one technique which is used to look at the perfusion. It is being routinely used in retina surgeries also to look at the perfusion. So what we did was the ICG.
No, I'm asking about the relevance. We have already done the surgery.
Yes, sir. So the relevance is that when it is not perfused, we can take a call on auto transplantation. How many glands to be transplant, and like we can take a call also how much, whether we need to transplant or, and how many glands to be transplanted.
And second question, what is the signal?
Yes, sir.
significance of checking vagus nerve stimulation?
Yes, sir. So when the vagus nerve is stimulated, because the entire circuit can be checked at one shot. When the recurrent laryngeal nerve is cut, and distally, if we can stimulate the recurrent laryngeal nerve, still we'll get a response because it is still connected to the muscles. So once the vagus is checked in that situation, we can have a troubleshoot. Like the vagus will not have a stimulation, but recurrent laryngeal nerve will have a stimulation. So by that way, we can get to know that recurrent laryngeal nerve is injured at some point of the course.
Okay.
Okay. Fine. Okay. Thank you, Dr. Natarajan.
Thank you, sir.
Thank you. Thanks for your presentation. The next person on our list is Dr. Arnab Chakraborty. Are you ready? Hello.
Gurmeet, Arnab is in the attendees list. He has not been promoted to the panelist. Can we go to the next person then?
I think it's
Yes,
Gino.
Yeah,
Yes,
Dr. Gino has to present, right?
Yes, sir. Yes,
Okay.
I am ready, sir.
You sorted out your issues.
Dr. Arnab hasn't accepted the request. Now he has accepted. Yeah.
No, but
Okay.
now Gino is already
Let
there.
Gino go
Let's
ahead.
go ahead with that.
Okay, Dr. Gino.
Sir, is my screen visible now?
Yes.
It is visible. We don't still hear any audio. Are you having any audio?
No audio.
Yes, sir. Audio is there.
No, we can't hear it.
That is not
Sir,
audible.
please allow me to share the video.
Sir, video is having the audio, sir.
We can't hear you.
It is not audible. It is not audible. Please allow me to play the video.
Okay, then Gurmeet, please share my video.
Yeah, sure.
This total laryngopharyngoesophageectomy by stripping technique and gastric pull-up. Indications of this procedure include extensive malignancies of hypopharynx, larynx and cervical esophagus. Surgery begins by glux incision. The subplatysmal flaps are raised, the strap muscles are then divided and paracarotid tunnels are created. Dissection is done along the prevertebral fascia and the operability is assessed. Once the operability is confirmed, abdominal phase is started simultaneously by an upper midline incision. Any previous gastric surgery is generally considered as a contraindication of gastric pull-up. The right gastroepiploic pedicle is identified along the greater curvature of the stomach. Greater omentum is divided and the stomach is mobilized, preserving the right gastroepiploic pedicle. Advantages of gastric pull-up compared to colonic or jejunal interposition include less anastomotic leak due to better blood supply, less number of anastomosis, removal of all skip lesions and ability to perform a tracheoesophageal puncture. Now the gastric tube is created using green linear cutting staplers. And the length of the tube is assessed. The stapler line is reinforced. A pyloroplasty or a pyloromyotomy can be done to reduce the reflux. Now the gastric tube is ready to be transferred to the neck. Now we are back to the cervical phase. The strap muscle division is completed. Then the inferior thyroid pedicle is identified, ligated and divided. Similarly, the superior thyroid pedicle is identified and divided, along with the laryngeal pedicle. The suprahyoid muscles are then divided, taking care at the greater horn of the hyoid bone, preserving the hypoglossal nerve. Now the pharyngeal constrictor muscles are divided from the thyroid cartilage. Now the same steps are being repeated on the other side, releasing all the lateral attachments of the larynx. Now the trachea is divided and the ET tube is visible and the ET tube is repositioned. Now the pharyngeotomy is done, taking care on the mucosal margins. The posterior pharyngeal wall resection is completed and the cervical esophagus is dissected bluntly with the fingers. Then the esophagus is opened. The stripper is now introduced and is delivered out through the abdominal part. Now the stripper is sutured to the abdominal esophagus. And it is pulled up to the neck with constant traction, with one end of the suture still holding in the abdomen. The thoracic esophagus is stripped from its attachments by the pull and is delivered into the neck inside out. The specimen is delivered and examined. This technique is introduced to reduce the thoracic complications of the blunt finger dissection technique. Now this technique is replaced by the transhiatal or thoracoscopic esophageal mobilization, which has reduced the pulmonary and cardiac complications. Cervical end of the suture is now tied to a Foley's catheter and pulled into the abdomen. The Foley's catheter is then sutured to the gastric tube. Catheter is now inflated and it is pulled along with the gastric tube and it is delivered into the neck. Now the gastric tube is prepared for the anastomosis. The cut end of the pharynx can be visible, and anastomosis is made into the cut end of the pharynx. After finishing the posterior wall anastomosis, Ryle's tube is passed across the anastomosis before the anterior wall anastomosis is completed. Then a feeding jejunostomy is performed. Now the drains are inserted and the tracheostoma is matured. Postoperatively, a barium study is performed on day 5 and oral feeds are started if no evidence of anastomotic leak is observed. Thank you. The procedure is total laryngopharyngoesophageectomy by stripping technique and gastric pull-up. Indications of this procedure include extensive malignancies of hypopharynx, larynx.
Yes, sir. Nice video, but can you explain what is new in it?
Sir, this is an old technique, but it still holds some significance because in low income settings where the laparoscopy and thoracoscopy is not available, we can still use this technique for the esophageal delivery into the stomach and the specimen extractions.
Yes, sir.
And so it still holds the significance where the low income settings are there, where thoracoscopy and laparoscopy is still not available, with acceptable rate of complications.
Yeah, that's my question. What complications could you expect in this stripping? I think this is the stripping method used by Dr. Rajima Rajan in Manipal about 2 decades or more ago. Is it the similar stripper you're using, or there are new advancements or anything in that? And what complications could you have if your stripping doesn't go well?
This is the same stripper we use for...
Same vein stripper, yeah. There's nothing
no, sir.
Very different about it. Yeah,
No,
what could you have complications if everything goes well and smooth, excellent? Have you had any complications while using the vein stripper?
Sir, intra-op complication rates are in matching with the other techniques also. We had once one tracheal injury was happened, and also post-operatively patient once had a pneumothorax also. And the rates are almost similar to that of the other techniques.
So you don't do any finger dissection on either end, is it?
Finger dissection we do on the cervical part, but we are not including.
Yeah. So you do some finger dissection there because that probably creates the plane and protects the trachea. Okay.
Yes, sir.
Yes, any other questions? Please go ahead. Otherwise, we go on to the next question. Okay. I think our next presenter is Dr. Arnab.
Yes, sir. Good afternoon, sir.
Yeah. Yes, Dr. Arnab. Please go ahead with your presentation.
Someone from the tech team can please share my video.
Sure.
Very warm welcome in Fhno 2021. I'm Dr. Arnab and I'm going to present this topic on transverse design intrahyoid myocutaneous flap. Now, this intrahyoid flap consists of skin, subcutaneous tissue, platysma and the strap muscle, including the superior belly of omohyoid. It starts from the midline of the neck, extending from the thyroid cartilage till the sternal notch, and the lateral border is outlined by index finger thumb pinch test. This entire pedicle flap is based on the superior thyroid artery, the anterior branch of external carotid. All the branches of superior thyroid artery except its posterior branch have tiny tributaries supplying the intrahyoid muscle and overlying skin. Venous drainage through the anterior jugular vein and superior thyroid vein. This anterior jugular vein needs to be sacrificed for adequate mobilization. The nerve supplies from the answer cervicalis, which is to be preserved. This prevents muscle atrophy and flap retraction after radiotherapy. Now, in our case, 68 years chronic smoker gentleman, treated case of DLBCL. He presented with the ulcer proliferative growth over the left buccal mucosa, 1 cm away from angle of mouth till RMT, skin over lesion free, no palpable lymph node in neck. Now, PET series shows the ill-defined soft tissue thickening in left gingivobuccal sulcus, no metabolically active lymph node in neck, metabolically inactive right thyroid lobe lesion. Biopsy was Bethesda 2. Now we have planned this flap transverse or horizontally 12 into 4 cm in dimension. We have incised the skin and then we have deepened the incision through the strap muscles. The flap is anchored to the omohyoid muscle situated immediately beneath with silk sutures. The proposed flap is first dissected off the left sternocleidomastoid muscle. Now the dissection is carried inferiorly and the flap is lifted from the thyroid gland beneath. At first, the anterior jugular vein is dissected out and ligated. Now slowly, the flap is lifted from the thyroid gland beneath. Approaching the superior pole, the branches of the STA to thyroids are ligated. In this case, we have seen there are multiple branches from the superior thyroid artery that are supplying the upper pole of the thyroid and larynx. Each of these branches was dissected out with sharp dissection using cold scissors and ligated. Now, wherever the superior pole of the thyroid is dissected free from the nearby tissues and the vascular structure, we have to keep in mind that we must spare the external branch of the superior laryngeal nerve as it forms a major nervous supply to the larynx. The flap tissue is dissected off the sternohyoid muscle and the thyroid gland entirely. So the dissection was initially started at the inferior-most aspect, then continuing anti-clockwise manner to the medial-most aspect and then to the superior aspect. The medial-most aspect of the flap is easy to dissect out because there are less vascular structures that we can encounter. Now, while approaching the superior aspect, there are many small vessels in the peripheral zone which has to be ligated and it has to be dissected free from the underlying thyroid cartilage, thyroid membrane and the hyoid bone. Now the dissection in the superior aspect of the flap is carried out maintaining proper hemostasis in an avascular plane. Now finally, the only area left behind to dissect is the lateral most zone with major feeding vessels. Lateral dissection is carried out preserving the major pedicular supply from the superior thyroid artery and the nerve supply from the ansa cervicalis. All of the branches of the superior thyroid artery to larynx, superior pole of thyroid and the nearby structure are sacrificed and the branches to the infrahyoid group of muscle is preserved. Now the tissue around the superior thyroid artery pedicle is further trimmed down. The origin of the superior thyroid artery from the anterior aspect of the external carotid artery is identified. Ansa cervicalis and its branches with course is also identified and isolated. This helps in better mobilization of the flap into the oral cavity. Now this is the final picture of the neck upper flap harvest. Here the transverse infrared flap is accompanied by a submental platysmal flap to increase the bulk. This is a picture of oral cavity with planned extent of resection. These two flaps were used simultaneously in this case to reconstruct the buccal mucosal defect. The transverse infrahyoid flap was used as the main framework of the reconstruction. The second submental platysmal flap was used for its bulk. For reconstruction, the submental flap was placed deep into the oral cavity and the buccal mucosa, and atop it, the transverse infrahyoid flap was fashioned in such a way that the skin faces the oral cavity. The primary skin flaps were closed above it. So this is the final specimen picture showing the marginal mandibulectomy specimen with the excised tumor. It was sent for frozen section and all the margins reported negative. So the final report was moderately differentiated squamous cell carcinoma, left GBS, PT2N0, no lymphovascular or perineal invasion, all the margins free, nodular goiter of the thyroid gland. This is the picture of the same patient that was taken after 1 month. As we can see, the flap has been taken up well.
So
the technical advantages of transverse infrared flap over the traditional vertical one. It has got a better reach, anatomical lie in defect site, ease of reach, and better cosmesis in a transversely fashioned closure in neck. More and more studies are coming up, and we offer to choose it more often. It has got a short learning curve and may constitute as a useful tool in an oncosurgeon's armamentarium. Thank you.
Anyway, thank you, Dr. Arnab. Any questions to Dr. Arnab?
Yes, I have a question.
Santosh.
Can you explain the vascular supply once again?
So the vascular supply is from the superior thyroid artery.
No. What I'm asking is if that is to the same side when we are taking the vertical flap.
Yeah, sir. The
midline, right?
That is the same, sir. The vertical and the transverse both have its blood supply from the superior thyroid artery.
Whether it is crossing actually midline.
No, sir. So actually, in this case, we have crossed the midline, and for this, we have seen just a small marginal necrosis. We propose to not to cross the midline. In this case, 12 into 4 centimeter flap size was used, and it can be done up to 10 centimeter in size, depending on the neck age of the patient, laxity of the skin. But crossing the midline, we will not propose it right now.
But the 12 centimeter you are speaking about the transverse dimension, right?
Yes, sir.
Yes, sir. Then if you want to take that much, how can we take without crossing the midline?
So we can go on further laterally because we have taken this flap in this patient. We have taken the flap too much medially. We can go further laterally, just above the sternocleidomastoid muscle, and the flap may survive. We are going through the same options, the same flaps. We are trying to make it work. We have just now a patient who is being operated 2 days back. We have taken the flap without crossing the midline. He is fine for now.
Okay. Is there any technique to identify the venous drainage prior?
No, sir. We have not done it yet.
The thing is, depending upon the vein, the the limit is the vein.
Yes, sir.
Okay, so only after dissection you will come to know that vein is, if the vein is from a lower part or middle part of the IVV, the reach will be less.
Yes, sir. So the thing is, actually, we have done a lot of number of vertical flaps, and in those cases, sacrificing the anterior jugular vein didn't cause any problem to the flap. The flaps were good, and there was mild venous engorgement, or the swelling of the flap was there for 3 to 4 days, but afterwards it was taken off well.
Okay.
Fine. I think we have gone through all the participants and who presented. I thank you very much, Dr. Santosh and Dr. Kannan, for your presence and your engagement. I think your judging and your marks, you forward them on to the organizers. Any closing remarks you would like to make?
Thank you, sir. Have you finished? Can we?
Yeah.
Yes,
sir.
This
Okay, thank you, sir.
Be sent to the mail, right?
Yeah, it has to be sent to Dr. Vikram, the secretary of FHNO.
Okay.
Okay.
Thank you, sir.
All right. Thank you. Thanks very much for your time.
We'll start the next session at 2:45. We have a couple of minutes more.
Okay.
Hello, tech team.
Yes, sir.
Hi. Oh, just checking. I just want to make sure that you can hear me. That's all.
Yeah.
Hi, Jamie. Good to see you.
Dr. Terry Jones, can you please accept the request for being panelist? Dr. Jones. Thank you, sir.
Good morning.
Good morning. Hi, Terry.
Hi, Hi, Jimmy.
Oh, it's Jimmy. It's Jimmy. Hi.
Hiya. How are you? Good to see you.
I'm okay. How are you? Fun seeing, seeing you on Zoom.
I know, it's a strange world.
Yes. Yeah.
Morning, Alec. Morning, Cesar.
Hello. Hello. Do you hear me?
Yes. Yeah. It's.
Hello. How things are going on over there?
Can we start the next session now?
Yes, we should. Let's
We're
invite.
waiting for Dr. Ashok Shenoy to join. He said he's joining.
Okay, we'll wait for a couple of minutes more. Yeah.
Hello. Good to see you.
Hi, Jamie. Good to see you.
Hello.
Yeah. Session we have been waiting for. Thank you.
Yeah, I'm with you.
So thank you, Professor Jones, Professor Piazza, for joining us again. Yeah.
Professor Ashok Shenoy is chairing the session. Can you please put on the slide for that? Gurmeet, the slides, please.
Yes, sir. Yes, sir. Next slide, please.
Dr. Ashok Shenoy is going to chair the session. It is the Dr. Sudhir Bahadur State of the Science Symposium. He is the Dean, Head of the Department, Head and Neck Surgery, Surgical Oncology, Mahavir Cancer Sansthan. And he has been in head and neck surgery and oncology for the past 3.5 decades. Over to you, sir.
Thank you. Can you hear me, Alok?
Yeah, it's audible, sir.
Yeah, sure. I'm with you now, and it's a deep pleasure for me to be introducing Dr. Sudhir Bahadur, who is primarily responsible for a lot of head and neck surgeons who have reached and become the pioneers for head and neck surgery in the country, including Dr. Tucker, Dr. Subbu. So all of us are very grateful to this good Samaritan who really gave his life, and during his entire work period at the Department of ENT at the All India Institute of Medical Sciences, New Delhi, he really went from the grassroots of what the head and neck was in India. And today, I think we can proudly say that our standards in head and neck cancer, as demonstrated in various cancer centers, are superb and probably compare with some of the good centers in the Western Hemisphere. Regards about, do I need to introduce Cesare? He needs no introduction. But if somebody else is going to introduce, it will be better, because I don't have his. I have known him since he was a resident with Piero Nicolai. He came with Piero Nicolai for the Hyderabad meeting at the Fhno. And at that time, I knew this guy is going to be a star. And he seems to have risen slowly, steadily. And now I believe he's back in Brescia, if I'm wrong, if I'm not mistaken. He has become the chairman of Brescia, where he started his career as an ENT colleague. So, talking to us, his main area is basically minimally invasive surgery, and I think he's a household name in image guidance. So, over to you, Cesare. Fine, very well, Ashok. I miss you and all the Indian guys. I would like to be there in person soon, really. So I don't hear you anymore.
No, Cesare, you can stop. You can start with your presentation now.
Okay.
So, dear colleagues, good afternoon. It's a pleasure to be here again with you, talking about transoral laser surgery of the larynx, when and especially when not to do that. The first contraindication, I will never stop to tell it again, is when you cannot have an adequate visualization of the tumor you want to operate on. And obviously, this is a clear, absolute contraindication, but sometimes the issue is much more subtle, and you have to deal with patients that may have a fantastic laryngeal exposure like this, or sometimes you need an external counterpressure to get that good anterior commissure visualization. Sometimes you need also to flex the neck of your patient in order to get some kind of laryngeal relaxation and have the adequate vision of the anterior part of the glottic plane. Sometimes you cannot do anything else than using a smaller bore laryngoscope like this, remembering that this is obviously a suboptimal indication for treating anterior commissure tumors and bulky T2 or T3 tumors. And sometimes, whichever the laryngoscope you want to use, whichever the trick you want to apply, you will never reach the visualization of the glottic plane. And this happens roughly in 5% of your patients, especially nowadays when even old subjects may have beautiful long teeth in the upper jaw, obviously after a long job of their prosthodontist. So you have preoperatively to assess these possible variabilities by an easy tool, which is the mini version of the laryngoscope. It just addresses three issues: the interincisor gap, less or more than 4 centimeters, the pteromental distance, less or more than 6.5 or 6 centimeters, and the upper jaw dental status that I already mentioned a minute ago. Combining these three parameters that you measure in 1 minute in your office, you will see if the mini laryngo score is 0, 1, or 2, you will have a very good opportunity to adequately expose your tumor. But if the mini laryngo score is 3 or 4, please consider that this patient will have, in 80% of cases, suboptimal laryngeal exposure. If you just need to make a biopsy, if you just need to make a small tumor of the middle third of the vocal fold, this can be adequate. But if you have to deal with a large lesion, please consider alternative therapeutic strategies. And then, obviously, there is the target. There is all the problems that are related to the tumor you want to get rid of. And if you look at the T1A glottic cancer in the dark blue area, that's definitely always a very good indication for TLM. When you're dealing with tumors in the T1B category involving just the anterior commissure at the level of the glottic plane, and you've got a good laryngeal exposure, again, this is a very good indication for TLM. When you've got a tumor in the green area extending supra and or subglottic, but just superficial to the conus elasticus subglottically or to the paraglottic space supraglottically, then again, it's a very good indication for transoral laser excision. The problem starts when you have got a deep infiltration of the vocal muscle, the so-called T2B of the Nantian TNM edition, or you have got tumors involving deep to that into the paraglottic space, or tumors that transgress in the vertical direction, the anterior commissure, and spreads in the supra or subcommissural area, and becomes therefore a T2 or even T3 for pre-epiglottic space invasion or initial thyroid cartilage invasion. These are the very tricky lesions in which you have to make an accurate preoperative staging and to be expert in TLM before embracing them. And obviously in this lesion, you have to obtain the maximal laryngeal exposure you can have. Because the T2 and T3 family is definitively very diversified, for the T2 with superficial supra and or subglottic extension, as already mentioned, you will have a very good outcome by TLM. In T2B with vocal fold hypomobility, this outcome, as I will discuss briefly, can be good, but are definitively less good than for superficial T2. And even less good are the outcome for T2 with anterior transcommissural extension and for T3 with anterior paraglottic space invasion. These are definitively tumor amenable of TLM, but with a big care in other opportunity. For example, in younger patients, I usually prefer to do a supracricoid partial laryngectomy when I deal with this kind of lesion, while, for example, in older patients, I push a lot the envelope and I push a lot the TLM approach because I know that the supracricoid partial laryngectomy above 75 years old, for example, is not a good indication. And then there are the T3 that, in my view, are contraindicated for a TLM approach, which are those with massive posterior paraglottic space invasion and arytenoid fixation or inner thyroid cartilage erosion. So as already mentioned, this tumor, for example, is not a T1. This is a T2 for initially impaired vocal fold mobility. So you have to put a lot of attention during your video laryngoscopy or video stroboscopy, and even with your imaging, because if you see an infiltration of the vocal muscle, I would say around its half of its thickness, like here, then you are facing not a T1A, but a T2B of the old TNM classification cancer. And this is definitively treatable by a TLM approach, but as mentioned in a lot of previous series, both in the radiation oncology group as well as this, which is the series from Steiner group, you see that in T2A, I mean those with the superficial extension, there is a very good overall survival, disease survival and organ preservation rate. But when you have got a massive infiltration of the vocal muscles, a so-called T2B, then these values drop down significantly. And this is still a reason why you have to take care of this tumor, for example, with extensive resection, with the frozen section, and with careful follow-up. And always thinking about the neck, because these tumors may have already N positive. And this has been demonstrated in our series from the University of Brescia in the last 1200s of TLM performed for glottic tumors. We just saw that about 20% of them were T2, and they have a very good disease-specific survival at 10 and 20 years of follow-up. But if you look at the organ preservation, again, this group, mainly composed by T2B, had a drop in the 10 and 20 years survival organ preservation rate. And if you look at the Kaplan-Meier curves, this is significantly different from those that you can observe in T1B and T1A lesion. This was already underlined by the group of Barcelona, Isabel Vilaseca, Manuel Berras-Preckelsen, that both underlined these and other problems when dealing with TLM of advanced lesion, for example, in presence of paraglottic space involvement, anterior commissural involvement, especially in the vertical direction, and again, thyroid cartilage infiltration. As mentioned before, the anterior transcommissural extension, I mean above and below the anterior commissure, is a very tricky point. First of all, because you can miss the pre-epiglottic space involvement vertically, and also you need a large exposure to get an adequate margin at the level of the supraglottis anteriorly and subglottically in this kind of lesion. Also, your imaging must be very adequate in this kind of lesions to rule out possible cartilage infiltration. This is no more a T3, this is clearly a T4 because there is a full thickness infiltration of the thyroid, but if you don't have a good radiologist that tells you, you will never realize it during surgery, or you will realize it when it's too late and you have already dismantled the anterior part of the larynx, so you can just complete with a supracricoid laryngectomy. You obviously have lost the non-surgical organ preservation strategy. And again, this was underlined in 10 years ago, more than 10 years ago, by Vilasek and co-workers. Thyroid cartilage infiltration by TLM is, at least in my view, a relative or absolute, I would say, contraindication, and vocal fixation is another big problem. It's mainly, well, when you have tumors that are limited to the anterior paraglottic space, anterior to the vocal process of the arytenoid, these are with the limit that I already mentioned for T2B or T3, small T3 glottic cancer, that they are with a good exposure, they are very treatable by TLM. The local control rate is around 75% at 5 years, so not spectacular, but again, in old people, I would recommend this kind of approach. But when the tumor is posteriorly to that line, you have got a posterior paraglottic space involvement, then you have arytenoid fixation, like in this patient. This is the initial laryngeal insufficiency as organ. You have dysphonia, you may have dyspnea and starting dysphagia, and this on your CT scan can be easily seen by sclerosis of the arytenoid, enlargement of the cricothyroarytenoid space. This is the posterior paraglottic space involvement, with or without arytenoid fixation. In my view, is a contraindication to TLM because you risk to miss the posterior extension of the tumor towards the piriform sinus, and sometimes you may leave, even if you remove the arytenoid, you may leave tumors at the level of the cricoarytenoid joint. So tumors like this are, in my opinion, absolute contraindication to TLM, but again, you have to make a proper diagnosis before embracing this kind of approach. And always think about even that these tumors may be contraindication also to open partial laryngectomy because, or at least classic supracricoid laryngectomy, because the tumor may be attached to the cricoid, pass through the cricothyroid membrane, and be already a small T4. So in this patient, you have to make an accurate balance in between the possibility of organ preservation, surgical or non-surgical, and the opportunity of a total laryngectomy. But first of all, don't think about TLM. This is my core message. For the supraglottic lesion, the borderline is the T3 again. For small T3, like this, I would say there is no problem in making a transoral supraglottic laryngectomy, but when the tumor fills the entire preepiglottic space, encroaching the hyoid bone, encroaching the thyroid membrane, the upper half of the thyroid cartilage, then complete resection in free surgical margin through a transoral approach, in my view, is very difficult. And in lesion like this, you may risk to have a positive margin at the level of the hyoid bone, a positive margin at the level of the prelaryngeal muscle, and of the perichondrium of the thyroid cartilage. So again, in these lesions, my suggestion would be to proceed with an open partial laryngectomy if the patient is fit for that, or to total laryngectomy if the general condition of the patient are not good enough. And for example, you don't trust as me that a lesion like this could be treated by chemoradiation, because I've seen, as most of you, patients like this, that to avoid the total laryngectomy as a first treatment, being treated by chemoradiation with usually persistent disease, and therefore the need for a large procedure later on after failure of chemoradiation. Thank you for your attention.
Is that your last slide, Cesare? Is that your last slide?
Sorry?
Is there a last slide?
No, there is no more slides.
No more slides. So we have some time for questions, or we don't conventionally ask a orator to answer. We have one question from Dr. Deepa. She asked the MRI is used to find out infiltration to the vocalis muscle, T2 and T lesion, I presume.
Well, this is a line of study that we are deepening in Italy with the cooperation of radiologists and anatomopathologists, surgical pathologists. This is indeed a very tricky question, because the MRI is definitively better than CT scan, but also tends to overestimate the depth of infiltration due to the presence of peritumoral inflammation and edema that must be distinguished from real tumor. So far, I would say MRI tends to overestimate, and with comparison of our surgical pathologists, we looked at this is so far the rule more than exception, I would say.
You mean that MRI, you think, is overestimates the disease and perhaps prevents you from taking that TLM more aggressively? Is that what you mean?
No, I think that when you're talking about just the vocal muscle, the depth of vocal muscle, if the MRI tells you that, for example, the vocal muscle is fully infiltrated, sometimes you will find indeed that part of that infiltration is not tumor, but is edema. So you have to take away, or however, the entire muscle up to the thyroid cartilage, and then the pathologist will tell you that, for example, infiltration of the muscle was less than half of its belly. And this is a good news. I mean, this is obviously means that that was not a T3 for paraglottic space invasion, it was just a T2B, and so you can spare, for example, neck dissection or complementary radiotherapy to your patient.
No.
Sorry?
Can't hear you. Yeah.
You can't hear me?
Yeah. Yeah, I can hear you. I can hear you.
Okay.
Yeah. I have one more question. What are your indications for second look microlaryngoscopy after a definitive TLM? When you have clear margins, what are the areas that you would tell a beginner to be careful and to have a second look so as not to miss a recurrent or a residual tumor?
Well, honestly, I don't perform a lot of second look microlaryngoscopy when I have not positive margin. That's my first indication. When I've got clear margin and I'm confident that the tumor was well exposed, well removed, and I have no doubt about that, I prefer to make a very close follow-up in order not to miss any persistent or recurrent disease.
Okay. Okay, then one last question is the internal perichondrium of the thyroid cartilage. How do we sample this? And would this be an indication for you to abandon TLM and then go on to open procedure or something else?
Well, the perichondrium is a very important plane. I always peel off from the thyroid cartilage the tumor with the perichondrium if I feel it's very close to that. I never send frozen section on perichondrium because I think it's just made for your mind or for the medical legal issue. But no, there is no way that a pathologist can tell you if the perichondrium is infiltrated or not better than you can do through your microscope when you are looking at the patient. And if you feel that the perichondrium is not safe or the thyroid cartilage is infiltrated, then I'm fully of the opinion that you have to abandon TLM. And if you have prepared your patient to an open neck approach, also you have to shift to that, or wake up him, discuss the issue, and discuss about other options, like, for example, radiation therapy or what else. But you have to at least to stop your thyroid cartilage removal, because in my hands he has never a function, or it's not oncologically sound.
Okay, thank you. I think he has answered most of the questions. I think he's one of those guys who is promoting image with the narrowband imaging as well. Does narrowband imaging help you in any of the decision making in TLM?
Yes, but essentially for detecting the superficial margin of resection,
right,
or
only the
multifocality. Yeah,
right.
Not in the depth.
Not in the depth. Thank you, Cesare, for a wonderful talk. And I think if there are no more questions, I would like Dr. Sudhir or Dr. Alok Thakkar to thank the orator for having delivered our teachers, Dr. Professor Sudhir Bahadur's oration, and say a few words before we say goodbye to Cesare. Over to you, Dr. Thakkar or Dr. Professor Sudhir Bahadur.
Sir, he is going to be here for the panel discussion also, so we'll do the formalities after the panel.
Okay. So then I will sign off then. Is that all right? Or am I still to be in the panel?
To invite the next speaker.
Yeah, please.
Professor Jones is there.
Yeah, go ahead.
So the next talk is by Professor Jones, TLM for the base of tongue, when, why, and how. Over to you, Professor.
Thank you very much. And it's a great honor and joy to be back with you today as well. I'm hoping that you can see my slides now.
Yes, we can see. We can see.
Okay,
yeah, please go.
So as you've just pointed out, I was asked to prepare a talk that was entitled Transoral Laser Microsurgery for the Base of Tongue, When, Why, and How. So I have no disclosures apart from the fact that several slides that I will talk to have been created by my very good friend and colleague, Mr. Jeffrey Lancaster. So the first question is when. So there are probably two situations that you might consider transoral laser microsurgery for the base of tongue. And one would be a primary resection of a tumor, which I'll talk to in much more detail. And then the other more common approach, particularly in the context of human papillomavirus positive oropharynx cancer or base of tongue cancer, would be in the workup of the diagnosis of carcinoma of unknown primary, which I won't talk to any further today. So the first thing to consider is probably size. And I personally think that the considering TNM status at the moment in this context is probably particularly unhelpful. I think a clinical examination where you actually are able to palpate tumors as well as taking into account the preoperative imaging is particularly important before you decide to embark on transoral laser microsurgery base of tongue carcinomas. This image is just an illustration of where you can fall foul of imaging. I think everybody would agree that if you eyeball this tumor prior to surgery and relied on the imaging, you would suggest that this was actually inoperable. And in fact, this tumor ended up being eminently operable because it was actually just adherent to the lateral, the tonsilloglossal sulcus by a little stalk, basically. And so all of this was massively exophytic. And so that's a prime example where you can get caught out relying totally on imaging alone. So my mantra is therefore take note of the scan. You obviously have to do a scan and take note of it, but don't rely on it exclusively. And therefore that brings us back to our well-versed cliche of treat the patient and not the scan. Access is another issue, and Cesare has just talked to that very eloquently related to the larynx, and the same applies with the base of tongue. Access to the base of tongue is often tricky, and you need a 3D appreciation of what you're actually doing. But sometimes it's actually completely impossible to get a sensible approach to the base of tongue. And I suspect, although I have no experience on this, this is where transvaal robotic surgery comes to the fore, because access to the base of tongue to resect some of these tumors is far, far easier with the articulated arms related to transvaal robotic surgery. Particularly when you take into account access is prominent incisors, retrognathia. You've got a line of sight issue with the laser relative to a transvaal robotic approach, which I'll talk to later. And resecting base of tongue tumors with a laser is not not for the inexperienced. There's a really significant vertical learning curve prior to becoming able to do this, and in truth that then ends up putting quite a significant number of surgeons off, and they don't adopt this as part of their routine practice. I think you have to take into account the patient as a whole, not the tumor at the base of the tongue, and therefore you have to take into account laterality. And by most definitions that are accepted, is that any tumor that arises from a midline structure, which includes the base of the tongue, is a non-lateralized tumor, and therefore you have to take into account how you would treat the contralateral neck as well as the ipsilateral neck. And that might influence your treatment decision-making process, but it's an important thing to take into account. So I guess then we move on to why, and why is that it's possibly, it's demonstrably useful to do. So I spoke to these data. These were our first 264 cases of oropharynx cancer that we managed with transvaal laser microsurgery. 3/4 of this group were, or 2/3 of this group rather, were HPV positive. So it's a mixed cohort. And as for reasons I've said yesterday, most of these had postoperative radiotherapy rather than postoperative chemoradiotherapy when that was appropriate. And we showed survival outcomes that for the whole group that were comparable to anything else that had been published with any other treatment modality, with very high levels of local regional control, around 91% at 5 years. And once again, we demonstrated that the HPV cohort did significantly better than an HPV negative cohort. So for the purpose of this talk, if we pull out the base of tongue cases, there were 61 base of tongue cases in that cohort. The vast majority were T1, T2, and T3, with the majority being T2 cases. But this comes back to the point I made originally, is that to rely simply on a classification of T1 to T3 is unhelpful, and that there would be T3 tumors, as I pointed out in the previous scan, that would be amenable to transvaal laser resection, rather than simply taking the point it's T3, therefore we don't do it. There are T2 tumors who you may also choose not to do as well. And when we look at the survival data from this, these two are mirror the larger part of the cohort. The overall survival, disease-free survival, and disease-specific survival all remain high in this base of tongue sub-analysis. And when we look at HPV versus HPV positive versus HPV negative, we also see a split out when a significant split out, significantly different split out when we look at HPV positive versus HPV negative patients, with the HPV positive patients doing far better. So no surprises there, but this confirms that transvaal laser microsurgery for the base of tongue is probably not an unreasonable thing to be doing. But once again, I come back to the point I made yesterday, is to really confirm its utility in the management of these patients. We need a randomized controlled trial, which is ongoing, as I explained yesterday. So I guess then how? So you need a laser and you need a microscope that is fit for purpose to allow you to access the oropharynx and base of tongue. And we use the purpose-built Steiner transoral laser tray. And whilst you've got closed scopes, which can be used to access, you usually end up using a mixture of closed scopes and open bivalve distending scopes. These are the workhorses, at least to start with, whether it's short or long. And some of the trickier places to get to, you may well end up using a closed scope route. So it's technically tricky and technically demanding. You need an array of grasping forceps and diathermy forceps, because bleeding can potentially be an issue. And that's aided and abetted by using suction monopolar diathermies down the endoscope to bleeding. This is the setup we use. We use a suspension laryngoscopy setup, which anchors everything down. This happens to show an FK gag. It's very rare in my hands to use an FK gag to do a transoral base of tongue resection, but rather than the FK gag, you would have the Steiner scopes set up accordingly. But again, what makes a resection difficult? So I've already alluded to the fact of access and getting a view, and then the real issue is distinguishing what is tumor and what is not tumor. And that's probably not a trivial exercise. You've seen this diagram before, and what you've actually got here is a demonstration of line of sight coming down into the mouth. And you actually, this is a typical image that you would get, that you would see the proximal end of the tumor. So you have to have a 3D visualization as to how you deal with this. And obviously the whole technique of a Steiner resection relies on a planned transtumoral resection. And this is best illustrated by these series of diagrams, I think, because this is difficult to demonstrate. But this would be the view from the cranial aspect of the endoscopy, where you see the proximal end of the tumor. You have to be really clear that margins are less distinct, particularly at the base of tongue, because there's significant amount of lymphoid tissue, which can be confusing, particularly to the inexperienced. And one of the ways that you assess the depth of this is to make a transtumoral vertical craniocaudal resection in there to define the depths of your tumor. You have to be clear about margins, so you have to have that 3D appreciation as to how far you make these cuts, both lateral mucosal cuts and deep intramuscular cuts. And as I've said before, the depth of invasion is assessed by the transtumoral transection or resection. So this is another representation. This is a bigger tumor, but it demonstrates how you take, quite often you take a transtumoral approach to take the tumor out in planned sections from a proximal to caudal, proximal to distal arrangement, and you'll take it out in 2 segments. And the next part, so once you've removed that, you take the next part, and then you take the final part. And in all of these cases, you're getting more exposure as you take these more proximal areas away. And this is what people become very, very uncomfortable about when talking about this technique. Cutting through tumors was initially, and to a certain extent, some people still consider it as surgical heresy. And in all of these situations, you have to be really clear that you're getting appropriate margins to resect this. And the final point is, how do you assess completeness of resection? So you've got microscopic visualization, which is probably the least helpful part of this in my experience, although it can be helpful to see the surface aspect of the tumor. Laser cutting characteristics are important. When you do this technique, because you're pulling on the tumor, you actually get a haptic feedback. This is not just a visual approach. So laser cutting characteristics, where cutting through a tumor is harder than cutting through non-involved adjacent tissue. Narrowband imaging, I have very little experience of this, but as Cesare said, that probably helps with defining the superficial extent of this tumor to a certain extent. There's the issue of intraoperative frozen sections, which we don't use as a matter of routine, but a point of discussion. And then in the time-honored way of this technique is the use of marginal biopsies, which would open up a whole other discussion. My personal view is that they are of limited use, and we often just take them to reassure our colleagues in a multidisciplinary team meeting that we've done something sensible, but in reality, intellectually, they're probably indefensible. The point I made yesterday in my talk is that we could spend hours and hours talking about surgical margins here, but we need to remember that surgical margins are surrogates of outcome, and therefore it's incumbent upon us to measure outcome. And if our outcome is correct, it's likely that our surgical margins are correct. That was probably all I was going to say at the moment about this technique. There's many things to discuss that maybe we could come back to later. I was going to show you a short video, but I don't think that's going to be stable enough on the platform that I have here available. So apologies for that. Thank you very much.
Was that your last slide, Professor?
That was my last slide.
Thank you very much for the very eloquent lecture. I have one or two questions, if I may. We were told about the differential carbonization pattern when you do transtumoral cutting in larynx. So you go on until you get a area which is the laser reflects as non-tumorous. Does the same thing apply in the base tongue, because the tissues are something somewhat more different, and it can be kind of confused with the lingual tonsils, the architecture of the lingual tonsils. So this is one question, and the second question is, do you use Liga clips or any intraoperative methods to control the hemostasis? And if so, what have been your incidence of serious postoperative bleeds? Is there a protocol for this? Do you keep the patient intubated in the ICU for a variable period? Would you like to share your expertise in this direction? 3 questions.
Yes, so really good question. So to take the first question is that I think this issue of differential cut-in patterns in the base of tongue could actually be even more important because of that discrimination between the lingual tonsil. So what you actually find is that when you cut through tumor, you get a significant amount of charring, and you probably have to use more power. But when you actually get into the tongue musculature, it's like dividing butter. Basically, it just makes it so. And then there's actually a similar cutting characteristic with adjacent lymphoid tissue, in the fact that adjacent lymphoid tissue cuts far easier than tumor as well. But what I'm probably trying to get over here, which is sometimes difficult to explain, is that you're not relying on one thing. You're actually relying on several things here. You're relying on optics, you're relying on the cutting characteristics, you're relying on haptic feedback from actually what this tumor actually feels like. So it's not a simple technique and that's why people become uncomfortable when either doing this or talking about this. Going on to your second point, which is also highly valid. So in our series, we reported on, so in the very early part of our series, we unfortunately had a day 8 bleed where the patient didn't survive in a recurrent case, which wasn't reported in this series. So we revised what we were actually doing, and so in answer to your question, what we use is a combination. So it would be monopolar diaphragm for fish bleeding. If we identify intermediate sized vessels, we would use Liga clips or a Liga clip applicator. But actually, more importantly than all of that, I think, is the fact that we, at the time that we would do a neck dissection, we would actually ligate either the branches of the external carotid artery feeding the base of the tongue, or we would actually ligate the external carotid artery above the superior thyroid artery in total. So what we found when we started doing that, we had a single percent level of bleeding, but when we started doing the external carotid artery ligation, our severe hemorrhage rate to date has dropped to 0. So we don't use covering tracheostomies. We don't, patients are usually in hospital dependent on the size of the resection, actually more limited by the neck than the base of tongue, but determined by the swallowing outcomes is actually, and pain levels is actually, they're in for a day or 2 afterwards. usually.
There is a question, how do you define optimal margin? I think you made that evident in your last statement, saying that outcomes are what define the success of a procedure. So how long, Professor, do you wait before the outcomes? If your histopathology is, what sort of margins are you looking for in PACE-Tung, in other words? And would you be satisfied with histopathology, the final histology, or would you like to use frozen section?
So we don't use frozen sections. There's two reasons for that. One is, in our institution, they've proved logistically difficult to use. But actually, the point is that I'm not sure how helpful they are, because we've had, when we did use them, we've had a couple of occasions whereby the frozen section report was actually refuted when a formal report was actually made. So we don't use it as a matter of course. I think the question of margins is, as we say, is a really important one and could fulfill the rest of the day's discussions. The trial I discussed yesterday was the international trial I lead, called the Pathos trial, which is actually addressing exactly how closer margins we can get. Now, this leads us into another area of the philosophical differences, as I understand it, between transoral laser microsurgery and transoral robotic surgery, where you do much more standardized procedures. Now, the reality of the transoral laser microsurgery is that you are attempting to get closer margins to avoid taking adjacent normal tissue. And the only way to address that, certainly the only way I can think of addressing that, is actually to randomize patients on the basis of their margins, or take in that risk stratification, and then to simply check that the actual outcomes are adequate and appropriate. So the retrospective data that I just showed you in the presentation shows that as far as things go, it looks as though this is entirely safe. I know, for example, that 3/4 of the patients who we would have resected in that base of tongue would have a margin around the main specimen that was less than 1 millimeter. So we've designed that as R0 high risk, for obvious reasons. But that doesn't seem to translate into a poorer outcome. Bearing in mind that we always have to, these, particularly in HPV positive cases, that the event rate, i.e. recurrence and survival, is actually low in these patients. So to demonstrate definitive harm or benefit, you have to have significant amounts of patients in trials to be able to do that.
Thank you, Professor. I think you answered some very difficult questions on an area which has been less explored with laser, that is the base tongue. I think it's really, time alone will tell whether we could try and use the laser more than the robot, because in India, the cost is a real problem. And you're well aware that the robot, Da Vinci robot or any other robot, they are 10 times the cost of a very high quality laser total equipment. So I think in India, maybe it's this and other area, which I think a gentleman from Madrid, he uses it using the ultrasonic Thunderbolt applicator. And he has also given a very elegant presentation last year, I think. And his results are somewhat emulate what you have been sharing with us. So thank you very much, Professor Terry Jones. And on behalf of the foundation, I'd like to thank you, and I hope that you will come to India after the pandemic is over and be our traveling professor and visit various centers where we train people in head and neck. Thank you so much, sir.
I'd be delighted. Thank you very much.
Previous.
So Dr. Jones is also part of the panel that will follow these talks, of course.
Gurmeet, can you take off that slide?
Sometime, yeah. We'll watch it for some time. In the next talk. Yeah, take sun.
He takes medicines all of it. Yeah, Pala. This is the living at look at the yeah, that's my level. It's like this. At the end of this, we can find out how it's improved. Then we can either continue or stop. 0, 0, 1. After. Magiri. Yeah, Ashok can get like that. No, next get that. Yeah, Madium to it. Cryptomodel pregnancy 001. Yeah, mentata. Wait. Mentata 101. Ayurvedic.
Yeah, yeah, Sakani Sanjay. Those ansangilla. The phone arrive on the food to the Lamma.
Wait, gastric problem was the
Thanks, Mataja.
Shall we move to the next talk? Dr. Nebu?
Yeah, we can go to the next talk. Professor Fhno, can you invite the next person?
The next person is am I the chairperson? Because I thought there was somebody else as well. Am I the chairperson?
Yeah, sir, you are the chairperson.
Okay, sorry about that. So it's my privilege to invite Professor Kazuhiro Omura from the Jikei University School of Japan, and he will be giving us his talk or share his experience with endoscopic approaches in sinonasal tumors. Dr. Omura, over to you.
Hello. Thank you very much for inviting me. Yeah, I was surprised. My photo is completely changed. But anyway, so I will start my talk.
Please.
Yeah, hopefully, can you see my slides?
Yes, I can.
And hopefully my operational movie works well. So my name is Kazuhiro Omura. I would like to talk about anterior skull-based tumors, and especially resection and reconstructions. First, I would like to introduce the Jikei University, Japan. We are the first ENT department in Japan, founded in 1892. And our operational numbers, this is actually the numbers for CRS and the highest in Japan. And also the sinusal tumors and the malignant tumors, the number of the cases is also the highest. And I'm the how to say, the chief for sinusal tumors surgery. For example, this is my 1 week schedule operations. On Tuesdays, we did anterior middle skull-based resections. And on Wednesday, maxillectomy. And Friday, anterior skull-based endoscopic resections. And also the Thursday, the pituitary adenoma and sinus tumor, something like that. So I'm pretty much focusing on surgery. And today, actually yesterday, the day before yesterday, I talked about these novel technique that I published as new techniques. But today, I would like to focus on the most latest articles about the anterior skull base reconstructions. Of course, the purpose why we use the endoscopy for the sinus tumors, it means a minimum invasive but sufficient resections. And a minimum invasive means less facial incisions, less complications, and less limitation after surgery. It means the patient does not have to stay on the bed. So even the anterior skull base surgeries, the patient can walk just one day after surgery and also eat. There are no limitations. And also sufficient resection means the margin-free resections, of course, and also unblocked resections. And the strategy, how to select the approach to the tumors, the site of the tumors, this figure is very similar for our approach. So I put this one. And the tumor involves skin, bones, frontal bones, orbit. It means the soft tissue invasions. Then we add the open surgery. But in addition to the open surgery plus endoscopic. So actually all of the tumors who invaded to the soft tissue, but we add the endoscopic resections. So, and talk about the reconstructions, and we do our original techniques for the reconstructions. And now this is an impress to the operative neurosurgery. And I will talk about this in detail. And basically about complications of the CSF leak and meningitis is still 5%, 1.5%. Still we worried about these kind of the complications. But if you follow our techniques, the ratio of the complications becomes 0. So we never face to the CSF leakage and meningitis, something like that. And our way of the reconstruction of the skull base is this. And yesterday, the day before yesterday, I also show our operational videos. And this is the illustration explanations in detail. So this is the dura here. And this is a skull base. And firstly, intradurally, as the first layers, I put fascia lata intradurally, and also the suture 11 points with dura mater. And extradurally, we put fascia lata again, and also as a rigid reconstruction, we insert the cartridge with parappendicular plate. And for the fourth layers, we use a pedicle flap. So I will explain them. I will show my movie. Hope it works very well. After the tumor was resected with unblock fashion, of course, we resect the tumor, unblock. The anterior skull base defect is seen. An incision is made on the anterior side to fix a falx, marked with a dotted line to indicate the orientation. The fascia lata is inserted under the dural defect and sutured to the dura with 5-0 vicryl. Suturing is started from anterior edge. "360-degree closure by suturing 11 points around the defect was completed within 60 minutes. A fascia lata is inserted extradurally and fixed with fibrin glue. A septal cartridge with perpendicular plate is hooked onto the bony defect for the third layer. A nasoseptal flap and superior lateral anterior pedicle flap is used for the fourth layer. This is an endoscopic view of POD6. No complication occurred, and both pedicle flaps covered the defect nicely. So this is the videos, and we correct the data as the time limitation. I skipped a little bit faster, but we correct 59 patients. And this year, actually, we also have over 20 patients. So totally, the numbers of the patient is around 80. And still, we have no CSF leakage and no meningitis and no major complications after surgery. And the time for the suturing, when I showed this technique, even to the Japanese doctors, they asked me why the 11 points, you need 11 points, and how long does it take for suturing. So I correct the data, and basically the average time is 44 minutes. And the fastest is 25 minutes. But recently, we started this kind of techniques 3 years or 4 years ago. And recently, our techniques is much better. So basically, the average of this year is just 25 minutes, something like that. So within 30 minutes. And the second and third layers is not so much time wasting. And also, some doctors said, oh, why you covered the pedicle flap as the last layers? And we also published the data, and we compare the functions with free flap versus pedicle flap. So because some doctors put the free flap on the defect areas, but it is quite different about the physiological functions. And pedicle flap definitely better than free flap. So if you are interested in this this result, please check the laryngoscope to 2020. And when we also have a chance to combine with neurosurgeons. And this is our operational theater. And even the neurosurgeons do the microscopic operations, but we also stand just next to the neurosurgeons, and we also use the endoscope. And I don't want to talk about in detail, but only the one most important thing is we try to share our surgical monitors. So even endoscopists, ENT doctors also want to see the neurosurgeon's view, like this one. And the neurosurgeons also want to see the endoscopic view. And we share our operational landmark. And this is also the tumors embedded to the falx and also intracranially. And for this kind of the tumors, we do the combined surgery with neurosurgeons. And this is the tumors, the specimen after surgery. The tumor was very nicely removed as unblocked. And the point is the green one is the neurosurgical part. And the yellow lines, dotted lines, is a ENT part. And the red arrow, that point of the red arrow is important areas we have to do together with each other. So this is the endoscopic view, right side, the intraorbitally. This is the, how to say, the lamina papillaceae of the right side, and I drill out. And you can see, this is a neurosurgeon's view, and we drill the bone. Then our neurosurgeon also find, oh, you are here, something like that. Oh, then a neurosurgeon drill and enlarge the bone. So if you share the operational landmark with each other, that is very, very effective and also quick. So neurosurgeon do the drill, and this is a frontal sinus, and even this is the left side of the orbit. This time the bone is a little bit thick. At the time, this is a neurosurgeon's view. The ENT doctors light up the areas. Then neurosurgeon understand, oh, you are here. So neurosurgeon can drill and widely opens. This is a posterior ethmoidal artery. This area is a little bit difficult to drill from the neurosurgeon's view. For example, this is a neurosurgical view. They are hard to see the tip of the drill. So at that time, we talked, the tip is, here is better, here is good, something like that, bad, something like that. So we talked each other during the surgery. Then we can remove the tumors safely and quick and very nicely. And also this is the last part of the slide. Even these tumors, very big tumors, and elevated intracranially, after resect the tumors, we have to put the big fat and with flip flap by a plastic surgeon. And the plastic surgeon sometimes have a difficulty to suture, to fix the flap into the into the nasal cavity. So this is a 0-degree endoscope, and this is a sphenosinus, this IC, and the plastic surgeons put the flip flap into the nasal cavity, and then we ENT doctors sutured the flip flap into the nasal cavity. This is IC, and we would like to cover the IC with a flap, so we sutures like this. If the plastic surgeons try to suture into the nasal cavity, they can suture only 1 or 2 points. But if you use the endoscope, you can suture 8 points, 10 points, and very quickly. And then after that, cover the pedicle flap. Yeah, right side of the middle turbinate, inferior turbinate, and 5 weeks post-operatively, very nicely healed. And of course, no complications. Yeah, so if you can use an endoscope very nicely, then we can do the minimum invasive but sufficient resections. So thank you very much. Oh, mute. Please. Dr. Paul Fhno, you are muted. you are muted. Yeah.
Can you hear me now?
Yes.
Your presentation was very highly appreciated. And there's a question, how do you train your residents or fellows for performing the dural suturing?
Well, actually, I have a team, a skull-based team, and the members, and we have 6 members, but 4 members is a sergeant, and all of them can do the suturing. And the dural suturing is not so difficult. Once you can understand the basic techniques for the suturing, then actually not so difficult. So we have simulators. Now I'm making the simulators for the suturing, and also we have we do the septoplasty, and after the septoplasty, I also doing this suturing, and then my young doctors also do suturing. Yeah, so they are very young, three years as ENT doctors, 5 years as ENT doctors, but they can do the suturing.
Okay.
Yeah.
Thank you. I have one question. Is when you get a dural transgression, you do a omula 4-layered closure. The innermost layer you put is an underlay technique of a fascia lata, which you suture 3. Is it underlay? And over that you put cartilage, and over that you put mucosa. Is that the way you go ahead? The fascia lata is intradural.
Exactly.
Okay, thank you. And you didn't have any leaks. You had less than 1% of ascending infections.
No,
you didn't have, and obviously because your closure is absolutely meticulous, so it's watertight, and there's no scope for any infection. What about radiation therapy? What are your indications for radiation therapy after cranioendoscopic resection? What are your
Thank
indications?
you very much. Thank you very much. So, if for example the olfactory neuroblastoma, the patient of the olfactory neuroblastoma, then the tumors goes into the cranially, and also the pathological diagnosis and Himes grade 3 over Himes grade 3 and 4. Then we add the radiotherapy, and also of course the margin positive. Yes. Margin positive and the piecemeal resections is definitely I add. Even the Himes 1, 2, Kaddish A. But if I do the piecemeal resections or margin positive, then I add the radiotherapy. But if even I resect the complete resections, but the Himes 3, 4, and Kaddish C, then I add the radiotherapy.
How many is orbit removal also possible with cranioendoscopic exposure? Because it improves your space for you to attack the bottom part of the anterior skull base. So removal of the eye can also be undertaken with this minimal invasive approach.
Yeah, so if the tumors goes into, we also have a tumor board, and we always discuss about the tumor board, about the approach. And if the tumors comes into the intraorbitally, then basically we remove the eye, but combined with the endoscope. Yeah, so hopefully I want to preserve the eye, but we cannot, we cannot control. Yeah, margin positive is a very poor prognosis.
Yes, I agree with you. So we will now go on to the panel, and I invite Dr. Shamit to take over from me And over to you, Samit. And please invite the panelists and go ahead.
Thank you, sir. And thank you for being kind enough to chair this session. And thanks to Fhno as well for bringing all of us together from all over the world. I'll be sharing my screen. At the outset, it's a privilege to be associated with the session that is eponymous with one of our great teachers. It's an honor, of course, to moderate the panel discussion. Can I request all the panel members? I think I saw all of them in the attendees. Can I request all the panel members to be available and per their discretion unmute themselves? Please make yourself visible. That would be my request. Great. And as we start talking about this, the session, of course, which has been highlighted by our 3 great talks is fine-tuning minimally invasive oncosurgery. We've had 3 great talks, and again, chaired by the ever dynamic Dr. Fhno, and our international speakers have been there. We do realize that this is the last session. We want to make it a great one, and we want to have great interaction between all of us. These are our panel, very august panel, Professor Piazza, Professor Jones, Dr. Omura, Professor Tai, Dr. Sharan, Dr. Deepa, and Mr. Jose. I think the chairpersons, probably Deepak is there, but since he's one of the organizers, I can imagine that he would probably have other commitments as well. While we start out, it's important to realize that when we drive a technology-driven symposium, there is also something that I found not in medical literature, but in biomedical literature in general, about technology improving outcomes. And when we talk about technology per se, we talk about this having all these features, and some of you might not agree, some of you might want to make some changes, but I thought it was probably pertinent as we try to push the envelope in minimally invasive oncosurgery and how head neck oncosurgery has developed over the last few years. And this is what we have. Of course, when we talk about minimally invasive, it is all site specific. We've had great sessions already throughout the conference from august speakers, panelists, moderators, attendees, chairpersons who've shared their perspectives. This is how I choose to divide it. These are how the sites can potentially be extrapolated, and it's a huge topic. It would probably, a 1-week meeting would not be enough to justify the challenges and the advances and the exciting innovations that minimally invasive oncosurgery offers us. But for the time being, drawing on the strength of our panel faculty, and also trying to make sure that we are able to do justice to each of their expertise, we decided to focus on these topics. We are going to talk in sequence about margins in transoral surgery, and that includes robotic and non-robotic approaches for oropharyngeal cancer. We will talk about surgical organ preservation in bilateral glottic disease. And again, we have Dr. Professor Piazza's great talk as a lead up so that we can probably talk a little bit nuanced. And as we go on, we want to know our other panelists' approach towards the second look microlaryngoscopy as well, because that is a topic that is so literature deplete, all literature conflicting, that we need an answer on that. We will talk very briefly, drawing on Professor Tai's experience about remote access thyroidectomy and how he selects his approach. And we'll be focused on that only. And in the end, again, drawing on Dr. Omura's talk, we'll probably talk a little bit about what his cautions and pitfalls are in endoscopic skull-based surgery. We saw great surgical treatises. We will not be focusing on technique. We'll only be talking about his pitfalls. Talking about the margins in transoral approaches, it's important to know that the oropharynx actually lends itself to most of these approaches now. As you can see, that be it TORS, be it TLM, TOLS, endoscopic, or even the non-surgical approach, there is an equal play between surgical as well as non-surgical oncologists as we try to tackle this site, which is anatomically complex, yet exciting in terms of what it has to offer. And when we talk about the limitations to analysis, remember, we'll only be talking about margins in transoral approaches for oropharyngeal cancer, drawing on Professor Jones' talk as well, and also moving a little forward. There is always going to be a surgeon bias in terms of selection of approach, deciding what margin is to be taken. And again, in literature conflicting scenario, we don't really have a lot of answers. We'll try to find answers, drawing on all of your experience. And a comment that is specific to India, we'll be talking or extrapolating from HPV positive literature in an HPV negative predominant region. Most of us know that in India, the vast predominance of oropharyngeal disease is HPV negative. And this is something that we have to realize a limitation as we move forward. What about the evidence? We know it is sparse, pertaining specifically to margins in oropharyngeal cancer. What we will be talking about is robotic, and that we'll talk about all transoral approaches, and then again, draw on your experience to find an answer. And we know that local control disease decreases with positive margins. So it's an important point. It's worth discussing. It's worth bringing up in a panel like this. We know also that HPV-associated oropharyngeal cancer is a different ballgame. But the problem is that there are no randomized control trials in the pipeline for chemoradiation versus TORS in the cancer that we see in India, which is HPV-negative oropharyngeal. And this is the pipeline. We have randomized phase 2 trials, single-arm phase 2 trials, and we'll also be talking about randomized phase 2. The problem is that we don't anticipate a lot of help from upcoming evidence. So we'll rely on our experience, and this forum is a great tool where hundreds of surgeons who are exposed to transoral approaches to oropharyngeal cancer can probably take a take home based on their margin philosophy in the disease. With that mindset, let's move forward. Question, we'll start with and again, this is in no particular order, but we'll be drawing on the strengths of our doctors in terms of what they practice to be able to take it forward. So question for Dr. Rajiv Sharan, please unmute yourself if you haven't done so already. Do you think that survival in TORS, specifically for early oropharyngeal cancer, is affected by margins, and do we have enough evidence to support
that? So there are conflicting studies are there. And some studies have shown that if your deep margin is positive, then that definitely affects your survival. But if superficial margin is it is positive, in that case, that may not be relevant in TORS, especially for early oropharyngeal cancer.
So agreed. Literature is conflicting. We don't have enough data on early oropharynx. Most of these studies have been single institution, single author driven, and they've not really relied too much on margins as an absolute endpoint. As Dr. Sharan mentioned, as we move forward in the spectrum, as we try to get more advanced in managing oropharyngeal cancer transorally, again, alluding to Professor Jones's comment about a tumor which might be considered borderline resectable, but is still amenable to transoral resection. It's important to know that currently we don't have enough evidence that survival in early oropharyngeal cancer, HPV associated or otherwise, is influenced by margins. Another single institution study only alluding to positivity rate without it having an implication on survival. Professor Jones, you talked about TLM, and you talked about TLM in the age of TORS, where we typically use the robot as often as non-robotic approaches for resection of oropharyngeal cancer. Based on your experience and based on your understanding of what's been published and what's available in the medical domain so far, do you think we have any consensus on what approach should be preferred, what transoral approach should be preferred for oropharyngeal cancer?
Okay, so just going back a little bit to the issue around margins that you've got of the data that are available, I think what is increasingly clear from our data and from otherwise is that we can only have these discussions about close margins in the context of HPV disease. The evidence that's available is if you're dealing with HPV negative disease, then to have close margins, I think the data are becoming increasingly clear that you should be aiming for 5mm margins or extensive margins, but we can only have this discussion about closer margins around HPV positive disease, which is an important point.
Yeah, we'll get to that, of course. Hit nail on the head. We know that HPV negative disease does not have a correlate with margins, and therein survival as a result of an invaded margin. Have you realized over the course of your decades of experience as to whether, subjectively speaking, a particular approach is better than the others when you talk about resecting oropharyngeal cancer? We have some studies here, a couple of meta-analysis.
Yep. So I don't think there is a consensus. I don't think there is a consensus about transoral resection of certainly base of tongue, if not oropharynx cancer anyway. I think where this becomes again nuanced is that of the people. So my declaration is I have no experience with robotic surgery at all. My experience has all been transoral laser microsurgery. But obviously now there are increasing numbers of people around who've been dually trained, and I talk to them and listen to them. We could talk about the philosophy of the different approaches, but what what seems to be a consensus is that for a tonsil tumor, except in the different philosophy, it doesn't matter what you use. Some people prefer transoral laser, some people prefer transoral robotic. For a base of tongue, I would concede, it seems to me that to do this with a robotic approach would be the obvious way to do it. We could get into a different conversation about the extent of the resection, but it is just going to be far easier because of the optics and the articulation, as I said in the original talk. So, answer to your question, I don't think there is a consensus. I think people are driven by what they've got in front of them. But actually, common sense would dictate that transoral laser microsurgery for lateral oropharynx is perfectly reasonable. For base of tongue, it's harder, much harder, but doable. And therefore, consensus would drive robotic approaches, particularly towards a base of tongue approach, I would have thought.
Thanks for sharing your experience. The last 2 slides pertain to all transoral approaches, and I'm glad to see you reinforcing the comment that literature already has on us, that we don't have a preferred approach currently for transoral resection. Professor Jones gave us some idea on what approach to use in preference to what, depending upon the subsite. But, kind of arguing both ways, when we look at robot-only literature, and we'll come to that slide as well, we do have evidence that base of tongue, quite ironically or paradoxically, has a higher margin positivity rate with TORS compared to tonsil. Now, that could be not just subject to the fact that we have great 3-dimensional visualization, but we also have an anatomically more complex or a more heterogeneous subsite, so to speak, compared to the defined anatomical levels that the lateral oropharyngeal wall has. But again, a topic that we'll be discussing shortly as well. Dr. Deepa, I don't see her picture. I hope she's here. Yeah. Yeah, great. Hi. So when we talk about preoperative consideration, of course, preventing a positive margin is the most desirable thing. When we talk about preoperative considerations, what tumor of the lateral or the mid-oropharynx would typically concern you with regard to margin uncertainty?
Okay, so let me take it in both 2 ways. When you're talking of lateral margins transorally, we're talking mainly of tonsillar tumors. If anything is involving the soft palate more than 1 centimeter, it's really not a surgical disease, because obviously the functional morbidity of extensive soft palate resection is going to be much larger. So when we talk of tonsil, which is involving the soft palate less than 1 centimeter, my concerns mostly are going to be the deep margin. And that's because beyond the superior constrictor, you have the parapharyngeal fat, and really you're limited by anatomy in getting very deep margins. So if I have a T3, a larger tonsillar tumor, which is involving the parapharyngeal fat, that would be my preoperative concern for lateral oropharyngeal resections. And when we are talking about base tongue, again, if the depth of the tumor is going more towards the anterior tongue, crossing midline, of course, I would offer TORS mainly for lateralized base tongue lesions. But if it's going much more anterior, or I feel the depth is going to go very close to the hyoid or into the preepiglottic space, then again, I will be concerned that my margins out there are going to be close. And I may have to think of whether I want to do a combined approach or think of a non-surgical option in these patients.
Thanks for a great encapsulation, Deepa, as always. Again, borrowing from Professor Jones's comment about when you're doing a lateral oropharyngectomy, the dogma of a margin is probably something that you don't follow as much as the quality of the tissue forming the margin. Speaking specifically about margins in transoral surgery, of course, that becomes a very important point, as Dr. Nair has just pointed out. Professor Tai, you've trained a lot of people in robotic surgery. One of the ways in which we think, and this might be a little philosophical, but when you talk about preventing a positive margin, the best way to do it is potentially to train your residents and train your senior colleagues in such a way that that can be worked. Can you just give us in a minute your philosophy on training in robotic surgery to be able to get the best outcomes that you can have?
Yeah, actually, it's training as robotic surgery. We need step-by-step procedures. First, that they need to familiar with anatomy of inside to outside anatomy, and also they need to dry lab and move to some kind of animal lab, and finally try to human patient. So in that case, we need step-by-step kind of teaching and securing of the procedures.
Okay, great. So we put an algorithm here, and again, given his experience in, I believe, a couple of decades of robotic surgery now, training residents in robotic surgery of the thyroid, potentially the same rules or the same philosophies would apply. But of course, there's so much more that needs to be done in robotic training. All of us need to potentially pool our resources to decide what is the minimum number of cases proctored, what are the credentialing, what are the privilege extent. And I remember my time as a fellow, and this is more than 10 years back, when we were talking about setting a number. I believe it's not still being set, even though there are certain organizations that are doing a great job. But I believe the best way to avoid it is to lend the necessary expertise from the seniors to make sure that everyone has a good chance of operating transorally safely and does not just jump into it simply because it seems the minimally invasive approach to do. Professor Jones.
Amit, can I just interrupt when we're talking about training?
Of course, yes.
I think one wonderful resource Da Vinci has is the simulator, and trainees should spend time on the simulator doing the exercises. It really improves the hand-eye coordination, and till you are adept in doing that, it's difficult to do that without really using the ergonomic advantage of the robot. So the simulator also should form a part of the algorithm whenever available.
Absolutely. And, I'll share our brief experience. Before we became a robotic institution, we had the lab trainer, and the lab trainer actually opens a lot of avenues open to a lot of otolaryngologists like us. And then before the robotic surgery, you try to do, for instance, in thyroid, you try to do remote access without the robot. So those two tools are available in most institutions, whether they're preparing to become a robotic institution or whether it forms part of resident training. So those could be incorporated equally easily as well. But thank you for your comments. Professor Jones, choice of radiology in oropharynx before you are proceeding with a transoral resection. And is there a particular subsite? I know you partly answered that question, but if you could just highlight what radiology you want and what exactly do you want to ask for when you are considering resecting an oropharyngeal tumor?
Yeah, so thanks. So I think I spoke to this in my talk. So we use MR scanning, and this seems that's just what we've used in our institution. I think, as Professor Piazza spoke to, is that there's a risk of that being too sensitive and that you overcall tumors. But the point that I was making is that whilst we need to look at radiology to take a holistic view of the tumor, that's not just the primary site, but the nodal disease and imaging relating to more distant spread. I think it's critical that it's always augmented with an examination under anesthesia and an intraoperative assessment of the tumor.
Sure. So alluding to a study where a CT was used, and it's not necessarily that a CT would not be used. It's in a country like ours, it's resource constraints. But yes, this study looked at base of tongue versus tonsil. And again, this study also focused on the positivity of the base of tongue margin compared to a lateral oropharyngeal wall, which is probably something that we've been talking about already in terms of Professor Piazza. I remember your time when you visited us and you talked about your early experience in transoral robotic surgery, talking specifically about oropharyngeal cancer and the avoidance of a positive margin. Professor Jones pointed out that HPV negative disease should probably have a different margin than an HPV positive disease. Can you just give us some guidance indicators on what margin to take? Because most of these is extrapolated from TLM literature. Yeah, Professor Piazza, can you hear me?
Yes, I think that the issue of surgical margin in oropharyngeal and at large in head and neck is not well known enough. I mean, and it's curious that in the oral cavity, for example, for standard procedure, you are required to have by some surgical pathologists 1 centimeter free margin, and then 2 centimeter back in the oropharynx. Sometimes you are happy with 2 millimeters or less than that. So there is something that I don't understand fully in this discussion, and honestly, I don't think we should change our concept in terms of oncologic radicality according to the tools we use. So my opinion is that also in the base of tongue and the tonsillar fossa, we should aim at the largest free margin you can obtain. And if you cannot obtain the 1 centimeter margin, then probably it's something that should prompt us to think about the feasibility of transoral surgery for given subsites. If in the tonsillar fossa you cannot reach the appropriate margin towards the mandible or towards the, for example, posterior wall of the oropharynx or soft palate, then in my mind it should be better to make a radiation or chemoradiation. That's just my point of view. I mean, I have obviously no data as anyone to say it's true or not. And different is the situation for the larynx, where clearly at the glottic level at least, because it's a different disease, you may have 2 millimeters margin, but that's because the laryngeal cancer at glottic level has a different biologic behavior. But I don't understand why the oropharyngeal cancer, HPV negative, should have a different biological behavior from the oral cavity cancer.
So great. I think with the words of caution that have been expressed by 4 of our panelists now, we know already the contraindications to proceeding transorally with these patients is deep soft palate, deep lateral extension. Dr. Deepa mentioned that. The chance of getting a negative margin, even in a positive margin in lateral oropharyngectomy, when you have deeply infiltrative disease in the parapharyngeal fat, the possibility that Dr. Rajiv pointed out about the situation in which the early oropharynx cancer might not be influenced by margins, but again, as we go big on the tumors, as we think we push the envelope in resecting them, it's extremely important to realize that prevention of a positive margin, if we think it's not possible based on what Professor Piazza pointed out, it might not be prudent to proceed with a transoral approach. That being said, there is the dogma of the margin, which we follow in mucosal oncology, especially of open surgery of the oral cavity, does not apply here, because we believe that there is 3-dimensional access, there is much better visualization, as Professor Jones pointed out. So we believe that for HPV positive disease, aiming for a margin that's 2 to 5 millimeters is generally considered adequate based on recent literature. And again, a lot of it is retrospective, it has its limitations. However, like again, Dr. Piazza and Professor Jones pointed out, when you get to HPV negative disease, we don't have enough evidence. So till that time, the dogma of 5 millimeter should be followed. Is that probably something, is that a fine summation according to all of you? Any comments on that?
Yeah, so I think I would agree broadly with that. But the problem we've actually got, we haven't defined. We talk about positive and negative margins, but we haven't defined them yet, and that is particularly unclear in the HPV positive context.
Yes, yes. And again, we'll talk a little bit about heterogeneity in literature, specifically pertaining to a transoral positive or a closed margin. But as you correctly pointed out, there is no consensus. There are some recommendations which we'll talk about. Again, this is a NCDB review of transoral robotic surgery alone for oropharyngeal cancer. And you realize that the tonsil has a chance of a positive margin a little less. The T stage, of course, correlates inversely, and so does a high volume facility. These are counterintuitive steps, but it's good to see that they are reinforced. So in the hands of more experienced surgeons with early stage tumors, we know that the chance of getting a positive margin would typically be lower. And again, Dr. Rajiv, having worked in a very high volume institution at your center and having done a lot of robotic surgery and transoral surgery, we do know that a positive margin or the chance thereof is going to be influenced by your specimen philosophy as well. What approach do you have? A specimen-directed approach, a patient-directed approach? And I'd probably want a couple of other panelists to chime in as well as to whether their approach is taking margins from the patient or from the specimen. How do you orient the specimen? Dr. Rajiv, please.
So specimen, like after every case, one team member goes to pathology department and orient the specimen. And specifically, like if we have some concern regarding one margin, we specifically take the margin from that area. And intra-op, if we have some like dot, if we have some dot regarding positive margin, in that case, you resect more and then send for frozen section. If frozen section is negative, then only we close that in the surgery. But if like frozen section for like all suspicious margin, if we are suspicious, we have suspicion that this margin can be positive in the post-op period, in the final histopath assessment. In that case, we take frozen section, and each specimen should be oriented with the pathologist, and depending upon like what margin, concerned margin, that should be especially gross.
Dr. Jose and Dr. Omura, if you treat oropharyngeal cancers, please feel free to chime in about your philosophy as well, because we just want to make sure that we have some kind of a consensus. Dr. Rajiv pointed out the essential steps. You do need some kind of specimen orientation. Some people prefer color coding, inking, mounting. A visit to a pathologist, like you mentioned, has to be an essential prerequisite. I think all of us do it in our practices. We've already talked about the distance as well as the quality of the tissue forming the margin, which is important. So the next anatomical layer is something we typically strive at, not always feasible, given the complex nature of the anatomy of that particular subsite. And at our institution, we follow a specimen-directed and a patient-directed approach. So we'll not only send, because since we don't have enough evidence on margins, we'll typically ask for the specimen to be assessed, and we'll also take representative sections from the patient's bed just to make sure that we do that. So this philosophy probably drives all of us. There are meta-analysis now done on it, on only transoral surgery for oropharynx. Talking about recommendations, there is conflicting data again on margins. Like Professor Jones pointed out, we have not defined the uncertain or the close margin yet. There are a couple of studies, as pointed out over here, where they believe that revision specimen neoplasia is more predictive. And we'll probably discuss that when we get to TLM. Professor Piazza has already talked about the second look microlaryngoscopy. But again, this is a different animal altogether. But even in oropharynx, we have that data. And there is also another paper which says that compared to TLM, you get more positive margins. And that again is comparing apples and oranges, in my opinion. So to clear the air, there are now recommendations for transoral resection for pharyngeal cancer. And this is slightly older, but still holds true. The use of frozen section based on these consensus recommendations was recommended till circumferential negative margins are achieved. Margins are either reported as clear or involved. So based on these recommendations, there was no definition of a close margin per se. The question, of course, that remains is the distance forming that margin is the question. Should HPV positive be different compared to HPV negative, as most of us think, or whether it should be something different? And the so-called close margin does not influence the risk status or the subsequent treatment. And this kind of takes us back to one of the first slides where we talked about margins not impacting the survival of early oropharyngeal cancer. That being said, we already know on a couple of meta-analysis that as we go higher in stage, T3 and T4, for those of you who resected, it has an impact on local control. And we know that local control will have an impact on survival. So surrogately speaking, we do know that margins are important enough to that extent for us to be able to consider some kind of standardized philosophy of our institutions in that. This is a list of studies looking at margins, and there's variability in margin positive rates, the definition of a closed margin, and in margin philosophy. Any comments from any of the panelists about transoral approaches? We're not just talking robotic here, we're talking all transoral approaches and their margin philosophy and how we should approach a particular case before we wind up this particular topic of the State of Science Symposium.
May I ask a question?
Absolutely, absolutely.
So it means that margin. So as your presentations, close margin does not mean anything in oral cancer, right?
In oropharyngeal cancer, again, we're talking mostly HPV positive right now because we haven't found the definition of a closed margin there.
Okay, so it means involved or clear is the most important thing.
Yes, so positivity or negativity, yes. But you know, this is probably a good point to discuss what we think is a margin philosophy. Again, by no means is it supposed to be all encompassing. In a literature deplete or a literature conflicting setting, this is what our philosophy is. And again, I'd like comments because this is the last slide of this particular topic that we'll be discussing. So the dogma of the 5mm microscopic margin may not be applicable to HPV associated, especially early oropharyngeal cancer, because that's where we have the most literature from. Like we just talked about, a negative margin is a clear margin and should be treated as such. For HPV negative disease, because we don't have much literature to go by, The evidence is unclear and treatment should be per guidelines, which is to mean, as Professor Jones and Professor Piazza pointed out in the last few minutes, we would typically consider 5 millimeter microscopic as a clear margin for HPV negative disease. It goes without saying, I think most of us are doing it now. HPV testing has to be done. It's been incorporated in staging. We know that there are prognostic implications of HPV positivity. So we have to always make sure that we test our patients via a surrogate marker. And P16 is a great test, readily available in our country as well as around the world. There's no prospective randomized data upcoming for margin positive and T4 disease, including the randomized phase 3 trials that we're looking so forward to. So I think that we'll all need to follow a philosophy and hopefully generate more literature, which helps us clear this line. And of course, we talked about preventing the margin, and utilizing the parameters that we've discussed amongst each other is probably key to not only avoiding unanticipated multimodal therapy, but also unanticipated morbidity. Every millimeter of the tongue base will have functional consequences that you resect. So we need to make sure that when we talk about margins, what is appropriate, what is not excessive, will probably be guided by future literature. Would that be a summation? Would someone want to add something to this? And this is just with reference to transoral approaches for oropharyngeal cancer.
Yes, I would like to, sorry.
Yeah, go ahead, please. Professor Jones.
I would like to ask to the Professor Terry Jones and Piazza, and is this slide can follow from your experience data? Do you agree with it?
Professor Jones.
So the bits I do agree and bits I don't agree, because of the retrospective data that we've actually got. It shows, particularly in HPV positive disease, that having margins less than 1 millimeter, whether you define, well, however you define those, appears to be safe in terms of outcome. If you take our significantly sized study, as I said, 2/3 of those had margins less than 1 millimeter, and the outcomes were as good as anything else you find. Except in my bias, and I do have a bias in this, of in fact a conflict of interest, we won't have the answer to any of these questions until some of the trials, and particularly the Pathos trial reports, because it addresses this issue exactly. It takes it head on. It makes no intellectual argument about the veracity of margins. It says margins are margins, and we need to look at this with enough patients in a randomized controlled clinical trial to determine whether they're safe or not. And that trial will hopefully report in 2027, so still a long way to go yet. But it's only by doing those sorts of studies will we get the answer to any of these questions.
Absolutely. And we also look forward to the ADEPT, because that includes the non-robotic approaches, all transoral approaches. But again, we know of your great work in this. So all of us look forward to some more clarity of air in terms of knowing about margin status in oropharyngeal cancer.
Shamit, one question to all the panelists.
Yes.
If HPV positive disease, if your margin is less than 2 millimeter, would you recommend radiation, any adjuvant therapy in these kind of cases or not? Because most of the studies have mentioned 2 to 3 millimeter margin as a clear margin, and less than 2 millimeter is a closed margin. So for those patients, what will be the recommendation for adjuvant treatment?
Dr. Deepa, can I request you for your comments before we hear from our international faculty?
So at IMDT, I think we'll look back not just at that single margin report. We look at the patient holistically. What was the T size? What is the nodal status? Are there any other adverse risk factors? And it's really going to be a discussion. If the 3 millimeter margin is the only point of contention, it's going to be a discussion with the patient, and about also we will have a discussion. So a 3 millimeter margin in absence of all other features may be kept under observation, subject to the fact that the patient will be suitable for follow-up, reliable for follow-up, and the surgeon knows that during the surgery we had under magnification a good margin. So, but obviously this 3 millimeter margin in a HPV positive patient is going to be taken in the context of all other pathological factors. With regards to HPV negative margins, we still would use 5 millimeters as our definition of free margins, even for TOS patients as of now.
Shamit,
Of course.
Sorry, if I make further comments on the slide we are looking at this moment, you rightly mentioned that there are no prospective randomized data coming for margin positive and T4 disease, and I would also add that hopefully will never be, at least for transoral surgery. T4 or oropharyngeal cancer, in my mind, is definitely as a wrong indication for a minimally invasive approach. There are many reasons for this, apart from the technical feasibility, which is nothing. I mean, you can do several things that are not correct or not to be recommended to your patient. The technical limit is not, in my view, never a good reason to say yes or no. The problem is that you always have to add at least chemoradiation to a transoral approach for a T4 disease and neck dissection and perhaps also reconstruction. So I don't see the position or the need for a transoral approach for a T4 disease of the oropharynx. This is in my end is still an indication for open surgery if you want to do surgery or something else.
And we know that with evolving data on survival outcomes from HPV-associated disease, that you'll typically have great outcomes with chemoradiation. So points very well taken. I think we can close this particular issue by talking about what the recent comments that have been made about considering a patient not in isolation or a positive margin, not in isolation, but a philosophy of an interplay of factors and making decisions thereby. As Professor Jones pointed out, we have data upcoming, very strong data, hopefully, which should help us pave the way. That being said, currently what we talked about, or a margin philosophy that each of us advocate across the world, would probably help us tailor the treatment specifically and expertly with respect to the functional compromise or the functional outcomes that Professor Piazza pointed out. Subjecting a patient to trimodality therapy for T4 disease is probably not ideal in every setting. But that being said, there would be certain subsets, and we need to know more about them to be, especially for HPV-associated disease, to be able to move forward. Okay. So thanks for this. And again, on this particular topic, if Mr. Jose or anyone else wants to probably add something that's already not been covered, kindly go ahead. Otherwise, we move ahead to the next talk. Okay, great. So the second thing that we thought was we rarely discuss, and again, this is in light of all the great work on TLM that we've seen, is a lesion mandating a bilateral glottic resection. And when we talk about bilateral glottic, I'm going to set the stage by mentioning one of Dr. Piazza's papers about anterior commissure involvement potentially having a prognostic implication, and we know that we have it. Just to make the point home, just going through some papers, small series, single institutional, multi-institutional, looking at glottic cancer involving the anterior commissure, we know it has prognostic implications. And ending with a systematic review of these patients where we have some conflicting findings compared to what we think otherwise, a higher laryngeal preservation rate and otherwise. But our question or our talk largely, and again, we have an interplay of voice outcomes in addition to that. So T1B is probably a question that our expert faculty have already answered over the course of the last couple of days. Again, it has to be individualized. It has to be a philosophy that has to be based on multiple factors, patient preferences, detailed discussions. That being said, this is a moot point. Look at this paper. Any patient who's counseled for all three modalities, by that I mean a transoral laser microsurgery, open partial laryngectomy, and radiation therapy, all of them would choose laser treatment. Now, that potentially applies across the world. The implications of resource availability, commuting every day, resource constraints, cost sometimes plays a big role in that. So how do we counsel our patients for extended glottic resections in the light of this? Because we already know that they are going to have outcomes which might be comparable, and we're talking about oncological equivalence, but we're talking about voice non-equivalence. Professor Piazza, would you just give us your take on how you counsel any patient who's in your clinic for an extended glottic resection? By that I mean in which bilateral
Yes, the issue of the oncologic outcome, in my view, must be solved by a careful radiologic and endoscopic, even under general anesthesia, endoscopic evaluation. If the tumor is really a T1B, I mean, does not extend above and below the anterior commissure and the laryngeal exposure is good, I think that the oncologic outcome of T1B is very similar to that of T1A. From the oncologic point of view. From the functional point of view, usually the patient starts talking like this with a T1B glottic cancer. And my personal view is that his voice or her voice will be very similar to the tumor-bearing voice after a type 5A chordectomy. The voice will never come back normal. This is more the rule than the exception, but will never be so bad in comparison to the voice with the tumor. So if they have got a high voice professional user profile like a lawyer, singer, and so on, they usually don't come to you with the tumor in T1B stages. This is the point. Usually these patients are not lawyer and not singer and not professional user of the voice. So they are happy of living with the voice that they already have, but without the tumor. So the counseling is usually very easy. If this is not the case, then I suggest them radiation therapy for sure.
So thank you for summarizing. This is, of course, going beyond T1B. For the most part, over the next 5 or 10 minutes, we'll be talking about T2 disease or bilateral vocal fold disease, either contiguous through the anterior commissure or non-contiguous in a multifocal setting. Of course, we know, just like the word of caution that was expressed by our expert faculty in transoral approaches for oropharynx, the same extrapolates here. And again, it's a word of caution to the early practicing oncologist and to someone who's thinking of an oncology career who might be joining us right now. There are contraindications which are fairly specific and very focused in terms of knowing when to push the envelope and which ones not to. We already talked about the fact that in T1B disease, as Professor Piazza pointed out, the interplay of decision-making between voice and survival actually ends up leaning more towards voice because survival is equivalent. When we push the envelope to T2 or even in some cases T3 lesions, we know that the outcomes are fairly recent. If you look at data incorporating T2 lesions, this is just a table that I made, and you'd see the local control rates are appreciable, comparable to radiation therapy, and the laryngeal preservation rate in all of these series is more than 90%. So counseling a patient is something which becomes of paramount importance. From here on, this topic will only focus on T2 disease or bilateral disease, so to speak, like in this particular patient. Professor Jones, what's your philosophy on staging a bilateral resection if you were to choose? Let's assume the decision for doing a laser chordectomy has already been made. What's your philosophy on staging these tumors versus stenting these tumors? Just give us a brief encapsulation of your philosophy.
I'm not sure I understand your question, actually. So we're on about pre-treatment staging?
No, so we mean staging the two procedures versus doing a stent anteriorly, doing both.
Okay, understand. Sorry, my mistake.
No.
So I've never done stenting. We've always done a bilateral, staging approach in the context of this. Whether that's right or whether that's wrong, that's simply our experience and what we've actually done locally in our unit.
Can I just have a word from either Dr. Deepa or Dr. Rajiv about the subcontinental perspective? What's your institutional philosophy?
I never stent these. Basically, these kind of lesion I don't resect because I know voice quality is going to be bad in these kind of patients. And if I counsel these patients, and if you tell these patients that your voice quality will be bad if you compare with radiation, then patient will choose radiation. Long term, if you say laryngeal preservation rate in long term, that obviously that the studies have shown that will be better with laser. But all these are retrospective studies, so I don't know what to choose. I generally send for radiation.
Professor Piazza, in a country like ours, as you're well aware, there are three other factors that influence treatment decision making for these tumors. There are cost constraints, there is the commute time to the nearest radiation oncology facility, and compliance rates are also modest. Your philosophy on this?
Well, I think that from this point of view, Italy is not very different from India. These problems are the most evident one in treating this kind of diseases by radiation instead of by laser. Laser surgery is one-day surgery, is very short. The outcome are equal, if not better, and the long-term survival are equal, if not better, and the laryngeal preservation rate also. The voice may be a problem, but again, in my experience, the voice is the last problem of these patients, usually already retired. Usually, they like just to read stories to their nephew. This is the main functional outcome they have, or functional request they have. And all the problem you already mentioned, the commuting, the cost for the hospital, for the society, are other, and geographic distance, because most of my patient does not come from my region, but come from 600 kilometers from my region. So these are all problems that you have to take into account.
But would you put a keel in there in case you're planning a bilateral with non-contiguous disease?
I've done stenting in the past years, but I'm agree with Professor Terry Jones. They are not a good solution because the synechia will come back again. There are someone who proposed the suturing of a mucosal flap to reduce the. But again, my only chance to reduce this synechia is the staging the procedure. When I can do it, because I feel it's a very important thing for the patient, I do it. It happens in less than, I would say, 15-20% of my T1B glottic lesion. But sometimes I do that.
Sure. So thanks. I think the jury is pretty clear on this. You would typically stage these resections if at all you plan them. So like Dr. Rajiv pointed out, you do a careful discussion with the patient and see what their anticipations are, what their anticipated compliance is, what are the other factors that are influencing the decision making. Even though the Indian subcontinent is much better than it was 10 years back in terms of resource availability, especially with regard to radiation therapy as well as lasers, I think we are still facing a large subset of patients whose commute times are more, who have issues with regard to traveling. So in those cases, even if you have to proceed with a bilateral glottic resection, you typically end up doing staging as opposed to stenting. There's some
if I can add something to the previous slide.
Yes.
The previous slide, in my opinion, this would be a one-stage procedure always, because the anterior commissure is involved. But when I mean the T1B glottic cancer, I consider the bilateral glottic lesion. In that case, I cut through and I do it like this, for example, in a staged way. But if there is just a marginal extension through the midline, then I always resect it in one piece.
So for
I agree.
Great. Okay.
Shamit, if I may interrupt here, it's been fascinating.
Yes, sir.
But it's time to conclude. It's getting onto the general body meeting.
So I think Professor Thakur
also give enough time for that too.
So are you giving me the last couple of minutes, Professor Thakur? I can then ask Professor Tai a question and then we'll come back. Okay. Hope so. He said yes, so we'll just go ahead with that. There were some questions, of course, that need to be addressed, but there's always time that is short. T2B disease, we think, is a different ball game altogether. There are some indicators that can help predict response, which we hope we'll be able to assess when we talked about radiation. But again, second look, we got a good idea of philosophy from Professor Piazza. And just one question for Professor Tai before we wind up. We had a great talk from you on transoral thyroidectomy. We've heard you talk about transaxillary as well in the past. What do you use? Are there any objective criteria of selection that your institution follows, or that you know others follow, other counterparts, in selecting between your approach? What candidates would you consider for a transoral approach in preference to others? And you might have already covered that, but this is what we do. The two approaches that we used, again, we are not a transvestibular or a transoral center yet, but we use these criteria for deciding between retroauricular and transaxillary approaches. Your thoughts on this, and then we'll wind up immediately.
Yeah, actually, it's very difficult to decide the appropriate surgical approach. Before that, we need to understand the advantage and disadvantage of various types of hemostatic thyroidectomy. But I think some approach has some advantage, especially for the cosmesis and the total thyroidectomy. I prefer the transoral approach. However, if you need some neck dissection, we need to add some retroauricular approach, something like that. Also, we need to discuss with patients about the various options about that.
You, Vikram, I'm just trying to straddle two computers. So.
Yeah, okay. Yeah, yes. So we need to discuss about the patient itself, the advantages, disadvantages of various approaches. It is more key point. Also, surgeon understand the recommend appropriate option for the patient. Yeah.
Thank you for the summary, and I know that Dr. Rajiv and Dr. Deepa would have liked comments, but unfortunately we are out of time. And again, thank you to each of my esteemed panelists as well as the chairpersons. Thanks most of all to the organizing committee of Fhno, and it's been great being part of it. And I know we are winding up the conference with the general body meeting. So thank you everyone, and especially for the patient listening. And I hope I was able to draw on your expertise in each of these. Thank you so much.
Thank you.
Thank you very much.
Thank you very much. Thank you.
Nice. Nice panel. Yeah.
Thank you, everyone. It's been lovely. Unfortunately, of course, it's time to say goodbye. So till next time.
Thank you very much, Dr. Thak.
Thank you, sir.
Bye-bye.
Thank you, Shamit. That was nice. That was really nice. Of course, you'd all have loved to have it going. And I'm not just saying it for the sake of saying it. It was lovely. We should continue that sometime. So for all the general body meetings on another Zoom, not quite the same Zoom, because that's a Zoom that is open only to members. It was posted out a couple of days ago by Vikram, and I have put it up again on the chat box here. So you can see the Zoom link on the chat box here. So I request.
The Zoom link had come through the mail, but I'm not able to get into it through that.
So it's also on the chat box here. I sent it down on the chat box.
Okay.
And if you can copy that or click from there, I don't know how, but do come and join the Zoom for the general body.
Yeah. Congratulations, Amit. It was wonderful.
It was, yes.
Yeah. Really good. Okay, see you in general body, everyone. Yeah.
you.